I'm going to introduce a video. We lost a board member this year, a long-term board member who was so important to everything that we were doing, and we want to share that with you right now.
He was diagnosed in 2006, and immediately he learned what a devastating disease it was, and he always was a fighter and someone who just wouldn't take the pat answer, the statistical answer that the docs use. And he worked relentlessly to find other solutions other than the standard therapies.
We met in Mayo Clinic in Rochester, and he was so kind to me. He came and sat by me during dinner and asked me if there was something that he could do to help. He had a lot of nonprofit board governance experience, and we didn't have any experience on the board like that. And so I got a little bit teary.
His main mantra, I guess, on the board was, we need to make sure this organization, the Cholangiocarcinoma Foundation, is prepared to be bigger. It's going to be an incredible effort to try and conquer this disease. And in order for us to be successful, we have to think about how is this organization going to function when it's 5 times bigger, 10 times bigger.
He spoke many times of the wonderful colleagues that he had on the board, and really enjoyed working with them in helping shape the CCF to be a better, stronger organization, looking out for a future which will actually bring a new era for cholangiocarcinoma.
He was, in a lot of ways, he was the glue. He was just, great visionary, but also great, kind and empathetic sort of wise sage, of the organization. So, of course, he's going to be tremendously missed.
Bruce's impact on the board will be felt for years. It was a very deep loss for us, and we just loved him, and he was such a big part of the foundation, being able to grow into this position that we're in now.
Thank you. We'll just turn the time over to the chairs.
Good morning. We are excited for another day of, for me, great learning and a lot of presentation of exciting research that's going on. So we're starting off with 2 more fellow presentations. And I'd like to invite Dr. Michael Litsky to the stage to give our first one today. Dr. Litsky is an assistant professor of surgery within the Division of Surgical Oncology at Duke University. And his practice focuses on the surgical management of cancerous conditions of the liver, biliary tree, and pancreas. Dr. Litsky also leads the hepatic artery infusion team at Duke, a rapidly growing program to deliver high-dose chemotherapy directly to the liver for patients with advanced primary and secondary liver cancers, including metastases from colorectal cancer and unresectable intrahepatic cholangiocarcinoma. And he's going to speak to us on improving therapeutic efficacy and durability in FGFR2 fusion cholangiocarcinoma.
Thank you so much, Laura, for the kind introduction. While they're loading my slides, I just wanted to express my sincere gratitude for being included in the conference this year. This is a truly incredible event. I've been really enjoying the time, of course, getting to see old friends and colleagues, but most importantly, making new friends and new colleagues and collaborators. And I think the most amazing part of this few days has been interacting and interfacing with patients and caregivers and advocates. So Stacy, I know you just mentioned you're looking for feedback to make this conference better. It's hard to imagine how you will do that. So thank you. I don't have any disclosures. I do want to begin with a brief mention of gratitude for receiving the Margaret M. Brown Memorial Research Fellowship Award. Margaret immigrated from Scotland to Canada in the 1950s with her husband, Jim. And she had many hobbies, including gardening, baking, golfing, and traveling. But she was also a firm believer in volunteering and instilled in her family how important it was to give back and to work hard. Margaret was stolen by cholangiocarcinoma in 2011 in her 80th year after a strong, dignified, and courageous battle. And this award is in her honor. It's sponsored by Jan, her daughter, and Jan's husband, Dean Meyer, who I had the pleasure of meeting and getting to know last night. As you know, Dean is on the board of the Cholangiocarcinoma Foundation and is here, I think, somewhere in the room today. As you may know, Jan, too, was diagnosed with intrahepatic cholangiocarcinoma in 2018, but is disease-free after surgery and chemotherapy. And Jan and Dean raise money for cholangiocarcinoma research through the annual Quack Out Cholangio 5K, which takes place next month, May 20th. If you scan the QR code on the right, it doesn't get any easier. You can learn more about how to participate, how to donate, and how to get involved, maybe even run. I'd like to thank the Cholangiocarcinoma Foundation and, of course, Jan and Dean for the honor of receiving the Margaret M. Brown Memorial Research Fellowship Award. So over the next 7 to 8 minutes, I'll briefly review the background data that drove the direction of our research, and I will then show you a novel patient-derived model of FGFR2 fusion-positive intrahepatic cholangiocarcinoma that we developed to investigate FGFR signaling and then potentially identified a new treatment strategy. So as you know, 70 to 80% of patients with advanced biliary tract cancers are not surgical candidates and are left with systemic therapy as their primary and often only modality of treatment. And even with the most recent standard of care regimen of gemcitabine, cisplatin, and durvalumab, survival remains somewhat limited for the majority of patients. Specific to intrahepatic cholangiocarcinoma, this is a single-arm study with pemigatinib, which, as you know, is the first inhibitor to receive FDA approval for intrahepatic cholangiocarcinoma. And in this study, they showed a progression-free survival of 7 months and a median survival that's under 2 years. So given the limitations of the available therapies in this space, we leveraged my unique access to patient tissue as a surgeon and derived a novel model system of FGFR fusion-positive intrahepatic cholangiocarcinoma, and I'll now share with you some of our data. So a patient with unresectable disease who was in the operating room for a pump had given us permission to use his tumor, and that tumor was used to create a xenograft, which is then used to make cell lines and organoids, as you can see on the top of this panel. And then both of those models were reimplanted into mice, which reestablished tumors consistent with that of the patient. To ensure fidelity of our models, we first did immunohistochemistry for both positive and negative markers of intrahepatic cholangiocarcinoma. And you can see on the left side, the xenograft, the organoid, and the cell line were all consistent with that of the patient's tumor. We also performed next-generation sequencing of these models and confirmed retention of an FGFR2 G3BP2 fusion. Now, we first investigated the biological relevance of these models, first looking at FGFR signaling. And in the top Western blots in the cell line and the organoid, when you deprive them of the growth factors and remove serum from their culture conditions, you can see that in the second column of each of those blots, where it says starve, the FGFR fusion is constitutively active, which is indicated by persistence of a band there. And on the bottom blots, when you use pemigatinib as an inhibitor, you can see that FGFR signaling is blocked. So we went on to look at the clinical relevance of these models and first treated the cell line and the organoid with pemigatinib on the left in A, which is the cell line, and D, which is the organoid. You can see that the IC50 for each of these models is in the low nanomolar range, and further, this response is dose dependent. In panel B, you can see that with increasing dose, you get an increasing loss of viability, and we confirm this with the clonogenic assays shown in C. In the first column, which is the Duke cholangio model, DUC18828, you can see with increasing dose, you get impairment in viability that's dose dependent. But in two wild-type lines, SSP25 and RBE, there's no loss of viability despite the highest doses. Importantly, we also showed efficacy of the inhibitor in vivo, and that's shown in panel E. Mice that were given pemigatinib, represented by the red line, have an impairment in their tumor growth, which translated into a survival advantage and improvement of 70%, shown in the curve to the right. So additional work looked at the effect of combining gemcitabine and pemigatinib. We first tested gemcitabine alone, and on the left in the cell line and organoid, you can see gemcitabine alone has an IC50 in the low nanomolar range. And on the right, those are synergy array plots, and these can be interpreted as data rises above the zero plane. That's indicative of synergy. Below the plane is antagonistic, and within the plane is considered additive. And I think these plots pretty clearly show that the addition of gemcitabine to pemigatinib is just additive. So in search for a combination that had the potential to augment response to FGFR inhibition, we performed a high-throughput small molecule screen with over 2,100 compounds in the presence and absence of pemigatinib. And on the left in the rank order plot, the further down the y-axis corresponds to increasing synergy. And then we went on to prioritize the drugs on the table on the right side for further validation. So specifically, we found that quisinistat, which is a pan-HDAC inhibitor, in combination with pemigatinib, is synergistic in the cell line and the organoid. You can see these plots look quite a bit different than the plots I showed you for gemcitabine, and here the data rise well above that zero plane. We went on to confirm these findings and perhaps the biology behind HDAC and FGFR inhibition here with a different pan-HDAC inhibitor, panobinostat, and when you combine that drug with pemigatinib, again, you see significant synergy here in our patient-derived cholangiocarcinoma model. But most importantly, we confirmed synergy in vivo. So tumor-bearing mice were randomized to control versus monotherapy versus combination therapy. And in mice who were given pemigatinib and quisinistat, which is represented by the green line at the bottom of that tumor growth curve, you can see that there's a statistically significant difference between either of the monotherapies and, of course, the control in a way that is more than additive of either monotherapy. You can see the relative reduction in tumor volume on the right is far greater than pemigatinib plus quisinistat. So we made an attempt to dig into the biology a little bit here and perform flow cytometry under the same treatment conditions. On the left, you can see that in the cell line on top and the organoid at the bottom, there's synergistic impairment and proliferation with the combination therapy. And then on the right, with annexin staining, the combination strategy also augments apoptosis with increased early and late apoptotic fractions. Mechanistically, I think the interplay between HDAC and FGFR signaling is not quite well understood. And in these Western blots on the right, these are some of the compensatory pathways that may change when FGFR signaling is altered. And what you see is that with monotherapy or combination therapy, these aren't altered at all. On the left, if you look at the second column, which is pemigatinib alone, you can see that pemigatinib impairs FGFR signaling, which is consistent with what we had previously shown. Interestingly, though, quisinostat increases FGFR signaling, which was an interesting finding, and that increase is then blocked or impaired with combination therapy shown in the fourth column. And these data led us to hypothesize that HDAC inhibition shifts these models toward an FGFR-dependent state, which can then be more effectively blocked with FGFR inhibition. So in summary, we leveraged patient-derived models to generate novel FGFR fusion-positive intrahepatic cholangiocarcinoma cell line organoid and xenografts that are both biologically and clinically relevant. We use these models to identify HDAC and FGFR co-inhibition to be synergistic, and I do think these data justify an early phase trial to investigate not just the clinical relevance, but also the tolerability of this combination therapy in patients. So we published these data late last year in MPJ Precision Oncology, and I'd like to conclude just by thanking once again the Cholangiocarcinoma Foundation and Jan and Dean Meyer for the honor of this award. Thank you.
Thank you, Michael. And we will just now move to the second fellow, Evan O'Loughlin, who is currently a postdoctoral fellow at the Massachusetts General Hospital after he achieved his PhD in Harvard Medical School. And he will give a talk about improving FGFR-driven biliary tumorigenesis and therapeutic response in 3D models.
All right. Thank you for that. Thanks for the introduction. I'm Evan O'Loughlin, and I'm a postdoctoral fellow in Andy McClatchy's lab at Harvard and Mass General. And I'm really grateful for the opportunity to talk to you all today about my research on using 3D models to study FGFR-driven biliary tumorigenesis. I have no disclosures. I just wanted to start off by reminding everyone that our body is made up of numerous epithelial tubes, and these tubes can give rise to a number of different forms of cancer. And importantly, the breakdown of epithelial architecture is one of the first signs of tumor onset. And a tube that we're all interested in, of course, are the bile ducts. Here's just a diagram of the liver, and as we all know, the liver is comprised of two epithelial cell types, the bile ducts as well as the hepatocytes, and these derive from a common progenitor called the hepatoblast. And there's two major forms of liver cancer, hepatocellular carcinoma and cholangiocarcinoma, and traditionally it was thought that hepatocellular carcinoma arises from the hepatocytes, whereas cholangiocarcinoma arises from the bile ducts. But recently it's become appreciated that there's actually substantial plasticity within the liver under situations of liver injury, so including liver regeneration, disease, as well as cancer. Again, I'm interested in intrahepatic cholangiocarcinoma, like all of you. And I think one thing that's really interesting about it is that when you look at these tumors histopathologically, you can see that they have this sort of, many of them have this sort of tubular structure to them, which suggests that there's some selective advantage that's being conferred by adopting this sort of organization. And I'm particularly interested in FGFR-driven cholangiocarcinoma. And just to remind everyone, fusions are the most common form of FGFR mutation, and the number of fusion partners have been identified. But there are also other activating mutations, such as mutations in the extracellular domain of FGFR2. In my PhD work, I was particularly interested in the development of the biliary network, in particular how you generate a tube on one side of the portal vein. And to, I guess, summarize a lot of work, I described de novo lumen formation as a central design principle that controls the development of these tubes. Just to summarize with this animation, you can see the formation and expansion of de novo lumen, and this self-organizes a structure until you get a system of ramified ducts. Moving forward, I wanted to move into a more cancer-related space. So I had this kind of question of like whether FGFR mutations that are found in cholangiocarcinoma can aberrantly hijack this process of de novo lumen formation. And to do this, I needed a specific model that enabled me to study lumen formation in 3D. So for this, I exploited a panel of cell lines that were derived by a previous postdoctoral fellow in the lab. So these are embryonic liver cells from a mouse. And these cell lines displayed a whole array of behaviors in 3D. So some cell lines like ELCA made no lumens, and some made like larger lumens, and some made these tubes in 3D. And so I like the system for a number of reasons. I think it has a number of great advantages. One is that it's manipulable with genetic and pharmacological tools. We can culture these cells mosaically to study what factors are autonomously or non-autonomously required for lumen formation. And I adopted the system for quantitative imaging, which I'll get to in a moment. In collaboration with a postdoctoral fellow in the lab, UN, we profiled these cell lines in terms of their expression of well-known biliary fate markers. And through this, we were able to define that the ELCA lines that don't make lumens are more representative of an immature hepatoblast state, whereas the ELCC lines, for example, are more representative of mature biliary cells. And for the remainder of my talk, I'll just focus on this ELCB line. And in collaboration with Shannon Stott's group, we established a quantitative pipeline for studying these. As opposed to a confocal image where you can only quantify a subset of lumens, we did whole slide scans followed by an image analysis program. And this enabled us to quantify many, many lumens, many-fold more than would be otherwise available. I'm going to skip through these next few slides just in the interest of time, but they're in the program, and if anyone is interested in talking to me about it, I'd be happy to do that. So our question was what different mutated forms of FGFR do to impact lumen formation in this assay that I've developed. So here we exploited some previously published mutations in FGFR2 that are associated with cholangiocarcinoma, so an FGFR2 PHGDH fusion, and 2 mutations in the extracellular domain. And when we look at these on a blot, we can see that the wild-type FGFR2 is present as both a glycosylated species, which I'm showing with the black arrowhead, as well as a non-glycosylated species, which I'm showing with the white arrowhead. And the fusion is as well. But interestingly, the extracellular domain mutants, as has previously been noted, are strictly non-glycosylated. And when we look at the distributions of these receptors, they're actually quite different. So the fusion, unlike the wild-type receptor, associates with the cell surface extensively. So it's trapped in a cortical compartment, whereas this EIDS has also been previously noted, is trapped inside the cell. And interestingly, in these cells, only the fusion activates phospho-FRS2 and phospho-SHIP2. Next we put these different mutations into my 3D assay, and I thought the results were quite surprising. So the fusion has a very dramatic phenotype where the lumens are basically completely lost, and the junctions are very perturbed with very punctate E-cadherin. And the fusion has the extracellular domain mutant has a very different phenotype that's more modest, I would say. Where there are some lumens present and the junctions appear more normal, and this is quantified on the bottom left. And when we treat these fusion-expressing cells with an FGFR inhibitor, we can see a nice rescue of lumen formation. And this isn't the case with either an ERB inhibitor or a MEK inhibitor. So I think this is an example of a proof of concept of how we can use a system to model sensitivities of these different mutations to targeted therapies. So I think, to conclude, I think this was sort of surprising to me that different activating mutations in FGFR have very distinct impacts on lumens, and this, I think, suggests that receptors that might be expected to function similarly might not when you have a highly sensitive assay like this. And this might kind of stratify patients on those kinds of distinctions. So our working model is that in the control situation, you have very tight epithelial organization, tight FGFR signaling that's locally restricted, and this helps to enforce epithelial architecture. With an extracellular domain mutant, because it's trapped within the cell, it's signaling from an internal compartment, and this doesn't disturb epithelial architecture to the same degree. But with the fusion, because it's on the outside of the cell, this can interfere with activities at the cell cortex, and this could lead to a disruption in epithelial architecture. And some important ongoing directions that I have. First of all, we want to test various mechanistic hypotheses for why these different mutant FGFRs first localize differently within the cell and why they have such disparate effects on 3D organization. And one thing that I'm particularly interested in is that we have mounting evidence that different mutations, the context in which these different mutations arise might cause them to exert different effects on the cell. So whether a mutation arises in a cholangiocyte versus maybe more of a bipotential cell or a hepatocyte seems to affect its trafficking and signaling and gene expression. And we're in collaboration with UN, we're going through massive RNA-seq profiling of these different cell lines to identify potential downstream targetable alterations. One major thing that I'm doing right now is to use a 3D system to phenotypically stratify additional mutations in FGFR. There are a whole host of them, either alone or in combination with co-occurring mutations in cholangiocarcinoma. And I'm also using the system to model the sensitivity of these different mutations to a variety of drugs using in 3D. And with that, I'd like to thank Andy, all the members of the McClatchy Lab, as well as our collaborators, my various committees, and funding, and particularly the foundation for so generously supporting me in this research. Thank you so much.
Very cool. So now we will move on to the ever-popular case-based discussions. I'll invite our moderators, Dr. Sky Mayo and Dr. Milan Javle. Dr. Mayo is an associate professor of surgical oncology at Oregon Health Sciences University and the Knight Cancer Institute in Portland, Oregon. He's board certified in both complex general surgical oncology and in general surgery, having completed a surgical residency at Johns Hopkins and a fellowship at Memorial Sloan Kettering. His clinical practice serves patients with cancers in the liver, bile ducts, gallbladder, and pancreas. And then Dr. Javle is a professor of GI medical oncology at MD Anderson Cancer Center, Houston, Texas. Oh, sorry, yes, let's clap for Dr. Mayo. And then Dr. Javle is at MD Anderson Cancer Center, where he leads the biliary cancer program. He graduated from Grant Medical College in India and did his residency at SUNY Buffalo, an oncology fellowship at Roswell Park, where he specialized in GI cancers. And he has been at MD Anderson since 2007 and one of our leaders. Thank you.
Very exciting session this morning, hopefully to stimulate some discussion from the audience. I'd like to thank the Cholangiocarcinoma Foundation for putting this together, and I think inviting speakers from around the world to showcase novel work that's being done in this space. What we'll do is we'll go through several presentations focusing on different treatment modalities, and then we'll leave time for a panel discussion, take questions from the audience at the end. So,
yeah, just to echo what Sky mentioned, we hope this is interactive. And we really want to engage the audience here, and not just the clinicians, but patients, providers, caregivers, because a lot of the cases really deal with real-world scenarios where we could use your help in questioning these investigators.
We'd like to first welcome, I think that next slide, if we could, is Dr. Bas Groot-Koorkamp from Erasmus Medical Center in the Netherlands, who is a surgical oncologist who I had the pleasure of training with when I was at Memorial many years ago. Bas has really done some novel work, both in biliary drainage and hepatic arterial infusion, and I think is a real thought leader in clinical trial design and pushing the boundaries for what's possible and what we should be considering for patients who have cholangiocarcinoma. Bas?
I'm very honored to stand here It's the first time I'm at this meeting, and I'm very impressed and honored that I can contribute to this meeting. So we've heard yesterday and today a lot of actual novel interventions from the past 2 years. I will talk about, using a patient of mine, about 2 interventions that are actually not novel. They're actually from the 90s. And I'm going to argue that we can improve patient outcomes a lot by doing things, implementing interventions that we already know that are effective. So this is a patient of mine I met 3 years ago in my clinic, a 70-year-old female who presented with painless jaundice. I'm only showing you one slide here, but if you run through this scan, it's obviously intrahepatic cholangiocarcinoma. There are 3 large liver lesions. There's no extrahepatic disease. And what you can also perceive is that there are dilated bile ducts. And so this is the first part of my presentation. I want to focus on biliary drainage. I think it's a very important topic for cholangiocarcinoma, because most patients with cholangiocarcinoma and also many patients with intrahepatic cholangiocarcinoma, like this patient, or gallbladder cancer, actually present with painless jaundice. So that's the first concern for the patient and for the doctor to resolve, because if we don't resolve the biliary obstruction, the patient is uncomfortable and we cannot give any treatment. So biliary obstruction is mostly at the distal end of the bile duct, like in pancreatic cancer or distal cholangiocarcinoma. And those obstructions are relatively easy to resolve. But a hilar biliary obstruction is much more challenging to resolve, and consequently the outcomes are very poor, as I'll show you. Just to show you the Dutch data, so we have in the Netherlands, we have universal health coverage. So everyone has access to all the treatments, but nevertheless, only about 1 in 6 patients with advanced perihilar cholangiocarcinoma who are not eligible for resection or for transplant can actually receive systemic treatment. And of course, this includes a few octogenarians and patients with a poor performance status. But I think the main reason is that these patients do not get to treatment because they never get adequate biliary drainage. And so if we really want to offer all those new treatments that we've heard about and really have an impact, we should at least start with resolving biliary drainage so we can actually treat all those patients. So I'll just briefly go through the literature on outcomes of biliary drainage. And the first question is always, should we drain endoscopically or percutaneously? And there are actually only 2 trials, and both of them, you'll notice, are very small. The first trial was here in the US, and it had trouble accruing patients. So, you know, if you have fewer patients than centers that were open, that's never a good sign. And this study included all patients with malignant hilar biliary obstruction, all stages. And just to show you one result that I think is very striking, 8 out of 13 patients passed away within 3 months. We did another study in the Netherlands in 4 centers, slightly bigger, 54 patients, and this was more a specific subset of patients, only perihilar cholangiocarcinoma, and they had to be eligible for resection. What is quite striking, and you don't see many papers showing this, is that only about half of the patients actually ended up getting a resection. Most publications on perihilar cholangiocarcinoma are about the ones that had a resection. And the median overall survival is really so poor. It looks like these patients only received systemic treatment, and that's many of them never had any treatment, so no surgery and no palliative chemotherapy or any systemic treatment. And the reason is because of the biliary drainage complications. So these were small series. Let's look at the really large series. This is a very nice paper I recently discovered from England. 16,000 patients who presented with biliary obstruction in the palliative setting and who had percutaneous drainage. And about 1/3 of them had biliary tract cancer, and the median survival was, when it's expressed in days, that's never a good sign. It was only 3 months. We did a similar study looking at ERCP in Rotterdam and Amsterdam, and those are the 2 major referral centers with, I think, best in the world endoscopists. And we selected a subgroup of patients with advanced perihilar cholangiocarcinoma who had their first biliary drainage in the Netherlands, in the tertiary center. And again, 90-day mortality was 1 in 3. And the reviewers didn't believe their results because all the gastroenterologists said this cannot be true, our results are so much better. But there's no publication in literature with better results than this. So what is the solution to this? Because clearly we need a solution. And the solution is relatively straightforward because this biliary drainage is so complicated because patients get cholangitis. And cholangitis is horrible and life-threatening. And because they get cholangitis, they need re-interventions. And so in the cohort I just showed you, patients on average had 5 endoscopic biliary endoscopic or percutaneous re-interventions. So this is what we do. We place primary percutaneous metal stents. We don't cross the ampulla. We don't leave an external drain, and we glue the puncture track. And the rationale is that if you need biliary drainage, you do not want infection. And where does the infection come from? Either from the bowel or from the skin. So if you use this approach, there's no infection, or at least less risk of infection. And this is not new. This also is not something I am doing. I'm a surgeon or interventional radiologist does it. This is something I picked up during my fellowship in Memorial. Dr. Karen Brown was doing this. But the problem is that if you get painless jaundice, you go to a gastroenterologist. And if you go to a gastroenterologist, you're getting an endoscopic stent and not a percutaneous stent. So back to our patient, this is what we did in our patients with the large central liver mass. We meaning our interventional radiologists, placed 2 kissing metal stents. They're crossing the tumor, they don't cross the ampulla, you don't need to cross the ampulla, there's no tumor there, and we don't leave an external drain. So she recovered very rapidly from the biliary obstruction, and she was actually one of the patients in our pilot. Somehow my PhD student came up with the acronym TESLA. I still haven't figured out how the study title ended up in TESLA, and this was also before Twitter got involved in the TESLA name, so apologies for that. But so this is our pilot, malignant hilobiliary obstruction patients, ineligible for resection or transplant. Important to realize 2/3 of perihilar, but it also includes about 1/3 of the patients have intrahepatic cholangiocarcinoma, gallbladder cancer, or even metastasis from colorectal liver mets, from colorectal cancer to the liver hilum. The patients were not allowed to have previous biliary drainage. And we placed 1 to 3 uncovered metal stents. And we started with a sample size of 10 patients, but we kept expanding. And the pilot is still running while we're waiting to open a randomized trial. So I'll show you some of the results. Please don't share these on Twitter because it hasn't been published yet. So in our historical cohort, 75% of patients had cholangitis. And in this study, nobody had cholangitis. 2 patients had cholecystitis, and all the mortality was unrelated to the biliary drainage. And this is just one table to show you the comparison with the historical cohort. And I think most striking is that we went from 20% receiving systemic treatment to 75%. And the reason it's not 100% because it included 2 patients on dialysis and 1 patient of 95-year-old and similar patients. So it's really an all-comer population. And I think it's most amazing that something as simple as the approach of biliary drainage has a tremendous impact on overall survival, as you can see here. So we are hoping to soon open our randomized trial to compare this approach with this current standard of care. So back to our patient, the bile ducts are drained. What are our treatment options? So this is kind of the flowchart I like. And there's a prominent place for intraarterial chemotherapy. That's one of my other pet topics. Because this patient has multifocal disease. There's no extrahepatic disease. I mean, theoretically it is resectable, but that's at an exceedingly high risk, unacceptably high risk, and probably not beneficial. So we've heard a lot about all the systemic treatments. I'm not sure this study has been shown. It's one of my favorite systemic treatment studies from Angela Lamarca again. I'm not sure whether she's still in the room. And I like it because it sets the benchmark for local regional treatment of intrahepatic cholangiocarcinoma. So this is a subgroup analysis of the ABC trials, 32 patients, unresectable liver only. One group is unresectable liver only. The other group, the other curve is metastatic disease. Interestingly, the curves are overlapping, really showing the importance of the liver disease. So basically what these curves tell you is that it doesn't really matter whether you have extrahepatic disease if you have advanced intrahepatic cholangiocarcinoma. So the number you need to memorize from this slide is the 3-year overall survival. I used to say it is 0 based on my appreciation of the Kaplan-Meier curve, but Angela has a tremendous, huge supplemental file, which actually tells you it's exactly 2.8%. So what is the rationale for intraarterial chemotherapy? Well, briefly, it's good to realize that most patients have advanced disease, and advanced disease in 50% of patients is confined to the liver. So there's liver-only disease. One of my favorite papers about intrahepatic cholangiocarcinoma is from Andy Anderson. That's the Yamashita paper in Cancer in 2017, which has an all-comer cohort, 500 patients, intrahepatic cholangiocarcinoma, and it looks at cause of death. And 70% dies from biliary obstruction or liver failure. Then there's a nice systematic review showing that embolic treatments don't do very much. And so, to me, the only effective local regional treatment is in hepatic arterial infusion chemotherapy. So why does that work? Liver tumors are predominantly perfused by the hepatic artery, and there's this amazing drug, floxuridine. It's like 5-FU, but it's also a very old drug. But what is special about it is that it's extracted by the liver during the first pass effect. So you can give a very high dose. They even say a 400-fold higher dose at the tumor cell level. So this is what it looks like, but I'm sure many of you are familiar with this. We surgically place a catheter in the side branch of the hepatic artery. This is the pump subcutaneously placed. It's a very stupid pump. It's non-programmable, constant flow rate. It's nothing fancy. So very often people say, well, there's no evidence. Well, it's true there's no RCT, but I think there are a lot of targeted treatments we heard about the past few days that we're all convinced work, which have not been investigated in a randomized controlled trial. So these are 4 phase 2 trials that investigated HYPE for intrahepatic cholangiocarcinoma. 3 of them are from Memorial Sloan Kettering Cancer Center, the first 3, and they all have very consistent response rate, median overall survival, and look at the 3-year survival. That's not 3%. This is between 30 and 40%. And we have replicated this trial, and the reason I replicated it in the Netherlands was not for scientific purposes, but the drug is not registered in the EU. So the only way to get this treatment available to my patients was to do a phase 2 trial. And so in 2 years, we included 50 patients, and I can't tell you the exact results yet, but I can tell you that they're exactly the same as the results from Memorial. So back to our patient. Our patient underwent pump chemotherapy, always combined with systemic treatment, unless they already had systemic treatment. So some patients get systemic treatment, and then when they progress, they get a pump. At the CAT scan at 3 months, she had stable disease. At 6 months, partial response. And unfortunately, after 15 months, she developed ascites with peritoneal disease. She had no targetable genomic alterations and a poor performance status by that time, and passed away after 18 months, which is not very long. Of course, it's way too short, but I think starting out with such a large central liver mass, I think usually the outcomes are way worse. I just added one slide last night, just to be a little bit provocative. We've heard a lot about second and third line treatments for advanced intrahepatic cholangiocarcinoma. And first, of course, there's the Angela Lamarca's Volvox trial. The advantage of it is that it applies to all patients, so you don't need to have a specific mutation. Median overall survival, 6 months, 3-year overall survival, 0%. Then we have the 2 targeted treatments. And you'll notice that the results still aren't that good, but the patients with FGFR rearrangements do better regardless of treatment. And so there's a promising 20 months overall survival, but again, only for the selected patient group. And then this is unpublished data that Bill Jarnigan from Memorial kindly shared with me. And we're going to add data from a few more centers, including our own trial. We looked at second-line pump chemotherapy. So these are patients, just like in the other trials, who progressed on systemic treatment, and they had pump chemotherapy. The beautiful thing of this is that all patients are eligible, regardless of your mutational profile. And the median overall survival was 30 months, and the 3-year survival, 38%. So in conclusion, ladies and gentlemen, 2 conclusion slides. One about biliary drainage. I think it's really an under-resourced research topic. I think it's the #1 challenge in probably about half of the patients who present with cholangiocarcinoma. And both endoscopic and percutaneous drainage have very poor outcomes with lots of re-interventions for cholangitis. And many of these patients spent the last few months of their life in the hospital. Primary percutaneous stenting, I think, is very promising, as I've shown you, and we'll do a randomized controlled trial. And regarding the pump, I think this disease is really perfect for intraarterial chemotherapy. It's mostly confined to the liver. Most patients will die from disease in the liver. And if you compare this with systemic treatment, 3% versus 40% 3-year survival, I think it's really beyond reasonable doubt, or I think medical oncologists would call this a signal. I think it's at least promising. And we're looking forward to present our trial, and the Memorial team, and we're participating in that, is going to do a randomized control trial. Thank you very much for your attention.
Excellent, boss. Very thought-provoking, and I think hopefully will stimulate some more discussion. I'd like to welcome Sarah White up to the podium. Can we have Dr. White's slides up, please? Dr. White is a professor of radiology and surgical oncology, and she is coming to us from the Medical College of Wisconsin. I think arrived late last night.
I did. Thank
you. Had a busy day in clinic and is going to share some cases that are going to be illustrative of the role of interventional radiology in helping manage patients with the spectrum of disease. Dr. White?
I'm getting old. I had to bring my glasses up here. I thought maybe I could see, but no, not really. So interventional radiology, they often think of us as the plumbers, right? You heard about, can you put a stent in? Yeah, then pull out, okay. We're the plumbers, but we actually do other things. But typically when we see patients, we see them in the end. When nobody else has a solution, they say, oh, can I or try something? So I always think of interventional radiology as the people that come up with creative solutions to difficult problems. So here are a couple of very difficult problems. This is a 63-year-old female who initially presented with abdominal pain and distension, which is how many patients with cholangio show up. They don't show up when you have intrahepatic cholangio with painless jaundice, they just have a bellyache. Many of my patients, my very first patient I ever treated as an attending, ate an egg sandwich, and she thought she had food poisoning. So she went to the ER, vomiting profusely, and she was found to have a central cholangio. So this woman, her CA-125 was 1,000, her CA-19-9 was 138, her LFTs were within normal limits, and she had this 18-centimeter, really central mass with peritoneal carcinomatosis at the time of diagnosis with most likely nodal metastasis. She got a biopsy just because her tumor markers were a bit odd, and it revealed that she had cholangiocarcinoma. So this is a very typical scan that we will see in IR. The central mass, it's clearly not resectable. There's no residual liver or two segments together of liver that could be resected. So just to set the stage, we've seen these slides before, but just to sort of think about these numbers, you know, the ABC02 trial, you're looking at overall survivals of 12 months. If we add in Abraxane, we're talking about 19 months. The new Topaz 1 trial, 12.8 months. So think about that in that setting. And then once we get to second line, we heard a lot about second line just a second ago. Think in that 6-month range is what we're talking about. So now we have this patient, what are we gonna do with her? We go on to first line chemotherapy, she gets Gemcis, and she has a really good response. But at about 7 months into her treatment, she starts to develop pancytopenia. She gets thrombocytopenic, her platelets are just on the floor, she's having episodes of bleeding, having to come in for constant platelet transfusions. Her job, she actually, I've never heard of this, she's the only patient I've ever had that does this, she's actually makes vitamins, and they scrape the velvet off of antlers. And this is some vitamin that she makes. So she's doing this, and she wants to have a life. She doesn't want to be sitting in the hospital getting platelet transfusions. And so she was referred to IR, is there something that you can do to help us? And so this is what her scan, we'll talk about radioembolization. So we talked about whether or not radioembolization would be an option for her. So radioembolization is where we put a small catheter into the blood vessel that supplies the tumor, theoretically the tumor only, and we inject teeny tiny little beads. Those beads carry a radioisotope Y90, which will kill things it's a beta emission. And so, but it only will travel about a centimeter, so it can't go very far. So you're not going to get the toxicity of the surrounding organs like you would from external beam radiation. But we want to put this in the context. What is her overall survival going to be? Is she second line? Is she still first line? Where is she in this? So when we look at our overall survival from diagnosis when we fold Y90 into the mix, we have a median overall survival of about 20 months, which is not bad. That's pretty good. And from the time of Y90, we have 11 months. So think what I told you to begin with. We have these patients that nobody else really, we're done. We've tried first line, second line, third line, or they can't tolerate therapy. Now what do? Again, ABC06, we're talking about a 6-month overall survival. So 11 months, this is what I quoted her. I said, we can do Y90, and this is what we anticipate your overall survival is going to be. This is what her tumor looks like. So you can see she's got hyperenhancement around the rim, but she's got some necrosis in the center. So she was having some sort of response. But again, we talked about doing Y90. This is just what an angiogram looks like. We get in there on the screen, right? You can see the spleen. And then on screen left, that is what a hypervascular tumor looks like. And so that's that area. Those beads are going to go to whatever looks dark on the screen. We got out into the right hepatic artery because the majority of her tumor was going to be on the right. It was right dominant. But you can see the majority of her liver is really supplied by that right hepatic artery. And what we try to do is we try to dose half of the liver at a time. But because of her anatomy, she had most of her blood supply coming from the right. So the way we dose this is we look at the tumor. We look at the volume of liver we're treating. And what you can see here is that her total liver volume is 24, but what I'm treating is 2,000. So I was treating a majority of her liver. Understanding, the toxicity with this is pretty good. The main toxicity or the main side effect of this is fatigue, so patients will feel very tired for about 2 weeks. But really, other than that, patients tend to tolerate the therapy pretty well. So I treated her right lobe. Her platelet count at the time of treatment was 102. Her hemoglobin had come back up, so she was no longer anemic, and she was no longer neutropenic. So she was in a pretty good place when I treated her. And this is what she looked like 2 months post Y90. So we really patted ourselves on the back. But what I didn't tell you is that there was this crazy, bizarre thing that happened to her. So she developed, again, not pancytopenia, but she developed thrombocytopenia, probably related to the Y90. She wasn't thrombocytopenic. Then she had Y90 and was. We don't understand why. But she had a beautiful result. She actually ended up in the ICU with 0 platelets. We sat with her and held her hand for an entire weekend while she had a GI bleed and transfused her. She got through that about 3 weeks later, was back out and scraping antler velvet. So this is what she looked like. She would winter in Wisconsin, and she'd winter in Arizona and summer in Wisconsin. Obviously, nobody wants to winter in Wisconsin, including me, but okay. And she was pretty horrified by this whole experience, so she decided that she did not want to undergo radioembolization of the left hepatic lobe. So she was maintained on capecitabine, and then she developed disease progression, and she had worsening progression. This is 1 year post-Y90. You can see over time that right hepatic lobe lesion just has shriveled up, and that's what often we see with Y90. And you can see that left lobe disease has progressed. And she succumbed to her cancer 2.5 years. As we talked about in the last lecture, 70% of patients die from liver failure, and she succumbed 19 months after Y90, 2.5 years after the initial presentation. So this just says, if you can't tolerate systemic therapy, is there another option? There certainly is, if we can get there. I show this case because this is a case of a more diffuse and broad tumor. Here's another patient. This is a 76-year-old male. Again, initially presented with abdominal pain, and he was diagnosed with diverticulitis. Okay, again, not presenting with what we would think to be a cancer. And again, oops, there's something in your liver. His CA19-9 was 25.5 at diagnosis. His liver function was totally normal. He was an ECOG of 1, so his performance status was good. He had a 12-centimeter mass, which is really centered in the posterior aspect of the liver, which is good for me, not for him, but for me. And again, had a biopsy that showed cholangiocarcinoma. So this is what we're talking about. It's sitting, that cancer is sitting way in the back part of the liver. And so the question is, when do we fold in Y90? So this is a guy that has new onset. He's got disease posterior lobe. Should we go on to resection? Shouldn't we go on to resection? It's a pretty big tumor. And so this is just some data from the MISPEC trial. This was a phase 2 prospective open label trial, multi-center, run out of France, that looked at combining Y90 with systemic therapy. Should we be doing this earlier? Should we not give me patients in the salvage setting? And what does that look like? So the primary objective of this study was response rate. The secondary objectives were looking at the overall survival, what was the toxicity, and what was the disease control rate. The inclusion criteria are what you can imagine. We wanted patients that were older than 18, that had a reasonable performance status at baseline, that didn't have terrible liver function to start with, and then we didn't want them to have extra hepatic disease. We really wanted it confined to the liver just to see if this really would help. Exclusion criteria are things that you would imagine if they couldn't get the Y90 because of technical problems when we deliver the drug. This is sort of the schema of how many patients were screened versus how many patients actually were able to get it. Many patients were excluded because of extrahepatic metastasis, or their ECOG performance status wasn't very good. And then when we go on to angiogram, not everybody is a candidate just based on your hepatic arterial anatomy. If I can't get a catheter in there to deliver the Y90 safely, you're not a candidate. And so they excluded 4 patients. So 41 patients went on to get therapy. And this is just the schema of when you would get it. So you would get systemic therapy. In the middle of the systemic therapy, you'd get a Y90. You'd go back on systemic therapy, and if we had to do both lobes of the liver, you would get that at a later time after your cycle of GemCis. So what I'll highlight here is, before I tell you the responses, what's really important to me is that when I do a therapy, I don't increase your toxicity. So if I'm going to give you systemic and Y90, I just want to make sure that I'm not making you sicker in the process. And what you can see is the ABC02 trial, the toxicity rate or the adverse event rate was about 70.7%. And in the MISPEC trial, the toxicity was 71%. So 70.7 and 71, to me, that's the same. So not any additional toxicity when you fold it in Y90 in the first line. And here you can see beautiful, beautiful response rates with best response rate of 98%. When we look at secondary endpoints of overall survival and progression-free survival, we have 22-month overall survival. So if we think back to that ABC02 with 11-month overall survival, we've doubled survival by folding in Y90 with GemCis. So this, to me, really is provocative data. So in this patient, is that what we really should be thinking about? The other thing to note about this trial is 22% of patients went on to get surgical resection. And we know if we can get that tumor out of your body, you will live longer. It just makes sense, right? So 22% of patients in this trial went on to have surgical resection. So this is the patient 8 months post Y90. You can see what happens. So no longer did I have to park my catheter in the right hepatic lobe and just let it go because it was a big tumor. It was confined to the back. And so I was able to give a very high dose, even a higher dose, 100 times more than they could give external beam. And you can see total, it looks like I almost totally killed that area of the liver, and I did. This is called a radiation segmentectomy, and I did 2 segments. But the unfortunate thing that you can see is that he also has disease on the left. So would he be a surgical candidate? Theoretically, he would, but because he's got disease on the left hepatic lobe, he is not a surgical candidate and is going on to get systemic therapy, continuing on systemic therapy. But this, to me, is a very nice result in that patient. Here's another case. This is a 66-year-old male. Now we're going to talk about patients that have underlying liver disease, and what do we do with these folks? Okay, he's got hepatitis C cirrhosis. He was found to have a mass again. He was living his life and found to have this mass on screening. His AFP was normal. He's not a CA19-9 producer. His LFTs, though he's cirrhotic, were within normal limits. He had a 5-centimeter diffusely infiltrative mass. I'm going to show you the mass. It was really sort of a quandary when we saw it. We didn't know what it was, and we biopsied it. He's a veteran, which was where I was yesterday, at the Veterans Hospital, and you can see it doesn't look like a cholangiocarcinoma typically. It's just sitting in this segment 5 and really sort of scooching over to 4B, and that's where I talked about where the tumor is and can I get my catheter in there. And so sometimes we have to be a little bit tricky about how we deliver our beads, because this is not confined to one segment. So radiation segmentectomy, like I did to the last patient, it was confined to 6-7, which means that one artery went to both of those areas. This is going to be a 5 and 4B, and those arteries are typically not in the same distribution. And so what happens if we start with Y90? What do patients do if that's our first-line therapy? We just say, we're not even going to do systemic combined. This guy has single site of disease. He has no extrahepatic disease. What if I just do a Y90? What is my efficacy on this? And this study looked at that. And so in this study, 52% of patients went on to surgical resection. When we were able to do what I'm anticipating or hoping to do to a patient like this, 52% of those patients are able to go on to have surgical resection. This is what he looks like now, okay, 9 months after. So I just told you, I put my catheter and I can really get a really nice treatment area in that segment. But what about that other thing in 4B? So what I did is I did a radiation segmentectomy, so radiation to 1, and I went to that other area that just had that sliver, and I did a chemoembolization, and we'll talk about the data for that. The other thing to think about, here's just another patient example, a really big hypervascular lesion, and we did a rad-seg on him. But we have to think about, is there something I can do to get you ready for surgery? So oftentimes, we're left with patients that could be a surgical candidate, but the residual liver isn't big enough, and so is there a way for us to make that liver bigger? So if we do radiation to one part of the liver over time, and sometimes it can take up to 9 months, the residual remaining liver will grow if I do radiation to one part of the liver. So we have to think about that. Is there a way that I can grow the residual liver piece that's going to be left behind by the surgeon while also treating the tumor? And yes, we can do that, and that was a case I showed you. And here's an example of that radiation segmentectomy I did, and this patient can go on to have a surgical resection. Here's my, I think, last case. Now we're even talking about a worse patient scenario, right? This guy has a tumor. You can see he's got ascites. He clearly has cirrhosis. So what do we do with somebody like this? Again, systemic therapy is not a great option for these patients. He was a B8 ECOG 1. But again, if we do radioembolization out of the gate, his overall survival in this published subset of patients was 22 months. That's pretty good. 22 months for patients that have really poor liver function and can't go on to get systemic therapy. Again, just showing the PFS of 7.4 months if you get radioembolization. The toxicities, again, adverse events are not anything outside of what you would get with systemic therapy. And this is really his story. So he's a 70-year-old man. He's NASH. He's a B8, like I said before. He was requiring weekly paracentesis, and he had a mass that was found 7 months earlier. He was lost to follow-up. He had some issues. His creatinine was elevated. His LFTs were within normal limits. And so really, they just didn't feel like he was a good candidate. This was a mixed HCC cholangio when they did the biopsy. And again, this is what he looks like after we do that radioembolization. So he had a really nice result. He continued to need weekly paracentesis, and he eventually succumbed to his illness. I talked briefly about, is there something else we can do? This is just a patient that has a central lesion. Doing a Y90 in this area would be very difficult just because there's no real one blood supply. It's just sitting right in the middle. And so in these instances, you can do any number of liver-directed therapies. I talked about Y90, but there's also chemoembolization where you can infuse chemotherapy directly in. You can do bland embolization like they do at Memorial Sloan Kettering, or you can do drug-eluting beads with these little teeny tiny beads that carry drug. And you can see the overall survival in all of those cohorts is about 13.2 months. So when these patients come to us, we can get about a year, depending on which modality we use. It probably doesn't matter. When they come to us, what do we say portends a worse prognosis? If they have a higher ECOGs, if their performance status isn't great, if they have a major complications like my patient had, that portends a worse prognosis. And if they have progressive disease or they're not responding to my therapy, that all makes sense. So those are just the things we think about. Chemoembolization, there was a big meta-analysis, and what it showed was that chemoembolization, the median overall survival, as you can see, there was 15.5 months, good median overall survival. These are just all of the different papers showing what the response rates and survival at 1 year was 58% when you're doing chemoembolization in this cohort. Complications and grade 3 toxicities, again, a 20% rate. So this is very well tolerated, irrespective of what kind of chemo you're getting. You have a less than 1% mortality rate if you go on to get this therapy. And again, overall survival at 1 year, we're looking at, 60 to 70% in these patients. It's pretty good when you're coming in, and mainly we're seeing those patients in a salvage setting. So again, this is just what a cholangiogram or a angiogram looks like. You can see that hypervascular tumor, and that's how we're getting chemotherapy. So that bright white stuff on the image left, that's the chemo. We mix it with oil, and it gets taken up into the tumor, and then we know we have a really nice response. This patient at 6 months, you can see the tumor has shrunk. And we can do this again and again and again on like Y90. This patient had 4 chemoembolization treatments, and you can see over time we slowly chipped away at this tumor. And at 18 months, the tumor is barely visible on that screen. So in conclusion, combination therapy is safe and effective based on the phase 2 MISPEC trial. The addition of local regional therapy prolongs overall survival and PFS, but clearly we need to understand where we fit in and optimal timing of combination therapy. So thank you very much.
Thank you, Dr. White, for reminding us of 2 things. One, consider all options, including everything amazingly you guys can do in interventional radiology. And also that antlers are amazing and are the fastest growing tissue in the mammal, amongst mammals, so thanks for that. I'd like to now invite, I missed the thing, apologize, where we are. We get to the next slide, please.
Rachel.
Dr. Rachel Guest, who will be joining us. Rachel, please come up. The other slide. We need the right slide.
Good morning. It's really wonderful to be here all the way from the UK, and also really wonderful to be able to share a case study of a patient who is currently under my care and to share her journey with you.
Dr. Guest, slides up, please.
Okay,
so,
thanks.
Please,
Yeah.
Dr. Guest.
That's great. Okay, so my disclosure is that I am not a liver transplant surgeon. I'm a hepatobiliary resectional cancer surgeon, but I have trained and work in a liver transplant center, and I've developed a deep interest in the role of transplant in perihilar cholangio because I've sort of seen firsthand the morbidity and sadly mortality that comes along with resectional surgery for these patients. So my case is of a 33-year-old fit and well, healthy lady. She has a known history of ulcerative colitis. This is quiescent disease, diagnosed in 2014 when she presented with some mild rectal bleeding. It's been pretty asymptomatic on Pentasa since that time. In 2017, she was diagnosed with PSC when her general practitioner, family doctor, found some cholestatic liver function tests on some routine blood tests. This is her MRCP from that time, and you can see that radiologically she had pretty severe stricturing disease at the time of diagnosis. So she has a dominant stricture in the left hepatic ducts, but she also already at the time of diagnosis had a Hyder stricture and at least 2 strictures of the extrahepatic biliary tree. So this was a quite classical radiological picture, and that was the basis of her original diagnosis. So she saw a specialist hepatologist at that time and was entered onto a surveillance program with annual ultrasound, bloods, and colonoscopy. As I said, she's a fit and well lady. She works as an administrator. She doesn't smoke. She doesn't drink. She's got an excellent performance status. And she went away and lived her life up until January this year. At this point, she presented to my gastroenterology colleagues at a district general peripheral hospital with a 2-week history of pruritus and itch and jaundice. This was painless. She described pale stools and dark urine and denied any longer history of weight loss, anorexia, or abdominal pain. These were her bloods at the time of her admission. So her bilirubin in UK money is 86. but there was no biochemical signs of infection. And her ultrasound at the time of diagnosis showed severe intrahepatic biliary dilatation, especially in the left side of the liver. And this comment from the radiologist at the bottom of the scan saying there was a focal area of cholangitis led to her being admitted for treatment with IV antibiotics under their care. So the MRCP was repeated, and this showed some progression of her known intra- and extrahepatic stricturing disease. So particularly in the left liver, the dominant stricture had progressed, but more concerningly, there was now a severe hilar stricture of bismuth 1 type. So this is a pretty poor MRCP, but you can just about here see the proximal common hepatic duct filling with bile there, and then the whole of the extrahepatic biliary tree is pretty much missing from this scan. This is a CT scan, which didn't add a lot, but just to say that the left and right hepatic ducts were remaining in continuity. And there was no evidence of any extrahepatic disease at that time. So she was treated for 2 weeks under the gastroenterology team with IV antibiotics in the hope that this might improve her jaundice. However, it didn't. The bilirubin rose to 132 and she developed vomiting. And eventually they arranged a transfer to my center for ERCP and drainage. And I was contacted on my on-call duty week from the ERCPist who was about to put the scope down for further discussion and referral to our multidisciplinary tumor board. So we had various discussions about the best way to drain these patients. We've already heard that at the time of diagnosis, you're really setting the clock to time 0, and leaving these patients with external drains can really lead to deterioration from a nutritional point of view. And so we went on to do everything we could to drain her endoscopically with an internal drain. So we set up a procedure combined with our EUS and ERCP doctors with interventional radiology on standby under general anesthetic to further assess the tumor. And her EUS was quite useful, really, because this demonstrated quite a well-circumscribed mass, which measured less than 2 centimeters in maximal diameter, sitting at the top of the common hepatic duct, going up the left side into the liver, which was in close proximity, although not invading, the proper hepatic artery and the portal vein. So she went on to ERCP, which was, given the number of extrahepatic biliary strictures, a reasonably prolonged and challenging procedure. But after many cannulations of the cystic duct, as you can see in the video, they did manage to get a proper cholangiogram, and a 12-centimeter 10 French plastic stent was placed. So what's this patient's options for management in the UK? Well, luckily her bilirubin has fallen, her LFTs have normalized. She has seen the dietetic service and started on nutritional supplements. But as you may well know, transplantation for her is not currently an option in the UK, and she's started chemotherapy with GemCis. So in the interest of time, I'm not going to spend a long time summarizing the evidence for transplantation in the setting of PSC and hilar cholangiocarcinoma, but our group in Edinburgh, as a centre who is obviously not transplanting for cholangio, hopefully did an objective, relatively unbiased meta-analysis of the data in 2021. So we analysed studies, 20 studies encompassing 428 patients, and demonstrated good 5-year survival in patients who underwent neoadjuvant therapy with a Mayo or Mayo-like neoadjuvant protocol. So 5-year survival of the order of 65%. And that's significantly reduced if you don't undergo neoadjuvant treatment. But importantly, the rate of recurrence, your risk of recurrence, is halved if you undergo neoadjuvant therapy. These data were similarly mirrored in a benchmarking study done by Pierre-Alain Clavion and Julie Heimbeck, published last year in Annals of Surgery, where they took a benchmark cohort, so the best patients treated by the best surgeons in the most high-volume centers, so 17 centers in the US and Europe. 134 patients were analyzed, and they showed 5-year survival of the order of 60%, and compared this to a matched cohort of resectional patients who had a 5-year survival of just 40%. So I presented this case as an example of the differences in treatment that are occurring around the world. Because we don't offer this treatment for her, she's being very kindly assessed by our colleagues in St Vincent's University Hospital in Dublin in the Republic of Ireland, and I very much hope she might be considered and assessed for transplant. And if anyone is interested, I will try and update you as to her future progress and how she does. Thank you very much.
Wonderful, and I think this has really highlighted, I think, what is the importance of a multidisciplinary team evaluation at the outset for these patients. And you're seeing just some of the representatives of the team on this panel up here. And at this time, I would like to open up the floor to the audience. I think I see Dr. Roca, possibly. Yep, there he is.
Great. Well, thank you very much. This was just an outstanding session. It just kind of contributes to how multidisciplinary, the treatment of cholangiocarcinoma is. So again, I applaud the moderators, the panelists, and the program committee for putting this together. I have a question and a comment, and so and I'm just curious to hear the perspective, especially from this very distinguished international group. HAI therapy for cholangiocarcinoma. And my disclosure is I'm a surgeon. I do put these pumps in, but I think we've had some discussions at this meeting and others about the timing and the sequencing. And so, should there be a period of induction chemotherapy prior to placement of pump a priori? Should we standardize that systemic treatment? I mean, you mentioned, the ongoing international trial is using systemic GEM-OX. In the Netherlands, Bas, you're using GEM-CIS. In the advanced setting, we have a new standard with GEM-CIS-DURVA. So how do we, come together as a field and try to standardize that process? And then the second comment to Dr. Guest, again, a fantastic presentation. I just want to be disclose, and I don't know if Dr. Elias may be behind me saying the same thing, is that, EUS biopsy is going to negate transplant candidacy in the US. So she'll comment on that. Okay, great. So maybe just Bas then, or the panel as well.
Okay. Bas.
Yes, so thank you, Flavio, and it's a good point, and we don't really know what is best to start with systemic first, and actually I analyzed the memorial data. I don't think we published this, but we looked at all the patients who had pump for intrahepatic cholangio, and we made 2 groups, the ones who had it as first line combined with systemic, and the ones who had it after systemic, and the survival curves are exactly overlapping. And the rationale, I think, is that if you get it as second line, you select the better patients, right? So you have a better outcome. But if you do that first line, you may salvage a few patients. I think if you really would do it case by case, what my philosophy is that I would start with pump if you're concerned for imminent biliary obstruction. So if you have a large mass that is getting close to the liver hilum and you really want to avoid biliary obstruction, I would definitely go for liver-directed treatment, pump, or if you don't have pump, Y90, to at all costs avoid biliary obstruction.
So I want to point out for the audience that there's a minority of patients that have liver-limited disease. That consists of maybe less than 20%, maybe 15%, and these are intrahepatic cholangios that are limited to the liver and what we would call oligometastatic disease, sometimes very small areas of metastasis. So there's a small proportion of these patients. And the pump is a fabulous therapy. I don't know, honestly, how you would interface that with other therapies like Sarah mentioned, Y90, radiation therapy. Bas, would you say that this is there a selection criteria that you would use between these various choices of liver-directed therapy?
Again, so my disclosure, I don't have industry disclosures, but I am biased towards pumps. I am a pump believer. I think if you have the pump, you should do the pump. I think the main advantage is that you treat the entire liver, so you also treat the satellites, which are inevitably there. And so if you can make that choice. Also, to come back to your comment, I think regarding the percentage of patients where the disease is confined to the liver. So if you look at this ABC subgroup analysis of Angela Lamarca that I presented, it was really 50-50. So 50% was liver only of all the advanced patients, and 50% had extrahepatic disease. So I think it's quite a large group, and I think there would even be room for if you have like a small pulmonary lung mets, of which we know also from colorectal disease that they very often do not determine your short-term prognosis, and you have a large mass in the liver encroaching on your hilum. I think those patients could also still benefit from pump or Y90.
So Sarah, how would you make the decision in your practice versus Y90?
Well, I will tell you about pumps is once they fail pump, they come to us. So when they fail, we can fix that. No, I'm just kidding. But we do posts. It's just a little bit more challenging to get to the artery sometimes. So in our practice, if we can confine the Y90 to two consecutive segments like that 6-7, and I can get a really high dose, that's when we tend to do Y90, as opposed to those big central masses where it's getting Y90 into that tumor effectively and not getting off target to normal liver. That's when we'll do it. RAD-SEG obviously is new kid on the block, sort of. For cholangio, it certainly is, but if we can get a segment and just do almost a surgical ablative therapy to that, we'll go with that first instead of an HAI pump. I think HAI pump in our practice is more for those big central that Y90 is just not going to be able to effectively get the tumor without getting off target to normal hepatic parenchyma.
There is another question from the audience. Oh, yes, please. Yeah, sorry, Dr. Guest.
I just replied to Dr. Roca. So NHSBT and blood and transplant, that's the overall national body for transplantation in the UK, are considering perihilar cholangio for PSC patients as extended criteria. One of how they're implementing that is in the form of a clinical trial called the emphatic trial, which is not going to start till next year, so unfortunately not eligible for my patient. But one of the preconditions of being entered into that trial is you have to have a biopsy-proven cancer. So she's in a complete catch-22 of not having a tissue diagnosis and not being eligible for transplant. So we decided with her just facing palliative systemic therapy, let's get a biopsy and prove the point. So it'll be interesting to see whether she gets approved in Ireland.
Hi, Samara Elias from the Mayo Clinic. I want to echo what Dr. Roca said. These have been excellent presentations that are quite informative and looking at a variety of treatment options for our patients. So just a follow-up comment on the EUS guided biopsy, and then I have a question for Dr. Guest, and I have two more comments after that. So the reason either EUS guided or percutaneous biopsy of the primary tumor is a contraindication for liver transplant is when we looked at this, it was Julie Heimbach looked at it with Mike Levy, I think about 10 years ago. We were still earlier on in our experience at Mayo. The vast majority of patients, 90%, had recurrence along the needle track after transplant. And so it became a contraindication. And actually, we've incorporated it into the ASLD guidelines that a primary biopsy of the tumor, biopsy of the primary tumor is a contraindication. We rely on cytopathologic diagnosis more, so we look at FISH, biliary cytology, and biliary biopsies. And now there is evidence that droplet PCR will be quite effective, so I do see that becoming part of the armamentarium. So we have to rely on a variety of approaches, but unfortunately the outcomes with primary biopsy haven't been good. Question, on that MRCP, that extrahepatic stricture, it was really long, the whole thing looks malignant. It's extending past the cystic duct insertion. So are you thinking this is a patient who has a perihilar and a distal, because it's a PSC patient, they have field defects, and so any discussion regarding doing an en bloc Whipple with the transplant?
Yeah, so this is partly why I selected this case for discussion, because this has been, raised about in terms of assessing the inferior end of the tumor for treatment. So back to her original imaging diagnosis, she had at least 3 extrahepatic strictures, almost encompassing the whole extrahepatic bile duct. And we felt that the mass looked fairly well circumscribed on the EUS. So, and it was that the FMBs come back positive. It's actually an adenosquamous cancer that she's got poorly differentiated adenosquamous cancer, but a small one. Do we assume that the mass is the malignant thing, or do we, as you say, assume that this is infiltrating down the extrahepatic tree, and does she need a Whipple? In terms of her fitness, if you were ever going to get a patient that would be fit for a combined liver transplant and a Whipple, this lady's it. But whether that's a good idea in terms of outcomes, the data on that is pretty scanty.
Yeah, we've done. Sorry.
I'm sorry. We have a question there. You have
So
a
I was just going to
follow-up?
comment that we've done about 25 combined liver transplant and unblocked Whipples, and you're right, their outcomes are worse than all comers for that protocol, but they have improved over time, and the outcomes are still we're getting to the point where they are around 50%. And most of these patients that have PSC with a field defect, what we would do is in this scenario, if there's a mass up there, we would just try to get brushings from the distal duct separately rather than pulling down brushings from
Yes, so
the
all of those were negative.
Okay.
I think that was very useful. Thank you for your comment. And if we have time, we'll talk about transplant for intrahepatic cholangio. Please go ahead with your question.
Hi, I'm Kathy Hopkins, and I'm actually a patient with either intrahepatic cholangio versus mixed with IDH1 mutation and a weird KIT mutation. And my question is two-part. First, how do you guys decide on the size? Like mine was 10.3, goes down to 5.3, when you would implement radiation. And how do you decide, other than anatomy, if you're going to do Y90, or you're going to do SBRT, or you're going to do the pump? I mean, how do you decide which one you do with the patients, other than anatomy?
Dr. White?
Other than anatomy is hard. So there's areas of the liver that are watershed for us, and watershed means that there's blood supply coming in. So in my institution, if you had a small tumor, 5 centimeters, and it was confined to a segment, what I would think to be a segment, we would do a mapping. And if the mapping showed that I'm going to have multiple different blood supply, I'm going to have to put my catheter in multiple different areas, then that probably is not a good idea for Y90. We could certainly do a TACE. SBRT is going to depend on the location, right? So can they get it? Is it peripheral? Is it sitting next to a bile duct? What is the off-target toxicity going to be? So in our institution, that's how we would decide. And I hate to say anatomy, but it's really blood supply to that area. Can we get it? Can we safely do a radiation segmentectomy? 5 centimeter tumor, also based on location, I didn't talk about it, but ablation is theoretically an option. Now 5 centimeters pushing the limit of ablation in our capabilities, but certainly that's also a possibility depending on location.
Okay,
Thank you. I hope we're going to have some time to also discuss stenting and biliary infection, because this is a real common problem with patients. Can we go to that microphone and then Shishir?
Yeah, thank you. Juan Valle from Manchester, UK. The question is very much about stenting. I think Dr. Korkamp presented very compelling data regarding the differences between endoscopic and percutaneous stenting. My question is, do you think this was due to just case selection, and do you really think there's equipoise for a randomized study? I appreciate the need to do a randomized study, and I'm a great believer in randomized studies. But how do you anticipate the challenges of getting patients to consent to such a clinical trial?
So glad you discussed that one, because I want to remind the audience that patients with perihyalocholangio infection and sepsis is really a common cause of morbidity and mortality. And I don't know, Bas, there's clarity in this regard about whether, in which case you would do biliary stenting through a ERCP, through PTC. How do you make that decisions? How do you deal with recurrent cholangitis? Could you give us some idea of what is done at your institution?
If anyone can do it, the Dutch can do it.
Well, so 2 things. First of all, for the sake of time, I couldn't go into the details, but the outcomes of ERCP and conventional PTCD, meaning internal, external percutaneous biliary drainage, are equally poor in the Netherlands and everywhere across the world. They're equally poor. So what we do differently is do not cross the ampulla and don't leave an external drain. So it's very different. When we had done 10 patients, I already had no more equipoise. It was that obvious. And so I decided we're not going to do an RCT. But I talked about this with many people, and I think the challenge here really is that these patients, they go to an endoscopist when they get painless jaundice, right? And when you get painless jaundice, mainly only 10% is a perihilar obstruction. And I think very often these are misjudged initially. So I think in order to have an impact on the rest of the world, to sell this to the rest of the world, we need to do an RCT. There are some other issues, like in our center, this has been a single operator intervention for the first 50 patients. We did really take in all comers, including, like I said, a 95-year-old and 2 patients on dialysis. And I think the accrual rate was 100% of all eligible patients. But we're going to do, so this also was single center. So there are some actual reasons that you could consider there's some bias here. And, but I think the only way to convince all the endoscopists in the world would be to do an RCT.
And I think, you know, this really highlights the fact for biliary tract cancers that have such a nuanced management that what happens at the outset really matters. And this is why it's important for our patient advocates to really spread the word about you need to have an evaluation by a team that has experience doing this. Because you don't want, you know, quote, bridges burned at the outset. You don't want to be ineligible for a transplant because of something that was done if you're a good candidate. You know, in our institution, Y90 up front precludes you from being considered for HAI because of increased risk of biliary toxicity. So what happens at the outset matters. So I think we have time for one more question from Dr. Mattel.
Sorry, not a question, just a comment. Again, wonderful presentations. And I think this concept of control of the liver, you know, whether it be liver-only disease or, as Dr. Javale was saying, you know, maybe small volume, extrahepatic disease, I think there is some value in control of the liver, as we've seen. And, you know, we're often in these situations where it's case by case, and this is what we do at our institution, this is what we do at our institution. I congratulate BAS in true Dutch fashion, randomized controlled trials. They have an amazing ability to conduct and accrue and complete these trials. But I think here in this country, we've struggled with that, and we need to really focus on liver-directed therapy in combination with systemic for the right population and start thinking outside the box, whether it's HAI, Y90, SBRT, because we have a precedence of other trials that have failed to accrue in the HCC space and cholangio space. So we really need to start working together as a NCI community to be able to run these trials and potentially global collaboration with the Dutch group and other places that actually have shown they can do this and get this done. Just a general comment. Otherwise, we're continuously doing panels with wonderful cases that still people, it's not a general field change, it's case by case by case. So we need to study this philosophy, I think.
So thank you, Shishir. We're out of time, and I just want to make a final comment is that this session has demonstrated very well that the treatment of these cancers is multidisciplinary. And so I want to thank Sarah, Rachel, and Bas for their contributions to this session. And I hope that some of the questions that were asked and will be answered down the road with appropriate clinical trials. So we are all here, and we hope to interact with you further. Thank you very much for joining us.
Thank you.
Before you go out, we have just one quick thing that we need to do, and then we'll take our break. If you could start the video, please.
I first met Patty as she was a spouse of my patient. Her husband had been diagnosed with advanced cholangiocarcinoma. What impressed me about her was her level of organization. Through the 2-year course of her husband's journey, she had a mastery over his schedule, when her stents would be changed, what medications he was on, when the next lab would be drawn, when he would see the pain clinic. Really, it made our job so much easier. And I asked Patty if she would be interested in working with the Cholangio Foundation on the Cholangio Connect program.
Patty is involved so deeply in the Cholangiocarcinoma Foundation. She's a board member. She took an idea and turned it into a thriving program.
Patty's commitment to the Cholangio Connect program has fundamentally impacted countless people, from patients to caregivers, and volunteers alike, to fundamentally change the way that those of us who have been affected by cholangiocarcinoma navigate this uncertain world.
Many of us want to give back. We've been so blessed. Is there a way for us to give back? So I called Patty and I said, I want to give back. How do I do that? It wasn't a week after I finished the training that she called me and said, okay, you ready for your first mentee? And I'm like, okay, I'm ready. And it was a couple weeks after that, she goes, do you think you can handle another one? And I'm like, absolutely.
It's wonderful that we have this incredible close community. And that is largely thanks to Patty and her tireless work, matching mentees and mentors and the work she does on the board for the Cholangio Foundation.
There were times when she would get 30 or 40 referrals in a day. I believe she has helped close to 900 or 1,000 patients.
To say that Patty has had an impact on my life is an understatement. She came into my life when I really needed someone like her. She has dedicated her whole life to cholangiocarcinoma and the Cholangiocarcinoma Foundation.
She is such a great example of making the world a more beautiful place, having come through a tragedy with her husband, Mike. We're so grateful for Patty. We're so grateful for everything that she has done. She has made all of our lives better, and her legacy will continue on for a long, long time.
Patty, could you join me, please? So, thank you so much. I think the hallmark of being an amazing volunteer is when the organization that you volunteer with has to hire a full-time person to take your place. Patty has, with absolute love and dedication, helped others to mentor. So today she is receiving this certificate. It's signed by President Biden. It's with the President's Lifetime Achievement Award for a lifelong commitment to building a stronger nation through volunteer service. So it is the Lifetime Presidential Achievement Award. And then she is also receiving this beautiful piece of artwork, which is a tree, and it is signed by hundreds of volunteers that she has trained to help each other, both caregivers and mentors. Over 900 pairs have been made, and one of the most joyous things about this conference is to see these mentees and mentors meet for the first time, many of them who have been just connecting virtually all through COVID, but to see them sitting and having meals together and just knowing that they have shared this journey together and that Patty made that happen. So, thank you.
I'm very honored. It has been a privilege. I'm still going to be a mentor. I'm just not going to be doing the program. But doing the program has been such an inspiration because those who volunteer, even when they're doing treatment, they serve as such an inspiration. They're gold. I mean, they give so much of themselves. And it's just an honor to be in their presence. Thank you.
We'll start the program back at 10, so please go take a break, visit the exhibitors, get something to eat.
Okay, so we are ready for the second session where we will start looking at the future and how we can strategize therapies we have and develop new ones. So I'm delighted to call on stage the two moderators. Daniela Sia is an assistant professor and researcher at the Icahn School of Medicine, Mount Sinai in New York, and Annie Babiker is a medical oncologist at the Mayo Clinic. And I will leave the stage to you now. Thank you.
I'll introduce you.
Okay.
So we're going to get a next session of therapeutics, looking at drug development and combinations of chemotherapy to fight cholangiocarcinoma. And it brings me great pleasure to introduce Dr. Neela Azad, who's a professor of oncology at Sidney Kimmel Comprehensive Cancer Center, where she serves as the co-director of the Development of Therapeutics Clinical Research Program and the Cancer Genetic and Epigenetic Core Research Program.
Thank you very much, and I want to thank the organizers for inviting me here to speak at my favorite conference every year. I've been tasked with spending the next 20 minutes talking about the next generation of combination therapies for patients with cholangiocarcinoma. And I think the last couple of days has made clear the complexity of this disease and how challenging it's going to be to come up with a single combinatorial approach. And so what I'm hoping to do today is to really talk through some of the emerging data that's come and how we as clinical trialists can look forward in terms of what we can do next. So these are my research disclosures and my consulting disclosures. So what's our reality right now in taking care of patients with biliary tract cancer? Well, clearly there have been significant advancements in the last 5 years. You've all seen the number of drugs that have been approved. We have a new first-line therapy after over a decade that involves immunotherapy. And concurrently, because of the increase in understanding and in technology, we really understand the biology of this cancer better than we ever have before, though there is still significant work to be done in trying to dissect the complexity of this cancer as well. The other interesting thing about our cancer is that among the GI cancers, biliary tract cancer has more targetable mutations, more patients that have something that we have a drug for or could have a drug for than any other GI cancer. And so with that truth is still the truth that we are not where we need to be, and survival for our patients is not nearly good enough. What we need is new drugs that hit new targets. We need drugs that are better, and we need to combine them together better. So I wanted to start with a big part of what we've been talking about over the last couple of days, and that's the genetic landscape of patients with biliary tract cancer and how we can use what we know about particular targetable mutations to make combinations that make sense, that have science behind them and rationale behind them. And so in this figure right here, I've tried to highlight what's in red are mutations or abnormalities that we presently have either FDA-approved or guideline-approved therapy for. But none of these therapies are curative. And so combination approaches might be ways to target patients, but better than we have been with the drugs that we have now. And then in yellow, I also highlighted a few other mutations where there are drugs in the clinic or even approved, but for other tumor types, and we haven't yet figured out how to use them for patients with biliary tract cancer. And I'm going to start with IDH1 because there's been some beautiful work about how we might be able to target IDH1 better in the last year. So this is the Clarity trial. Others have presented it, so I'll go through it very quickly. But this was a clinical trial in the second line in advanced metastatic cancer patients who had an IDH1 mutation and were treated with ivosidenib, an IDH1 inhibitor, versus placebo. And this is the updated survival. Now, this trial had a crossover design, so patients who were in the placebo group once their cancer grew, were able to cross over and get ivosidenib. So it's difficult to show an overall survival benefit when both groups of patients are going to get exposure to the same drug. But when they corrected for that, there was still an improvement in overall survival with the correction. But you can see at the right side of the curves, we still don't get there in terms of curing patients, getting them living years rather than an increased number of months. So Nabil Bardisi's group published last year a beautiful paper that gives us a hint about a new strategy that we might want to use for patients with IDH1. And Nabil's work really looked at multiple components of how IDH1 inhibitors are working using mouse models. But one of the most important things that came out of that paper was that we actually needed an immune system for IDH1 inhibition to work. And what this figure right here is showing, if you look at the two curves that, does this have a pointer? If you look at the two curves at the very bottom, those are the curves that separation is what happens if there's an intact immune system and you give a mouse, or you could extrapolate a patient, an IDH1 inhibitor. That red curve shows how much tumor growth is controlled. But over on the left, what you see is the curves don't separate when a mouse that doesn't have an immune system is treated with an IDH1 inhibitor. So you need an immune system for an IDH1 inhibitor to work. Does this make sense? Is that what an IDH1 inhibitor is? Is it an immunomodulatory drug? Well, what is IDH1? So IDH1, if this is bringing back any troubled memories for people from medical school or other times, it's actually an important protein that's involved in glycolysis, that's involved in how we utilize glucose oxidative, using oxygen. And so in the Krebs cycle, IDH1 is an important protein that results in an alpha-ketoglutarate, which is eventually a substrate for energy for a cell. In the setting of a mutated IDH1, what happens is you end up having a buildup of an abnormal protein called 2-hydroxyglutarate, or 2-HG. And what 2-HG does, it affects multiple cellular functions. It infects multiple proteins. It affects epigenetic machinery that changes the way that a cell interacts, and it absolutely affects the immunologic fingerprint of a cell as well. And so in the same paper, Dr. Bardisi's group then took a look at the different cell populations that were affected when an IDH1 inhibitor was utilized. And this is called a UMAP, where you can map the different cell populations and what happens to them when you treat with a particular drug. So what you can see on the right is the brightness in different circles increases when IDH1 is given to these mice. And on figure C and D, what you see is an effector T-cell population, a T-cell population that's really aimed at killing the tumor, increases with IDH1 inhibition. So that's why an immune system is so important for an IDH1 inhibitor to work. Well, what about our patients with FGFR2 fusions? What do FGFR2 fusions is fibroblast growth factor, so it's a growth factor. It signals through the MAP kinase signaling pathway, and there are many different ways that FGF can be upregulated or increased in cancer cells. The ones that are today's FGFR inhibitors that are approved target are if you have an FGFR2 fusion. So these drugs are now FDA approved. They have been transformative for our FGF2 inhibitor patients. So infigratinib, pemigatinib, futibatinib, the latter two are the ones that are presently, I think, the highest in circulation, showing response rates in that 30 to 40% mark and survivals of patients that are living up to 2 years. But people aren't cured with these drugs. And so these slides are courtesy of Dr. Goyle, who's worked significantly in this area of FGFR2 resistance. And what her team showed back when she was at Massachusetts General Hospital was that patients that are treated with FGFR2 inhibitors develop mutations. They can develop mutations within FGFR2, and these can be gatekeeper mutations, which then don't allow the drug to work as well, to bind and to work as well in inhibiting FGFR2. And what they also were the first to show, and this is in cell line models, was that if you took cell lines that were becoming resistant after being treated with an FGFR2 inhibitor, one of the first generation ones, but then treated them with a covalent FGFR2 inhibitor that could bind regardless of the gatekeeper mutation, that now you could get tumor control or cell growth control. And in fact, when the futibatinib data was initially released, they really did show that there were a subset of patients that if they had prior FGFR2 exposure, they still benefited, though the drug does not have indication for that setting. Now, there's a new drug that is presently in clinical trial that's extraordinarily exciting, that's been reported. And this does remake the landscape because the response rates to this agent are over 80% in FGFR2 naive or exposed patients. So if you haven't had an FGFR2 inhibitor before. And I say it remakes the landscape mostly because people are still not cured with this drug. And so we still need strategies for how we can overcome FGFR2 resistance even as our drugs get better. And so this is looking at those response rates. So now we've got response rates of 88% at the phase 2 dose compared to response rates that were a little under 40% of the other agents. So there have been a couple of interesting papers that have looked at FGFR2 resistance and what other pathways are upregulated that we might then think about combining in combination strategies. And so this is Samik Rao-Chowdhury's work, and what his group showed, and this was work done in cell lines, that if you have an FGFR2 fusion positive cell line, that you have an upregulation, an increase in proteins in the PI3 kinase AKT mTOR pathway. And this is even more upregulated as the cells become resistant to an FGFR inhibitor, and that's what you see on the right, where that network increases in terms of the number of proteins that are upregulated in that setting. And so then the next step, which was logical in their work, was to look in cell lines. If you combined mTOR inhibitors, which are the pathways that were upregulated, if you combined inhibitors of mTOR, could you help with this resistance problem? And so the way that these assays are done are that the cell lines are treated with either drug alone or both drugs, and then they look at how many cells die, and they look at and see, hey, is this what we would expect? Is it additive? Is it just the two drugs, 1 + 1 = 2? Or is it synergistic, 1 + 1 = 5? And so anything on the figures on the right that are in the red or in the yellow or orange, that's synergistic. And you can see that when you combine mTOR inhibitors in these cell lines with FGFR inhibitors, that you have synergy the majority of the time, and that's demonstrated here numerically. Numbers less than 1 indicate synergy. So the next rational step for this, we can test it in animals. That's just a cell line. We should test it in a more complex model system and then consider testing it in patients. And that would be a good next step for the work that Dr. Rao-Chowdhury has reported. Now, Dr. Bardisi has also been interested in looking at FGFR signaling and what happens when cells or animals are treated with FGFR inhibitors. His work also showed an upregulation in the same MAP kinase AKT signaling, and also another receptor, growth factor receptor, EGFR. And so what you see on the left is a heat map showing that negative regulators of those pathways, so it's a double negative. Negative regulators of these pathways were downregulated with treatment, and so then you had increased MAP kinase signaling, increased EGFR. That's what you see on the right. And when you added an EGFR inhibitor, in particular the drug afatinib, they were able to do away with that phenomenon. And then they were able to show this in mouse models as well. And so this is a mouse model system of an FGFR2 fusion. These two different models that they used, and they showed that when you use the combination of afatinib with an FGFR2 inhibitor, that you get the red lines at the bottom, which is that really beautiful tumor control with no tumor growth whatsoever. So that next step for this would be to test it in patients. Now this is a little bit more complicated because we've got drugs that work, so you've got to have an endpoint. If you're going to give this to a patient who's never seen an FGFR2 inhibitor before, now you're going to be aiming for the stars, right? You've got a relay drug that has a response rate in the 80s, so it's very complicated to try to build on something that's so good. On the other hand, if you do this in patients that are already resistant to an FGFR2 inhibitor, then you can test it in fewer patients, and you can, your goal and your benchmark is a little bit lower, and it's a little bit more feasible to do. So I'm very intrigued because a trial is planned. This was also part of, this is a second email to Nabil 5 minutes later. But that trial design hasn't been released yet. So we'll be very interested to see how they decided to target this combination. But this is a new option in clinical trials for FGFR2 patients that's going to be exciting in the next year. And I wanted to touch on KRAS inhibitors too, because this is such an exciting area. About 5 to 7% of patients with cholangiocarcinoma, especially extrahepatic cholangiocarcinoma, have mutations in KRAS. And for 40 years, we haven't been able to target KRAS. But in the last few years, we now actually have a drug that's FDA approved for a particular KRAS mutation that's actually very rare in cholangio and GI cancers. But we now have drugs that are going to be hitting the more common mutations in our tumor type as well. And so I wanted to show this data. This is a drug called adagrasib. Adagrasib hits the KRAS G12D mutation, and in the clinical trial that they reported, they did enroll multiple biliary tract cancer patients. Those are the patients in blue, and you can see these are the waterfall plots showing beautiful responses in patients with biliary tract cancer that have this mutation in this early trial of this drug, and they are going to continue to move this forward as well. Combination therapies are going to be the next logical step for these targeted agents as well. KRAS is a very important signaling protein for cell survival, and it has many downstream and upstream partners that we could potentially target as we go forward. And I expect that we'll be seeing more papers and more work in the next year or two that are really going to explore what would be the most ideal combinations. And our very own Ben Stanger, who is now the chair of this Scientific Medical Advisory Board for the cholangiocarcinoma, published a beautiful paper just a month ago that we needed to mention as well, using this G12D inhibitor as well. And what his work showed was that just similarly to what Dr. Bardisi had showed, these KRAS inhibitors do have an impact on the immune system as well. And so these are figures from his paper showing that immune cells that we want, which are CD8 positive cells that are anti-tumor cells, go up when you treat with a G12D inhibitor, and the cells that we don't want, which are tumor-associated macrophages or MDSCs, these are immunosuppressive cells, they go down, or they change their polarity so that we have the ones that we want more, which are the M1 versus M2 ratios also change favorably. So these have an immune impact that we might really be able to harness as well. He further demonstrated this in animal models where he was able to show that if you knock out an animal's immune system, you deplete these immune cells, you still have a benefit from the KRAS inhibitor, but that benefit is not durable the same way it is if the animal has an intact immune system. And so the next step of this work is going to be clearly to look at how we can combine these drugs with other immune modulating drugs as we think about options for the future as well. So that testing these in animal system. But the other thing that's important for a tumor like ours is that we've got to jump on the train when these drugs are coming out and being tested in other tumor types. This is a very exciting drug in other GI cancers like colon cancer and pancreatic cancer. And so our community has been very vocal in advocating with the company to also test in biliary tract cancer, and so they're going to do that as well. And I think we've got to take advantage of those kinds of opportunities. So I only have a few more minutes, so I just want to talk about other immunomodulatory strategies as well. You guys have seen the TOPAZ data significantly over the last couple of days, so I'll go very quickly that we've got an overall survival benefit. We've got a tail, meaning people at 2 years, there's twice as likely a chance that people are going to live at 2 years compared to patients who didn't get durvalumab. But we still need to build on that too. And so there's been conversation about the combining of VEGF inhibition with immune checkpoint inhibitors. Why should we consider that? Well, there is data that shows that cells that help with presenting antigens, those cells can be matured in the setting of depriving them of VEGF, and that immunosuppressive cells like these MDSCs and regulatory T cells can also be decreased, or the tumor microenvironment becomes less hospitable for them if you don't have VEGF, so if you block VEGF. And so that's why it rationally makes sense to combine these two. There's absolutely been activity in hepatocellular primary liver tumors. And so we have a couple of trials that I just wanted to highlight the data that where there was the LEAP study that gave VEGF inhibition in combination with PD-1 therapy and did show that there is a disease control rate of about 70% in those patients. A separate study looking at a PD-1 inhibitor with an anti-VEGF agent also showed, as you can see in this waterfall plot, multiple responders and significant disease control. Our work at Hopkins has been focused on how we might use MEK inhibitors, which are part of that MAP kinase pathway, in order to modulate the immune system as well. Mark Yarshwin, who is now associate professor at Hopkins in combination with Greg Lazinski, who is also here, they've really been leading this work, showing first our initial clinical trial 4 years ago now, showing that atezolizumab, a PD-L1 inhibitor in combination with MEK inhibitors, that those patients were able to go twice as long before their cancer grew. But if you look at the progression-free survival curve, there is a separation, but then it comes right back down together. So we knew we needed to build upon that. And so Lauren Dennison, who was a graduate student in Mark's lab, spent her graduate studies really trying to examine what MEK inhibition was doing and why we weren't getting the responses that we wanted in that initial study. And what she basically was able to demonstrate was that MEK inhibitors actually have a negative immune impact when they're given systemically because of their impact on immune cells. And so we can counter that by giving it with a T-cell agonist. And so in a series of studies in mice, Lauren was able to demonstrate that the addition of a T-cell agonist improved T-cell function as well as survival. And so because of that, we now have an open national clinical trial that's open at many of our area centers that's combining a T-cell agonist as well as a MEK inhibitor, the same MEK inhibitor and PD-L1 inhibitor. And I only have 9 seconds, so I'm going to just quickly touch on vaccination strategies. This is an area that is underexplored in terms of combination strategies, and I really hope that is an area that we'll be able to develop further. At Hopkins, we've been developing a KRAS-specific peptide vaccine. This has been done, work that's been done by Neha Zaidi. And so that has been deployed in pancreatic cancer and in colon cancer, and we are presently excited about the idea of deploying that vaccine along with some additional mutations that are more specific to cholangiocarcinoma, and then running a clinical trial in that as well. So in conclusion, we've had so much progress. It's speeding up. It really feels like we're on an accelerated path right now, but we do need to understand why the drugs that work, why they stop working, and how we can reverse that after patients have had their initial benefit. And what we really need is advocates. We need our physician scientists to advocate within our community about working in this space. We need them to be advocating to pharmaceutical companies about allowing their drugs to be tested in cholangiocarcinoma. By far, I feel like that's the biggest hurdle, is to get access to the drugs. There's so many good drugs out there. And then we need everybody else to be advocating in every way that they can so that we can make sure that this tumor that is not that rare can really get the research that it deserves. So with that, thank you very much.
We have time for 1 or 2 questions from the audience. Please go to the microphones if we have one question. But thank you very much for the presentation. It was very, very nice to review. I guess I can ask you one question while we see if other people have something to ask you. So in one of your slides, if I did not misunderstand, there was IDH plus CTLA-4 based on Dr. Badiz's work, but there was second line with a question mark. Do you mind to argue, like if you see a space for IDH inhibitor plus ICI as first line or second line?
So when I was doing my slide deck, I decided to design a trial. And then after that, I reached out to Nabil to ask him if the trial was already ongoing. So I put the question mark there because I don't know what line that they're going to be testing this combination in. But I think that would be a reasonable place to test the second line. Yeah.
Can I ask one quick question? I mean, you mentioned, again, CTLA-4, and a few years back, when we did some transcriptomic analysis in resected biliary tract cancer, we saw that the expression of CTLA-4 in peritumoral area, but no PD-L1, was associated with a poor prognosis and relapse. So do you think CTLA-4 is something that should be limited only to IDH1 tumors, or do you think that with the rise of bispecific products or dual combination might have a role in all other?
Yeah, so that's a great question, and not at all. In fact, I think many of us that work in tumor types that are considered either cold or mostly cold tumors in terms of how active immunotherapy is, many of us are impressed with how well CTLA-4 works compared to PD-1. And for a while, it was thought to be kind of a quirk of animal models, but now I think we're starting to see even more human data where that might be true. Kim Rice-Binder published a really nice paper in pancreatic cancer where she gave PARP inhibitor in combination with CTLA-4 and PD-1. And in fact, the PD-1 PARP combination, those patients did less well than would be expected. Meanwhile, the CTLA-4 combination did much better than would be expected. And so I do think that there is something there, and I'd be really interested to hear Dr. Gretton's thoughts on it too.
I'm going to cheat and ask you a quick question, Dr. Azad. What do you predict the sequence of treatment of FGFR2 fusion is looking? This is almost sounding like, the first, second generation anti-FGFR in lung cancer. Do you foresee a future of how we're going to sequence anti-FGFR2 fusions with combinations in the future?
Yeah, I mean, I think that's absolutely an open question. I mean, now with both the relay drug that's already in the clinic, and there's some other agents that are coming out that I think we're very excited about too. I think that there's going to be a big question about whether they should come first or whether they should be the salvage regimen after someone uses, one of the more first-generation agents as well. And some of it may also be tolerability and how well tolerated they are as well. But those sequencing questions, I think, can be well investigated, both in clinical trials and then in observational data if it's done tightly as well. But I think that's a big quagmire.
Thank you very much. Thank you for being with us. It is my great pleasure to introduce our next speaker, Dr. Tim Gretten, who joins CCR Medical Oncology Branch as the head of the gastrointestinal malignancy section. It was promoted as tenured senior investigator in 2015 and deputy branch chief in 2018. Dr. Gretten is co-chair of the Center of Excellence in Immunology and co-director of the NCI CCR Liver Cancer Program. It is our pleasure to have you here. Thank you.
Thank you, Daniela, for the nice introduction. Novel targets for future, what is coming from basic research? I have no conflicts. But we're always looking for patients to enroll. I always have open jobs in the lab. Anybody interested to work with us, always, we're there. And I want to thank Stacy. I think she's just doing a really great job here. So my task is going to be, to tell you what comes from the basic lab. And, this is just, one of the many reviews that we have that shows, how much progress we have made. You just heard this from Nilo, and, we don't talk about chemotherapy only. We have targeted therapy, immunotherapy. So yes, I would agree it's a rapidly moving target, which also tells you they only gave me 20 minutes. It's impossible. There's tons of missing parts. I'm not going to cover everything. And I also don't understand everything. So, I just pick a few things, and either you like it or you don't. So when we talk about basic research, what we really, at least the way I see this, it's a lot of translational research. So it's this interface between doing research where you do cell line work or you would do potentially studies in mice and try to test something, and then you see, if what we find in mice actually works in human. But it's actually more than that. I think the more interesting studies, which are also translational studies, are the ones where you actually go back from the human into the mice. And I will show you some of this today. All right, so let's cut to the chase, and enough of all this introduction. So how do we do this research? And as I said, I'm just going to highlight a few of the studies that came out in the past. One of the advantages is that we have now patient-derived xenografts, and we can make tumoroids or organoids out of these that we can test drugs on. And this is one of those studies that was published in Clinical Cancer Research this year that shows you we get, and this is, I think, an important point also, for patients, that we can actually get the biopsy and can take this biopsy into the laboratory and then can potentially implant this into mice and then the important and test this. And the important thing is that most of the times these tumors actually really maintain the features of the primary tumor. So if we have our pathologists look at the specimen, they look the same. And if we do the genetic testing, they really resemble what is actually in the patient. So this clearly is a good tool, to study different drugs. And this is, one of those evaluations where you either do this, where you generate cell lines and do this in vitro and then test this, or potentially treat mice. And you can even, in this particular system, you can even treat resistant tumors that have been exposed to a first drug. So it's basically like a patient that received a first-line treatment, a second-line treatment. You just heard this, discussion, how do we sequence this and can test this. But what are we targeting? And basically, I'm just going to show you some general approaches that are new. The first one that is being tested, and this is all preclinical work, are fibroblasts. So when you look at the pathologist looks at the tumors, you can see these tumor nests, and you see this fibrotic that is all around the tumor. And there are studies and investigators who actually study this. This is one of them. This is work that comes from the group of Robert Schwabe, where they specifically studied these fibroblasts, and they were able to show that there are different subsets of fibroblasts. And then, again, this is preclinical work, so it's in mice. If you treat these fibroblasts, you can actually, and eliminate them, you actually see that these mice develop fewer tumors. So this is, I would say, a very novel and different approach. You don't even treat, you don't use any drugs that target tumors, but you try to eliminate fibroblasts. The next big point is tumor cell metabolism. And now when I talk about tumor cell metabolism, I specifically don't mean just IDH, but just tumor cell metabolism in general. And this is also something that's being discussed here at the conference. You can target altered glucose metabolism, lipid metabolism, or amino acids. We know that these are general phenomena that are different in tumors versus in healthy tissue. These are phenomena that you find in different types of cancers, but they're also being studied in cholangiocarcinoma. The good thing is that there's actually many, many different drugs and pathways that you can potentially target. You can see on this slide, it's a very nice summary, a review that describes this. All these different drugs are basically targeting different potentially metabolic targets in cholangiocarcinoma cells. So I would say, this is clearly something, to watch out for and that will bring new treatment options in the future. Molecular targets, you just heard this. Nilo mentioned cholangiocarcinoma is the GI tumor with the highest number of potentially molecular targets. And that really has revolutionized the field in cholangiocarcinoma, I would say. And here I would like to highlight some work that has already been mentioned by Nabil's group, showing that you potentially can make this type of treatment more effective in this case of an FGFR inhibitor by combining it with an EGFR inhibitor in preclinical models. You can very nicely see this, where he now basically shows the data very similar to the way we actually present clinical data, with waterfall plots, and then obviously here tumor volume, and you can see that this combination is very effective, and then more detailed analysis of the environment helps us understand the mechanism. So I think these are new approaches how we can in the future treat this. But the most important one is obviously the immunotherapy. And so I would like to spend the rest of my talk to tell you about, aspects of immunotherapy and, how we think this is potentially going to move forward. So when I talk about immunotherapy in cholangiocarcinoma, there are obviously way more approaches than just using one drug or type of drugs that may target the PD-PD-L1 pathway. Currently, there are actually studies available or ongoing where we use now bispecific antibodies to target not only T cells but other cells in the environment. There are other checkpoint inhibitors. There is a lot of interest in targeting different cells in the immune environment, such as macrophages, myeloid-derived suppressor cells, potentially activating NK cells. There's this whole idea of performing adoptive T cell therapy. You heard a lot about combination of PD-1 with other agents or with other approaches. And obviously, there is also the still continuing and rapidly growing field of vaccines. Now, when we do this, I think it's important that we do this similar to what we do when we use targeted therapies, that we potentially strategize and really remember that there's different types of diseases that are all classified as biliary tract cancer, but obviously there's an anatomical classification. There are different molecular subtypes that actually display different immune infiltrates. And then, if you just want to go very bland, and I doubt that that is going to be helpful enough if you just use PD-L1 expression, but that is obviously, another opportunity. The interesting thing is that now with the new technologies where we can really look at these tumors in more detail, we make very interesting observations. So this is one of the studies that I decided to show that came out of Cancer Discovery in last year, where they actually now look at different areas of the tumor. So you can see here, oops, sorry, this was wrong, and now I have to go back, and I don't know, yes. This is where you go in different areas, tumor region, tumor margin, and the non-tumor area. They look at different immune cells using multiplex immunohistochemistry. And then you can really see what we call neighborhoods, so how immune cells with tumor cells and immune cells talk with other immune cells, how this really works together. And here it's a surprising finding here in this case was actually that there were fewer immune cells in the tumor in FGFR mutated tumor, but this is not the only finding of this particular study. But what I want to tell you is, this is kind of makes us, helps us better understand the specific environment. Now with this, I'm going to move, and I'm just going to show you some of our own data that we have generated at the NCI, and this is basically, the team that is doing this because I'm just the presenter. We actually started with immunotherapy in 2014 using anti-CTLA-4 in cholangiocarcinoma patients, and this is just an overview of those studies, and then we decided to combine this with PD-L1 in patients, and then more recently we did this heroic approach of adding a third drug, anti-VEGF. And I want to show you some of this data because I think it's actually very interesting, and this is very early and very, very preliminary. So initially we started this in 2014 because at that time we had a clinical trial where we treated patients with HCC, and we saw responses, like many others later also saw them, and said, well, we should try this in cholangiocarcinoma as well, and it didn't work very well, to be honest. So then we went and said, let's combine it with PD-L1. That was a second study, and again, the treatment was kind of, there were every now and then we saw some responses, but it was not something where I say, I can be very proud of this. So then, in 2019, we started this triplet therapy, and you can see, the treatment regimen that is shown here. And we made the interesting observation that after 7 patients, we saw that all of a sudden, a lot of patients actually responded. This is something that we had not seen before. You see, this is only a very few patients. You see this, 6 patients. 1 patient has an HCC, so you may want to ignore this one. But here we saw in a very small patient population, and this is way too little to make any point that this works. Okay, this is only 6 patients. I just want to make sure that everybody understands this. I'm not claiming anything else. I only treated 6 patients here. And then I make another mistake. I may show you a survival curve and compare the survival curve from these 6 patients with what we had done before. Those studies were always about 20, 25 patients. You should not do this. And this is what comes out. Okay, but now I'm getting excited, okay, because this may be something. But what I didn't show you is, he started this in 2019. Why does he only have 6 patients? The reason is we saw unexpected toxicities. All of a sudden, in these few patients, we saw toxicities that we usually don't find that frequently, especially if we only have 6 patients. We saw patients with myositis, with myasthenia, myocarditis. Some of these patients had all of these adverse events at the same time, and they are dangerous. I don't like it when you have a problem with the heart and the central nervous system. That's not something, you want to deal with. But it shows you that we really triggered something, that we really triggered a very strong immune response, which actually correlates with the outcome. We know this. We know that patients, if they actually develop immune-related adverse events, they are more likely to respond to a treatment. Okay, so this is obviously, something that really caught our interest. And when I say caught our interest, remember my third slide with the mouse? So we went back into the mice now. And this is what I mean by translational research. So we said, is this true or not? It's only 6 patients, and I'm telling you, because I think it's important to mention this is only 6 patients, so don't make anything out of this. But it can potentially help you better understand this. So we went back now into our mouse model, and we did study design, like we have in patients. We used the different models, and I'm not going to bore you with all those details, but we can implant them everywhere into the mouse, either into the liver or subcutaneously. And then, we use similar reagents, anti-VEGF, anti-PD-L1, CTLA-4, the ones that we also use in patients, and try to mimic this. And this is what we're currently doing. Obviously, this is not done, otherwise, it would be published. And the first thing that we saw is there's actually toxicity. So these are now tumor-free mice, and we treat them with this combination treatment. And if we look in lung, we find a lot of immune cell inflammation. If we look in their kidney, we find nephritis. If we look in the liver, we find periportal inflammation. And, and then we have experts who can score this and quantify this, suggesting that it's actually very similar to what we see. And we don't see this with the combinations that we had used before. And then if we go and look at efficacy, again, we can look at this over time. And here it may be easier to see. Indeed, this triplet combination is way more effective than what we see with the doublet. Now, currently, we're studying this and trying to understand, on a more cellular basis, what the immunological mechanism is, why this is changing the immune response so strongly, and I hope that soon I can tell you about this. In the last 2 minutes, I have to thank again the Cholangio Foundation because, I think it's actually very nice if you have one project that you do in mice. that Lawrence Dix did, that was supported by the Cholangio Foundation, where he showed that, and you heard this before by others, that's why I'm not going to talk about this again, about anti-CD40 as a potential treatment option. And then Dr. Monhay, now she told you about this yesterday, is taking this now into a clinical trial where we hopefully can test if what we have found in the marine system also applies to patients. And with this, I'm going to close and thank my group who are doing all the experiments and all the various collaborators that we have within NIH and outside the NIH. And then last but not least, for those who are working in the field, I just want to shout out that there is a special conference on the cholangiocarcinoma, a FACET meeting, which is going to happen in August. And with this, I'm happy to take any questions.
Thank you. Questions for Dr. Gretton? Unfortunately, I cannot see. I might need some help. I don't see. I see Dr. Bardisi. If we can get him a microphone, please. Thank you.
Great talk, Tim. Just a quick question. Do you know the source of VEGF in these tumors? Which cell types are producing the VEGF? Would you happen to know? Either from your single cell work
no, actually, that's a good point. No, we have not looked at the source of VEGF. What we know is that the VEGF in the serum of the patient is elevated, and it goes, as expected, dramatically down if we treat them with anti-VEGF. I mean, that's not, not surprising. It's just a confirmation. But we don't know what the source is. Others have looked at tumors. I know that tumors can produce a lot of VEGF, but I have not looked in this particular group yet.
Okay, thank you.
Any other question?
I will ask one question, which is a little obvious and probably there is no answer. What about heterogeneity? You introduced the concept of CAF as targets, but we know that not all CAF are good, not all CAF are bad. How do you envision tackling that?
So that's an important question, the heterogeneity. And as you know, I work a lot together with Xin-Wei Wang, who is really the specialist in this and can answer this probably much better. But what I can tell you is there's also an immune heterogeneity, and what we believe is that you may actually overcome this. So because we know that if you kill one tumor cell, you may actually cause bystander killing, and then a different tumor cell that may be different and will release antigens again, and then you will actually prime an immune response against this. So the nice thing from an immunological perspective, at least, is that heterogeneity does not necessarily have to be a huge problem.
Thank you. Thank you very much.
We're going to switch gears right now from novel combination of therapeutics and immunotherapy targets to actually CARs that are finding their way fast to our clinical trials portfolio within each cancer center, not in leukemia, but in solid tumor. And with that, it brings me great pleasure to present Dr. O'Hare, who's going to talk to us about the potential of CAR T-cell therapy in this disease. Dr. O'Hare is an assistant professor of medicine, Division of Hematology Oncology at the Aberystwyth Cancer Center at the University of Pennsylvania, where he concentrates on the treatment of gastrointestinal malignancies. Dr. O'Hare is a clinical and translational researcher who focuses on immunotherapy in GI cancers. Thank you very much.
Thank you for that kind introduction, and thank you to the organizers for the invitation to speak today about the potential of CAR T-cell therapy in cholangiocarcinoma. I have two tough acts to follow here, so hopefully I can do some justice to what I see as sort of an emerging field in GI cancers in general, but hopefully also in cholangiocarcinoma soon. Here are my disclosures. So overall, I just wanted to give just a brief outline of what I hope to accomplish today, and that sort of is to, first off, give a background to CAR T-cell therapy. As CAR T-cells are not commonly used in cholangiocarcinoma, as we'll soon find out, but they're emerging. I wanted everyone to get on a basic framework of understanding of CAR T-cells, and then kind of using a lot of my experience in using CAR T-cells over the last 10 years in different cancers, especially pancreatic cancer, and in terms of looking at some of the barriers that are set up against solid tumor efficacy of CAR T cells in solid tumors, including target selection and looking at the immunosuppressive microenvironment, and then looking at some potential strategies that we're using to overcome some of the CAR T cell exhaustion that we're seeing within our tumors. And then finalizing on just looking at some of the open clinical trials right now that I hope to continue to expand in cholangiocarcinoma. So looking at what is a CAR T cell, so looking at CAR, which means chimeric antigen receptor. Basically, it combines an external scFv of an antibody, so something that recognizes a specific target that we want to target in a cancer cell, with the endogenous T cell effector function. So if you look on the bottom left, you see an endogenous TCR, which is basically the normal T cell receptor that we see in our T cells. And then to the right, how we've modified the T cell receptors. We've taken some of the endogenous components, so for example, the CD3 zeta that's there, and combined it with co-stimulatory domains, 4-1BB mentioned there, but there's also CD28 amongst other ones. And then we've attached it through a hinge region to an scFv of an antibody targeting a protein that is overly expressed on cancer cells. And so a lot of the work we're going to be talking today is on mesothelin, although there are some other targets that we'll mention there. These constructs are built in the lab, and there's been modifications over the years from sort of first generation, which just had the CD3 zeta, to second generation, which includes one co-stimulatory domain, third generation, fourth generation, and now fifth generations, as we're kind of combining more co-stimulatory domains or more chemokine secreting domains within the CAR T cell construct itself. These constructs are made in the lab, and the way we bring it to patients is that we collect their T cells, as I'll show on the next slide, and we will introduce the construct through a lentiviral vector that's been modified, so it basically will just introduce the construct into the nucleus of the T cell, as shown here. When it introduces it, it's then processed and then able to be presented on the outside of the cell, and now we have a CAR T cell. We grow these up in the lab, and we give them back to the patient. That whole process is shown here in this figure. So we start with a patient who's interested in pursuing a clinical trial. We undergo apheresis to collect their T cells. We select these T cells, we infect them with the lentiviral vector in the lab. We grow them up and expand them. And then once expanded and we do some quality and control, we are ready to give them back to the patient. This whole process takes about 3 to 4 weeks on standard, although there are some ways of actually speeding up this process overall. But that is definitely a pertinent point when we choose the right patients for these trials, because you want someone that is basically able to have their disease controlled prior to enrollment and treatment on the trial. And when ready, we can give them back to the patients, and patients may or may not receive lymphodepleting chemotherapy prior, and you'll see that's variable amongst the trials that we're about to show. And so moving forward and just sort of looking at CAR T cells in general, amongst patients, we know that CAR T cells have revolutionized the management of hematologic malignancies, specifically CD19 CAR T cells, which I did a lot of work with, actually just sort of seeing patients in my fellowship at Penn as we had some of the first clinical trials there. And now there's 5 different CAR T cell products that are approved for use by the FDA. 4 of them are CD19 based and are approved for ALL, B-cell lymphoma, follicular lymphoma, and mantle cell lymphoma, and one is a BCMA-directed CAR T cell that's approved for use in multiple myeloma, and there's ongoing studies on how to improve the efficacies of each of these CAR T cells in these diseases, but they really revolutionize the management of these patients. However, as we try and translate them to solid tumors, as has been mentioned several times at this conference, there's several barriers that are in place that we need to try and overcome. And that's a lot of the work I've been doing to try and see how, what barriers the cancer itself is putting up against these CAR T cells, and try and see what methods we can use to try and overcome them, and use that as knowledge to hopefully translate these CAR T cells into efficacy for cancers like cholangiocarcinoma. Some of the barriers I'll focus on today is looking at CAR T cell selection, the trafficking of CAR T cells to the solid tumors themselves. You know, one of the easy, quote unquote easy things about liquid tumors is that when you give CAR T cells into the vein, the CAR T cell sees its target right away because of the circulating hematologic malignancies, but the CAR T cells need to go from the vein to the tumor, and then once it gets to the tumor, it's got an immunosuppressive microenvironment to contend with, as we've heard over and over and over again at this conference. But I think there's lots of strides being made in terms of understanding this microenvironment. Hopefully we can take some of this learning to combine it with CAR T cells to actually make this a more effective therapy for our cancers. So looking specifically at CAR T cell selection, the target selection, We know that targets for these CAR T cells, it's different for some of the other processes like T cell receptor or adoptive cell therapy, but these targets have to be an extracellular membrane-bound protein. And so something that can be recognized on the outside of tumor cells. And the goal is to find a target that is presented on the extracellular membrane of tumor cells, but not expressed at high levels at normal tissue. Because when you give these CAR T cells, it's going to basically see the receptor, see the target, and attack the target. So you have a potential for on-target, off-tumor activity that leads to side effects. We'll talk about that in a second. Looking at the potential targets, looking at the preclinical work that's being done right now in developing CAR T cells specifically for cholangiocarcinoma, I've outlined some potential targets here. And I'm happy that a lot of the same targets that were mentioned in Dr. Gritton's talk just prior to mine are also shown here on the slide. But we have one example showing next of EGFR being used. This is something that's sort of universally presented on intrahepatic cholangiocarcinoma, about 50% of extrahepatic cholangiocarcinomas. Although we know that EGFR is also expressed on normal tissues and has the chance for on-target off-tumor activity. A lot of work I've done in the clinic is on mesothelin expressing tumors and its variable expression, probably more likely expressed on extrahepatic cholangiocarcinomas, up to 2/3 in some cell line assays, and maybe about 1/3 in intrahepatic cholangiocarcinoma. CD133, cancer stem cell antigen, is presented about 70% of cell lines. MUC1, or the mucin-1 gene, also expressed at high levels, and then aberrant glycosylation of MUC1, which I'll show on the next slide, is also expressed about 70% of cell lines for cholangiocarcinoma. HER2, definitely a lower presentation, less than 10% of patients, but mostly in the extrahepatic and gallbladder cancers, and definitely gives a potential targeted therapy from adoptive cell therapy potential there. And then the last but not least, integrin alpha V beta 6 is also expressed at high numbers. And so there's CAR constructs that are designed against all of these targets in the preclinical space, and we'll see that there are some clinical trials exploring these CARs in cholangiocarcinoma or all solid tumors currently. Just as an example of how actually trying to decide which is the best type of target to use, I explore TN-MUC1. So MUC1 is a mucin gene. It's a glycoprotein commonly expressed in normal, healthy, simple, and glandular cells, and a little bit in leukocytes. And in cancers, we find that MUC1 gene is actually aberrantly glycosylated. So we get these TN or STN moieties added on. And so now we have something that MUC1 is expressed on normal tissue, TN-MUC1 is expressed in tumor cells, so it's sort of an ideal target for us to sort of say, okay, this is something that's expressed in cancer cells, not in normal tissue. Maybe we can have some activity with CAR T cells here. And we see here in the lower right a construct that's been made using a SCFV to TN-MUC1 linked by a hinge region to a 4-1BB co-stimulatory domain and a CD3 zeta endodomain. And if you look at the graphs at left, you see that when you use this construct in a xenograft model of TN-MUC1 expressing cholangiocarcinoma, you see increased tumor kill, decreased tumor volume over time. And then at the bottom, looking at the histochemistry, you see an infiltration of the CD3 positive T cells into the cancer tissues of the CAR T cell treated tissues, but not just using a mock T cell without a CAR T cell construct. So proof of principle, and this is moving into the clinic as we speak. The only clinical trial that's actually published right now looking specifically at a CAR T cell in cholangiocarcinoma is looking at an EGFR CAR T cell. I'm using this as sort of an example to kind of point to the fact that we really need to look at the targets closely. And so in this trial, they used the EGFR CAR T cell, and patients received lymphodepleting chemotherapy with nab-paclitaxel and cyclophosphamide, followed by infusion of the CAR T cells, and they were monitored closely. We see a modest clinical activity on the right side. You see one patient with actually a durable complete response, which is quite interesting. 10 patients with stable disease, but this translated into a median progression-free survival of only about 4 months. So definitely some potential movement in terms of making this more efficacious in this population. What I want to point out and sort of circled on the left-hand side is the adverse events that we're seeing. And although not all patients develop significant adverse events, we see that there's evidence of on-target off-tumor activity. We know EGFR is expressed on most of our tissues, including the skin, and we see that patients developed over time desquamation, pruritus, gastrointestinal hemorrhage, mucositis, and oral ulcers, some of them significant. And so from that perspective, clear evidence that this target itself may not be the best because there's a potential for significant adverse events. And I'm glad that most of these were not grade 3 or grade 4, but something to be cautious of in the future. In my own experience using mesothelin CAR, I want to point out also the potential that some of these targets that are thought to be just expressed on cancer cells and at low levels of normal tissue, we could still have some on-target off-tumor activity. This is our clinical trial looking at a mesothelin-directed CAR T-cell in pancreatic cancer delivered by IV initially in the first cohort. What we saw on trial is that 1 of 3 patients had stable disease when it was given intravenously. Patients did not receive lymphodepleting chemotherapy on this. We did see a good expansion of CAR T-cells in the blood, and then as we commonly see, that it falls off about day 14 to day 30. And we see the presence of CAR T-cells in the tumor tissue, so we know that these CAR T-cells are getting to the cancer through the IV delivery. The thing we weren't expecting was that 2 out of the 3 patients developed significant pneumonitis. I give an example here just on CT scans. We see baseline CT scans at left with patients with pulmonary nodules. That's her site of disease. Day 11, she got admitted to the hospital for some increasing subjective shortness of breath, although no need for oxygen. We got a scan, and the nodules are about the same size. There's a little bit of inflammation showing in between, just sort of throughout the lungs at these 3 representative cuts. And as we progressed, the patient developed worsening shortness of breath, worsening oxygen requirement, eventually developed high-flow nasal cannula, a need for high-flow nasal cannula, and we see that the scans themselves show worsening pneumonitis. And the patient was in a prolonged hospitalization up to almost about a month and a half, and then eventually we were able to wean down the oxygen and get her off oxygen as an outpatient with some improvement in the pneumonitis. This kind of illustrates 2 points. What we know is that mesothelin is expressed at higher levels on cancer cells, but lower levels on normal tissue. And we had always thought that this was sort of because of the pleura, the pericardium, the peritoneum. But what we also know is mesothelin is at very low levels in type 2 pneumocytes. And so what we think actually ended up happening here is that when there was some level of inflammation against the mesothelin in these type 2 pneumocytes, inflammation then actually led to more mesothelin production, that then led to more CAR T-cell activity, that then led to more worsening pneumonitis. Now, this doesn't happen in every patient, so it doesn't explain everything 100%. And one of the things we were also worried about is by giving this by IV delivery, the first place that this patient, the CAR T-cell actually encountered mesothelin was in the lungs, because it went from the IV into the vein to the right side of the heart to the lungs, and then hopefully it was supposed to go back to the left side of the heart and then the rest of the body to the tumor. But the first place it encountered it was in the lungs itself and causes inflammation. From this, we learned that we might need to actually change our protocol a little bit, so we went to regional delivery, where we deliver CAR T-cells directly to hepatic lesions through a specialized device, a hepatic arterial infusion through the TriCellus TriNav device, and then also in the peritoneum using a peritoneal catheter for those with peritoneal carcinomatosis. And what we found is that the CAR T-cells obviously made it to the tumor, but part of our big focus in this is actually to look at biopsies here and actually try and figure out what was happening to the CAR T-cells within the tumor. So we actually had a little higher levels. It was safer. We didn't see the pneumonitis in any other patient itself, and we're still ongoing in terms of analyzing some of this data. So now knowing that we can get these CAR T-cells to the tumor, now how do we get them to work? And we've heard over and over and over again about this tumor microenvironment, the myeloid-derived suppressor cells, the regulatory T cells, the TAMs, the fibroblasts. All of these forces that are up against the normal immune system are also forces against the CAR T-cell. And so we need to think of different ways of actually getting these CAR T-cells to be better or combining it with something to make it a little bit more effective. So one logical thought is, can we combine CAR T-cells with checkpoint inhibition? And while this hasn't been done in many cancers, it was done at Sloan Kettering using a mesothelin-directed CAR T-cell in patients with malignant mesothelioma. These CAR T-cells were actually infused directly into the pleura because that's where most patients' disease was. And what we saw is initially patients just received the CAR T-cells into the pleura, and then I don't know if you can see the red numbers there, it's a little bit small, but all patients that have the red number actually also received a checkpoint inhibitor. And what you see is that the responses that we see on this were increased in those that received the pembrolizumab, had a median overall survival of about 18 months. And then looking on the lower part of the graph, you see that's sort of looking at CAR T-cell levels in circulation. And when patients receive the pembrolizumab, we actually see an increase in CAR T-cell presence in circulation. So clearly some potential synergy there. Now, PD-1 inhibition actually does work in in mesothelioma, and so further work has to be done here. But I think overall, when we look at our other diseases, such as cholangiocarcinoma, where single-agent PD-1 inhibition isn't necessarily all that effective, we might need to look at some other strategies, and there's definitely several different potential options to look at here. I'm kind of switching gears a little bit to actually, rather than doing combinations with CAR T cells, kind of look what can we do about the CAR T cell itself to try and see if we can actually make some changes to make them more effective and maybe less targeted by this immunosuppressive microenvironment. This is a clinical trial that's been ongoing looking at Gavo-cel, or TC210. It's a mesothelin-expressing TRuC T cell, so it's sort of a modified T cell receptor-based therapy, so not necessarily within the CAR T cell realm, but I thought it was worth highlighting here. So this is basically taking an entire endogenous T cell receptor and fusing to it to target antibodies to target mesothelin. And it works through an HLA-independent manner, unlike some of the TCR therapies that we have in clinic. And this study showed an impressive waterfall plot looking at some responses as well as prolonged stable diseases here in the phase 1 setting. It was also pretty well tolerated overall. I've highlighted on here, despite this trial being open in mesothelioma, ovarian cancer, and cholangiocarcinoma, only one patient with cholangiocarcinoma was enrolled on this trial. And they did demonstrate a partial response to this therapy, albeit it was not significantly prolonged, as they did come off therapy before 4 months because of progressive disease. But this phase 1 trial did lead to orphan drug approval for mesothelin-expressing tumors, including cholangiocarcinoma. They've moved this now into a phase 2 study, and they're using, first started with just a single agent at the recommended phase 2, and now they've actually modified the protocol to now include checkpoint inhibition, looking at nivolumab, as well as nivolumab and ipilimumab in mesothelioma, and then nivolumab in both ovarian cancer and cholangiocarcinoma. And I'm interested to see how nivolumab would work in something like cholangiocarcinoma, where PD-1 inhibition may not be the best option. And it would be interesting to sort of see if ipilimumab may be a better choice in these cold tumors, as I sort of echo what Neela had said in her talk earlier today. I'm going to have 2 more quick points to make. One thing that we also realized, I mentioned in the CAR T cell trial that we did for pancreatic cancer, one of our big focuses was to see what was going on with the CAR T cells in the tumor microenvironment. One of the things that was happening concurrent with the trial is in the lab they were studying the effect of CAR T cells in these mesothelin-expressing tumors. And what they found is that with continuous antigen exposure, the CAR T cells actually become less proliferative, less cytotoxic, and less effective in terms of secreting cytokines, as shown here. And so knowing that these CAR T cells, when we give them in humans, see a continuous antigen exposure most commonly, what can we do about potentially finding a signature that we might be able to target? Moreover, actually looking at this continuous antigen exposure, if you actually took away the antigen, then the T cells actually could rest and could return to actually having high proliferation and cytotoxicity. Looking at these CAR T cells that had the continuous antigen exposure, we were able to identify CAR T cell dysfunctional signatures in the lab. And we focused specifically on SOX4 and ID3. 2 transcription factors were upregulated within these continuous antigen exposed tumors. And what we found is if we actually knock out SOX4 and IDA3 or ID3, then that actually led to less exhaustion of these continuous antigen exposed CAR T cells. And so it opens up the possibility that we may be able to translate this into the clinic. To figure this out, though, we wanted to see whether or not these CAR T cells actually had this dysfunctional signature in our patients. And this is a representative slide from one of the patients on the peritoneal infusion of our mesothelin-directed CAR T cell, and we, in fact, were able to find this dysfunctional signature, including upregulation of SOX4 and ID3 on these CAR T cells. And so current work right now is actually looking at modifying and potentially knocking out SOX4 and ID3 during the manufacturing step of our CAR T cells to potentially be able to bring that into patients to hopefully lead to less T cell exhaustion. And I realize I'm just out of time right now, but I just want to focus on just this one last topic here. It's a new clinical trial that we're opening up for cholangiocarcinoma patients among also with ovarian and mesothelioma, but this is a new sort of novel design looking at mesothelin, a mesothelin CAR. And so what we know is when we take chimeric antigen receptors, I showed you in the beginning, we're basically taking parts of what normally happens within the T cell that are separate functions, and we're combining it all into one construct. And so with this, we wanted to, work had been done in the lab at Penn showing that actually if you're able to take certain parts of it and keep it separate, we might be able to increase the efficacy of these CAR T cells. And so they designed this thing called a KIR CAR. So basically, they took the killer immunoglobulin-like receptor, which is found in CD4 positive, CD8 positive T cells, as well as NK cells, as well as the DAP12 immunoreceptor. These are sort of separated, and if you actually put them and design them as a CAR T cell and put it into tumor models, xenograft models of mesothelin-expressing tumors, you find that these two components of this CAR combine only when they're actually bound to mesothelin, and then after tumor cell kill, there's no more mesothelin, so they separate. So it kind of recapitulates more of the standard T cell receptor activity. And you see that in this model here of a previous CAR T cell that was a model of mesothelin-expressing tumor that was resistant to the standard CAR T cell, that these KIR CARs were able to actually increase function itself. And this has now moved on to a phase 1 clinical trial, which just opened, looking at patients with mesothelin expression. Mesothelin expression cholangiocarcinoma is the part that I'll be running. And this is something that literally we're just starting to screen last week. Patients on this trial will receive lymphodepleting chemotherapy with fludarabine and cyclophosphamide, followed by infusion of these KIR CARs, and there's going to be 6 cohorts at a 3+3 design. And so we're excited to see what kind of activity we see in the clinic on these new generation of CAR T cells to try and see if we can increase efficacy. I know I've talked about a lot of barriers to CAR T cells, but there is CAR T cell work being done in cholangiocarcinoma. I think that we're going to continue to learn about them. This is a list looking at my clinicaltrials.org research here of trials that are available. Most, unfortunately, are available in China for those in the US. But in the US, top one is the mesothelin-directed KIR CAR that I just mentioned. There's also a couple of HER2-directed CAR T cell trials that are available. And a lot of the other CARs that are mentioned there are things that I mentioned earlier where they had done preclinical work to find efficacy for those receptors. And so in conclusion, we find that in hematologic malignancies, CAR T cells are effective, but in solid tumors, there's a lot of barriers that we need to overcome. And similar to what's been mentioned earlier, we need to find what's happening in other diseases, how we can modify these CAR T cells, what logical combinations can be done within cold tumor microenvironments, similar to what's seen in cholangiocarcinoma, so that we can actually make this potentially effective therapy for patients with cholangiocarcinoma in the future. And with that, I'd like to thank you for your time. Thank you again to the organizers for inviting me to the conference to speak, and happy to take any questions. Thank you.
I think we can have time for one or two questions, if that's possible. So I was going to throw out one question. So thank you very much for the great presentation. It sheds light into the future of CAR T cells immunotherapy in solid tumor malignancies. One talk, I think you touched point on it. One talk we always hear about CAR T cells is the CAR T cells exhaustion. Mm-hmm. And I know in the world of leukemia, they're looking at boosters or treatments to overcome that exhaustion after treatment. Is that something that you foresee will occur in the future in solid tumor?
Booster
Yes.
treatments? Yeah, and so actually built into the pancreatic protocol right now, we actually have the regional delivery with sort of 2 subsequent IV infusions. In the ovarian cancer and mesothelioma trial, they're actually doing 3 IV infusions. And so that's something that we're studying to see if it actually helps with this exhaustion. I think a lot of it's going to be getting that tumor biopsy sort of before you do the repeat, as well as sort of after all the repeats, and sort of see if we're actually having a role on it. We are having potentially some increased clinical activity, although I can't say it's sort of a major change. And so I do think it's going to be more than just doing a booster, personally.
One of the questions is the lymphodepleting chemotherapy, because the issue with the type of therapy is that you have to gain some time because you have to produce the cells, etc. And then the other question is, what type of chemotherapy are you actually proposing to use for lymphodepletion?
Yeah, so that those questions I think I could actually spend an entire day talking about, just because it is definitely a source of contention, not only in some of the liquid tumors, but also in solid tumors. What we found in our early clinical trials in pancreatic cancer, ovarian cancer, mesothelioma is actually when we gave lymphodepletion, we actually didn't see much change in either expansion or proliferation of the CAR T cells in circulation. or actually translation to the tumor. So when I designed the pancreas trial, I actually opted not to do the lymphodepleting chemotherapy because there are obviously a potential of side effects that come with that in terms of neutropenia that can happen. The type of lymphodepleting chemotherapy is interesting, and I think that there's variability amongst different centers. There's sort of a new theory that I'm kind of ascribed to and sort of testing out my pancreas trial right now is that maybe we actually don't need lymphodepletion, but maybe we need conditioning chemotherapy. And so one of the thought processes I have is actually, can I use the chemotherapy that's actually appropriate for use for the cancer to actually kill off cancer cells to see if I can condition the tumor or the tumor microenvironment to receive these CAR T cells a little bit better. And so how I modified the pancreas trial right now is actually in the first line. So patients actually get collected before they start first-line chemotherapy, receive 3 to 4 months of chemotherapy, standard chemotherapy for their pancreatic cancer, and then I will work the CAR T-cell infusion at that point after sort of maximal benefit of the chemotherapy to see if maybe I can use the standard chemotherapy as a conditioning regimen to potentially make these CAR T-cells better. And so I don't know the answer to that, but I do think it's definitely something that we are still learning about, and I think we need to still think a little bit more critically, especially as we design trials for solid tumors.
Excellent talk. I have a question, especially regarding improving the efficacy of CAR T. There was a paper that came out of C.D. Chen's lab at Yale last year. I think they looked at kind of a CRISPR knock-in screen, and they found that an enzyme related to protein metabolism, actually when they knocked in kind of like the co-stimulatory molecule that improved CAR T efficacy, effector function. Are you aware of that? And then have you kind of looked into those avenues? And is that type of therapy or modality kind of ready for prime time to be trialed in clinical setting or something like that?
Yeah, so that's a great point, and I think that's where a lot of the work being done in CAR T cells is heading right now. Well, I don't know that one specifically. I know that at Penn we have done CRISPR-Cas9 knockout, not necessarily knock-in, of certain genes. We did a TGF-beta double knockout and actually a modified PSMA CAR in prostate cancer and saw some interesting results there. And so it's definitely something we're exploring, and I do think will be certainly a part of CAR T cells in the future.
I have a quick question. Regarding mesothelin expression in cholangiocarcinoma, one of the challenges we had as a site on the TC210 trial was unexpectedly low rates of positivity. And I'm wondering if there's any data according to anatomic subsite that would help us know which patients to look at.
No, I think that's definitely something that I'm concerned about moving forward with this SynCure CAR trial as well. In the numbers that I kind of showed at the target levels were actually stuff that's based off of cell lineages, sort of preclinical models, or some patient-derived samples, and so it's not necessarily representative of what we see in the actual trials. I had a similar outcome when I was screening patients for pancreatic cancer as well, where I was told 90% by those things, and it ended up being about 40% at the levels we were looking at. And so I don't know what it's going to be. I do think that what we see is that the extrahepatic cholangios tend to have more mesothelin expression than intrahepatic, and so I do think there's going to be an enrichment for the extrahepatics in our trial.
Thank you.
I want to say thank you very much. We appreciate it. Thank you for the great talk.
It is now time for our last presentation from Dr. Sandra Kazak, who unfortunately was not able to join us in person. We will play a video. Dr. Sandra Kazak is a pediatric oncologist and the acting team leader for the gastrointestinal malignancies in the Division of Oncology in the Office of Oncology Products at the Center of Drug Evaluation Research, FDA. Over 15 years at FDA, Dr. Kazak has gained expertise in the design and analysis of clinical oncology trials of drugs, biologics, combination therapies, and companion diagnostic for the treatment of cancer. And in the next 20 minutes, she will discuss future thinking for clinical trials in cholangiocarcinoma. Let's play the video, please. Thank you.
Good morning. My name is Sandra Kazak, and I am the clinical team leader for the gastrointestinal malignancies team in the Office of Oncologic Drugs at the Food and Drug Administration. I would like to thank the Cholangiocarcinoma Foundation for inviting me to participate in the 2023 annual conference and for keeping the dialogue with the FDA open. I have no conflicts of interest to disclose. In 2010, the results of the ABC02 trial were published, establishing cisplatin and gemcitabine as the standard of care for biliary tract cancers. It took another 10 years before another treatment was approved for cholangiocarcinoma. Since then, 3 FGFR2 inhibitors, an IDH1 inhibitor, and an immune checkpoint inhibitor have been approved. These therapies represent incremental improvement, but cholangiocarcinoma remains a disease with an unmet need for effective therapies. For more than half a century, the clinical development of anti-cancer drugs followed a paradigm with sequential stages. Phase 1 trials were designed to determine the drug's safety, tolerability, and dose. Phase 2 trials then explored the drug's activity in a variety of cancers, and Phase 3 trials compare the new drug with existing treatments and serve as the basis for regulatory approval. This paradigm requires the conduct of multiple trials and a long time for a drug program to demonstrate that the drug is effective and safe for a particular indication. Multiple trials were required for each disease and multiple trials for each combination. This was an inefficient and burdensome paradigm. Innovative strategies are changing the clinical trial landscape. Advances in our understanding of cancer biology have led to both development of more effective drugs and improved patient selection by early biomarker discovery and development of assays to reliably detect these biomarkers in patients' tumors. The 3 distinct sequential phases of drug development have therefore become increasingly blurred. Innovative trial designs like master protocols and adaptive trials can accomplish many objectives in a seamless fashion and provide a more flexible and effective way to conduct clinical trials. In addition, through the advancement of biomarker discovery and identification of tumors harboring these genetic aberrations, when the biology supports that a particular genetic aberration drives the tumor growth, irrespective of the tumor origin site, a tissue-agnostic development may be possible. Traditionally, cancer clinical trials have relied on overall survival and measures of tumor growth or reduction to assess the efficacy of a drug. However, benefits are often accompanied by significant symptomatic toxicities. The degree to which a therapy improves disease symptoms and introduces symptomatic toxicity affects how patients function in their daily lives. Patient-reported outcome assessments in cancer trials and evaluation of functions are crucial to truly assess the benefit of any treatment and are being slowly incorporated into trial design. As we are coming out of the COVID-19 pandemic, the clinical trial ecosystem should be changed to address what we learned. Patient-centric, decentralized clinical trials are needed to reduce patient and sponsor burden and increase accrual and retention of a more diverse trial population. The growth in technology, data mining and processing, and other technological advances are opening the doors to incorporate real-world data into clinical trials. For each of these topics, the Oncology Center of Excellence, or OCE, at FDA has already published guidances and numerous papers. There is virtually no area in medicine and care delivery that is not already or will be not soon be touched by artificial intelligence. Analysis and interpretation of information from multiple sources and large databases will revolutionize clinical practice and the clinical trial landscape. None of these innovations will be possible without establishing partnerships between all stakeholders. Although these are exciting developments, any future thinking should be informed by the experiences we have gained on clinical trials. I would like to focus this talk on issues related to FDA's experience gained on multiple oncology trials that should be addressed when considering the design and conduct of such trials. Because of time constraints, this is an incomplete list. These additional considerations include issues related to diversity and representation, dose optimization, development in earlier disease settings, and pragmatic trials, particularly in the context of cholangiocarcinoma. The first consideration is related to diversity and representation. Drug development is mostly a global enterprise. Clinical trials are planned under the assumption that the treatment effect applies to the entire target population, particularly to the regions included in the trial. For a rare disease like cholangiocarcinoma, multi-regional trials are necessary and should be designed to allow for an examination of the applicability of a treatment to diverse populations. The table on the slide summarizes the population by region enrolling the 5 trials supporting approvals for cholangiocarcinoma since 2020, showing a similar enrollment across North America, Europe, and Asia. However, as we can see on the table on the right, although the trials were multi-regional, the population enrolled does not adequately represent racial and ethnic minorities, and results may not be truly informative of the effects of treatments across the population that has the disease. These trials enroll only 3% of Black patients and only 5% of Hispanic patients. Of note, in the US, the highest incidence of cholangiocarcinoma is observed in Asian Pacific Islanders, a group that was almost not represented in these trials. Furthermore, although the median age of diagnosis of cholangiocarcinoma in the US is between 70 and 72 years old, the median age of patients enrolled in these trials is 59 years, and 61% of patients were younger than 65 years of age. Although data on where these trials are coming from, although data on where these patients are coming from is not available, most of the centers enrolling patients in these trials are not community practices, leaving an important gap in our knowledge of the feasibility of receiving these drugs in the places where most patients will be treated. Diversity in clinical research, including in clinical trials, benefits everybody. Last year, FDA published a guidance with recommendations for sponsors to develop and submit a plan to address inclusion of clinically relevant populations. In December of last year, the Food and Drug Omnibus Reform Act, also known as FDORA, was signed into law, which means that diversity action plans to increase enrollment of subjects from underrepresented populations is now required, expanding the original scope of the guidance. Diversity goes beyond racial and ethnic minorities. Shown in this slide are several OC projects aimed at increasing diversity and representation in clinical trials. These projects have a wide-ranging scope, from working on policy like the implementation of the requirement of enrollment of diverse populations, working on outreach initiatives for patients, advocates, families, and people living in underserved urban and rural communities to increase communication and foster understanding between stakeholders, to provide a framework for concurrent submission and review of oncology products among international partners. In addition, there are numerous publications and ongoing collaborations with other institutions like ASCO, AACR, and others that are aiming to expand diversity. The second area in need is related to dose optimization. Future clinical development programs should be designed to conduct proper dosage optimization and incorporate dose optimization strategies into drug development. With traditional cytotoxic drugs, as we can see on the left graph, dose response and dose toxicity curves were parallel. The default decision was to select the highest dose that was evaluated, reflecting the belief that higher drug doses will have better therapeutic activity. However, as can be seen on the right curve, this paradigm does not apply to targeted drugs. In the table on this slide, we can see that in at least 2 of the approved FGFR2 inhibitors for the treatment of cholangiocarcinoma, most patients require dose modifications, likely indicating the poor tolerability of the studied dose. For infigratinib and futibatinib, as a condition of approval, dose optimization studies to evaluate lower doses have been required. Dose optimization should not be an afterthought. Dose optimization prevents avoidable toxicity, increases uptake of the drug, and improves adherence to treatment. Through Project Optimus, OCE is working on multiple efforts to improve dose optimization in clinical trials. In 2023, the FDA guidance on optimization of dosages in oncologic diseases has been published, which includes specific recommendations for each stage of development. Among other recommendations, the totality of the data, including dose response for toxicity and efficacy, and the assessment of low-grade toxicity, which has the potential to substantially impact the quality of life of patients, should be incorporated into dose selection. An important step forward in clinical trials would be a reframing of the timing for enrollment of patients. This slide from the University of Chicago describes the current drug development paradigm in which clinical trials are mostly centered in patients with late-stage disease who have already been treated with one or more prior lines of therapy. However, consideration should be given to design trials that support initial approval in the earlier disease setting, which may provide important advantages. Initiating the clinical investigation of new therapies in an earlier treatment setting can provide more patients the opportunity to receive the investigational drug early enough in the disease course when disease-related factors do not preclude participation in the trial and when the treatment has the potential to alter the course of the disease more effectively. Trials in earlier settings may improve assessment of drug effects. There is greater opportunity to characterize the drug's safety profile while avoiding the confounding effects of disease-related complications or sequelae of prior treatments. In earlier disease settings, drug effects of new therapies can be compared to established standard of care. Randomized controlled trials are less challenging to conduct earlier in the course of advance of metastatic disease due to larger patient numbers and identifiable effective treatments to compare the new drug to, factors which may be lacking in a more advanced setting. And earlier disease setting investigations have the potential to improve general outcomes. With the increase in the number of approved cancer treatments, there is a need to continually optimize treatment strategies for newly diagnosed patients with metastatic disease. While treatments in the frontline setting for many diseases may provide improvement in survival, better treatment options could also potentially replace current non-curative and often very toxic treatments. Project Frontrunner is an OCE initiative to encourage drug sponsors to consider when it may be appropriate to first develop and seek approval of new cancer drugs for advanced or metastatic disease in an earlier clinical setting, rather than the usual approach to develop and seek approval of a new drug for treatment of patients who have received numerous prior lines of therapies or have exhausted available treatment options. The goals of the project are to develop a framework for identifying candidate drugs that are appropriate to initially develop for the treatment of early metastatic disease, taking into account clinical, scientific, regulatory, and operational considerations. Facilitate engagement with drug sponsors and drug development to develop and implement strategies to support approvals in earlier clinical setting, and to engage and collaborate with internal and external stakeholders on related research, policy, and educational initiatives. Although there are innovations in the design of clinical trials in oncology, drug development continues to be expensive and slow. But this approach could be different, and some of these trials can be simplified. Although not generalizable to all clinical trials and mostly applicable to drugs or combinations of drugs, for which there is a breadth of experience and knowledge, a pragmatic approach with limited data collection may be used. An example of a pragmatic trial that shows how a close collaboration of multiple stakeholders, including academia, cooperative groups, NCI, FDA, advocacy groups, and industry working together, is the Pragmatica Lung trial. The Pragmatica Lung trial history started with data from a proof of concept trial, LungMap. LungMap is an NCI trial of precision medicine in lung cancer that tests multiple treatments simultaneously under a master protocol. Patients who enroll in the trial get a genomic profile to determine the mutations of their cancer. Based on those results, patients are matched to a treatment being tested on LungMap and randomized to the targeted therapy, if available, or the control. On the right highlighted, we can see the arm of interest. In this particular arm, S1800A, patients with non-small cell lung cancer previously treated with immune checkpoint inhibitors and platinum-based chemotherapy with progressive disease were randomly assigned to receive ramucirumab plus pembrolizumab or investigator's choice standard of care therapy. With a goal of 130 eligible patients, the primary objective was to compare overall survival using the long-run test with a one-sided 10% type 1 error. In the 136 eligible patients, the hazard ratio for survival was 0.69, which suggested that there was an improvement in the patients who got pembrolizumab and ramucirumab versus standard of care therapy. In addition, the safety profile favored the combination ramucirumab-pembrolizumab over the standard of care. The results from LungMap S1800A presented a unique opportunity to test run a pragmatic trial. Based on the promising survival data from the exploratory trial, strong safety data collected over years for both antibodies, and the need for effective treatment for these patients, the Pragmatica Lung trial was designed to remove many of the barriers that prevent people from joining clinical trials. For example, allows the participation of patients with lower performance status who are more representative of people with advanced lung cancer. The trial designers also cut out many of the extra tests, data collections, and secondary study goals, and only grade 3 or higher adverse events will be collected. Patients will be enrolled across the country, treated, and followed up in the same manner they would be in real-life settings, effectively integrating clinical research in the clinical care environment. Of note, although multiple stakeholders were involved, less than 7 months after discussions on trial design started, the trial opened for enrollment. To conclude, as we embark on a new, exciting era of clinical trials, the successes and failures of our experience should be applied to better serve our patients. I would like to acknowledge my colleagues for their insight, help, and providing slides. And once again, would like to thank you very much for your attention.
With that, we close our session. I would like to thank all our speakers, the chairs, and Stacy for organizing such a beautiful conference. Thank you all.
Thank you very much, and I am now happy to invite on the stage Lewis Roberts, who is a professor of gastroenterology at hepatology at the Mayo Clinic and runs the hepatobiliary cancer laboratory there. And he will give us a talk about the update on the GWAS project.
Thanks very much, Dr. Bracconi. So I'll share a few slides just to give everyone an update on the hepatocellular carcinoma genome. Oh, am I hitting the right? Okay. The hepatocellular carcinoma, sorry, not hepatocellular carcinoma, cholangiocarcinoma genome-wide association study. I think that's the wrong set of slides too. The slides from those are slides from yesterday. There's another set that I handed in this morning. Perfect. Good, good. Doesn't want the full screen. Should I just go ahead with it like this, or can you will it full screen? Yeah, perfect. Thank you. Well, first of all, I wanted to have this up there just to thank the many contributors to this study. I've listed here just people who contributed to what I'll describe as the discovery phase, which is the initial phase of this study that we have just about completed, and which I'll show you some of the data of. And yesterday, Dr. Younghan Han from Baylor College of Medicine, who is one of the bioinformaticians, statisticians working on that project, gave some more details about the study. So what have the objectives of this talk are to briefly review cholangiocarcinoma epidemiology and risk factors, and then talk a little bit about our efforts to understand the underlying genetics, particularly as it relates to inherited risk for cholangiocarcinoma. I'll describe as what we are trying to achieve in terms of genome-wide association studies as well as exome sequencing studies, and introduce the International Consortium for the Genetics of Biliary Tract Cancers, which is sort of the overarching framework within which we are doing this, as I described, initial discovery phase, and then what we are going into the expansion phase. So I think everyone's seen this, but cholangiocarcinoma we distinguish as intrahepatic or extrahepatic, has some well-recognized risk factors that we've talked about: the congenital choledochal cysts, biliary tract stone disease, primary sclerosing cholangitis, and liver fluke infestations, particularly in Asia. But it's important to highlight that most cases of cholangiocarcinoma have no known cause. Early diagnosis is difficult as well, and so from the overall cancer control perspective, prevention and then to the degree that we can achieve it, screening will be key to actually controlling this cancer. And this just is to highlight the distinction between intrahepatic and the extrahepatic, where we add perihilar to distal cholangiocarcinomas together. And the global epidemiology of cholangiocarcinoma then is actually quite variable. One of the challenges is that there are large parts of the world from which we have no data or very limited data. But where we have data, you can see that there are areas where there's relatively low risk. There's other areas with intermediate risk, and then areas, particularly in Asia, where we have quite high risk. And those tend to be areas that have high prevalences of either liver flukes or viral hepatitis, which is a significant risk factor, not only for hepatocellular carcinoma, but also for intrahepatic cholangiocarcinoma. And yeah, some of the risk factors, and so broadly thinking about them. And I think some of the themes, big themes in terms of the epidemiology, are that inflammatory conditions appear to be important. And we see viral hepatitis, liver flukes within that space. And then gallstones also appear to be important. And there are people who, because of lifestyle or potentially even their host genetics, are at higher risk of developing gallstones. There may be environmental factors that play into risk of cholangiocarcinoma. We've seen that particularly in relation to different types of toxins. And then we also have diseases that are associated with immune activation, particularly primary sclerosing cholangitis, and that has a strong association with cholangiocarcinoma. And in our minds, host genetics potentially plays a role, particularly where it might intersect with diseases like primary sclerosing cholangitis. There's a fair bit of evidence already about gene variants that are associated with risk of primary sclerosing cholangitis, but also variants that may, in general, be associated with inflammation. So in terms of understanding the genetics, cholangiocarcinoma genetics appear on the face of it to be complicated. We don't obviously have strong genetic links. So for example, there's a very low frequency of familial clusters. We actually heard about one cluster at this meeting where I think you'll remember there was a description of one of the advocates, and I think it was one of the donors who had a mother who also had cholangiocarcinoma. But that's quite uncommon for us to identify these familial clusters. Most genetic links have been attributed to risk factors. So primary sclerosing cholangitis, we know there's a body of evidence that suggests that there's gene variants that increase risk of PSC, and maybe those gene variants therefore increase risk of cholangiocarcinoma. Or there's gene variants that increase risk of gallstones and gallstone disease, maybe those would increase risk of cholangiocarcinoma. And I think the other thing is that most of the mutations that we find in cholangiocarcinoma are seen in other types of cancers as well, so they are not unique to cholangiocarcinoma. But on the other hand, we have this interesting distinction between the intra and extrahepatic cholangiocarcinomas, where we see that the genetic profile of tumors is different between an intra and extrahepatic cholangiocarcinoma. But really, most of the genetic studies that have been done up to now have been done in small numbers, and most of them have been with targeted panels of genes, where someone had a hypothesis that these genes might be associated with cholangiocarcinoma, and they did a small study in relatively few patients. And so what we embarked on a number of years ago, and I think this effort is about as old as the foundation, was at least as old as this meeting, was to begin this effort to see if we could do genome-wide studies so that in an unbiased fashion we can look across the whole genome to see if we can identify regions of the genome that are associated with increased risk of cholangiocarcinoma. And this is sort of genetics 101. So we start with chromosomes. You've all seen pictures of the cells. Actually, we have nice pictures in our Mutations Matter movies, where we have chromosomes. These chromosomes are made out of these long strands of DNA. Within the DNA, we have these genes, and we each have around 20,000 protein-coding genes and about 22,000 non-coding genes. So not all the important DNA really codes for a protein, which is most of our structural and enzymatic functions in our bodies. There's actually these non-coding regions that many of them make RNAs that also regulate other RNAs or protein functions. But we have these about 43,000, 42,000 different protein or non-protein coding genes. But these are located within about 3.2 billion bases. And so you can see the expansion there of the different bases. And the interesting and sort of fascinating thing about humans is that we are about 99.5% identical. All of us, we all share lots and lots of our DNA. These bases are the adenine, cytosine, guanine, and thymidine, or the ACGT, that you'll see often in these types of descriptions of DNA. And the key thing for us in terms of understanding genetic risk is that you can have changes from, in this case that I'm showing, from a G to a T, and in that case from the C to the A. So that at this particular spot, we all of a sudden have a variant. So some people have the one type, they will have a G, a C, and other people have the TA. And it's commonly the case that for many of these variants, they're actually fairly common. So you might say 80% of the people in this room might have a GC at one spot, and the other 20% have a CA. And so the common single nucleotide polymorphisms, or SNPs, are actually things that we see in more than 1% of people. And there's about 4.25 million of these. And then beyond that, there's relatively rare ones that we see in less than 1% of people. There's about 80 million that have been identified called rare SNPs. So SNPs are the most common type of genetic variant. They occur normally about 1 in 1,000 nucleotides. And like I mentioned, there's up to 5 million SNPs that are common in the genome. Most of them don't cause diseases. But there are variants within important parts of genes that can affect the protein's function, and that can include predisposing a person to development of cancer. So in the genome-wide studies, we study the DNA sequences to look for these SNPs. One of the strategies is to have chips that look at specific spots in the genome. So in the case of a chip that we're using here, we'll be looking at about 2 million different spots in the genome. When we do that, we call it genotyping. Another strategy is to look at all of the expressed regions, all of those 40,000 odd coding or non-coding genes. We can look at all of them, sequence them, and see if there's abnormalities in any of those genes. And when we do that, we call that exome sequencing. We're sequencing all the exons. And our goal really in this project is to do this with as many people as possible. And this is because when you're looking at lots and lots of different bases and lots of different variants, the likelihood that by chance you'll find something that's different is really, really high. So you need as many people as possible to make sure that when you find something, it really is meaningful. And these strategies we hope will allow us to identify common variants as well as rare variants that are associated with disease. And so this shows you an example. It's actually from a study that was for looking at kidney stone disease. But here's an example of a SNP that they showed a sequence variation. If we look in affected cases, I just use this as an example. There's 41% of the people on the affected side that have this variant that shows up in the red, we colored the people sort of red, orange. And then on the unaffected controls, there's only 13% that have this change. So we would do a simple statistical test to see is 41% different from 13%, and that's the p-value or the probability value we would get. But because we have so many different tests we are going to do, we run into the problem of what we call repeated testing. And so what you'll see here on the graph below there is that the scale on the y-axis, the standing axis, is actually negative logs to the base 10 of the p-value. So we actually end up looking for p-values that are really, really tiny, as significant in the case of SNPs. And that's because we have this problem of repeated measures. And you can see here there's the blue sort of column of dots there with a little red dot there that reflects this one particular SNP on one of the chromosomes. And on this plot that we call the Manhattan plot, because it kind of looks like the Manhattan skyline in New York, you can see each chromosome is lined up, the SNPs across all the chromosomes, and where they jut up is where we are seeing something that's significant. So who was Banfroni and what is he to GWAS? So Banfroni was a mathematician that was born in Bergamo, Italy, near Milan, and he actually did a lot of economic mathematics. But one of the things we learned from him is how to correct for this problem of multiple comparisons that we have. And so what we do is when we, instead of a usual statistical p-value of 0.05 that we use in a lot of our studies, when we do these multiple comparisons, we then divide that number by the number of SNPs, which means that it's a really small p-value that we're looking for. So I'll just describe very briefly here the initial results from the discovery phase. We ended up collecting samples from about 2,600 patients with cholangiocarcinoma, also did a parallel study with gallbladder cancer as well. And this is, most of our cases were from North America or Europe, most of them of European ancestry. The total number of cholangiocarcinomas we had was about 2,400. And this is the results of the initial discovery phase, where in all cholangiocarcinomas together, we had about 2366. We compared them to about 7,000 controls. And you can see that the thing that rose above the line of statistical significance was in the HLA region, which is related to immunity. That's where antibodies are controlled, the structure of our antibodies. So this tells us that immunity, inflammation, really important in this disease, and so in a sense, expected to see. Then next to it, we see something that didn't quite reach significance, but was really close, and it's a gene, and it's something that we'll have to explore now, what the connection of this gene might be to risk of cholangiocarcinoma. So we broke it down, looking more detail at just the extrahepatic cholangiocarcinomas. Again, a strong signal in the HLA region, but a different signal now that came up that's actually a non-coding gene that we see that is significant. So again, something to explore there. And when we come to intrahepatic, we see a few things that are suggestive, but nothing that reaches statistical significance, which is why I'm here talking about the expansion phase. Because when you go to the statisticians and you say, well, that looked really interesting, how come it's not above the line of statistical significance? They say more samples. And so that's what we've been doing today, is collecting, doing actually this conference, collecting more samples from participants. One of the interesting things we can do with this data also is begin to get a sense of what proportion of cholangiocarcinoma can be attributed to our genes. And from the studies we've done so far, if we look at cholangiocarcinoma across the board, at the SNPs that we've looked at, about 12% of the risk of cholangiocarcinoma comes from our genes. That is different for extrahepatic than it is for intrahepatic. It actually seems to be higher for intrahepatic, also higher if we break it down by PSC-related versus non-related. So more to come as we learn more about this. So we were recently awarded a U01 grant, and that's a cooperative grant by the National Institutes of Health. Our goal is to sequence 7,000 more samples over the next 5 years. We currently have expanded to about 82 sites, collaborators from 31 countries across really all the continents to really emphasize the global genetic diversity and increased representation in the cohort. And I know I'm rapidly running out of time. This is the map of where the current sites are. Here are the list of the sites. And if you would like to participate as a patient or family member or caregiver here, you can participate downstairs. That's available. And otherwise, if you're an institution like to collaborate, please contact me. We'll be really happy to include you. Thanks very much.
All right, now we're going to hear about the CholangioConnect initiative from the Cholangiocarcinoma Foundation. And we have Debbie Rose and Carla Boyden who are going to present to us. Debbie Rose is a 3-year survivor of intrahepatic cholangiocarcinoma from my hometown, Nashville, Tennessee. And Carla Boyden was diagnosed with HCC hilar cholangiocarcinoma in the spring of 2021. And they're going to come talk with you about the program.
Good morning. My name is Debbie Rose. I'm a cholangiocarcinoma patient from Nashville, Tennessee.
Hello, I'm Carla Boyden. I am a cholangiocarcinoma patient from Las Vegas, Nevada.
Carla and I had been friends for a couple of years now, but only a couple of days ago did we actually get to meet the first day at a conference. And we're going to share with you our story of how we connected. A few weeks ago, April the 1st, was my 3-year anniversary of being diagnosed with intrahepatic cholangiocarcinoma phase 2. This gives a new meaning to the phrase April Fool's Day. This was diagnosed by an incidental find dealing with persistent back pain. I had recently retired, and of course this was in the early days of COVID. It was determined my tumor placement prevented immediate surgery, And after testing, consults, and referrals, I began Genesis treatment at Sarah Cannon Cancer Center. Some of you may not know that Sarah Cannon is the real name of Minnie Pearl, who was in the Grand Ole Opry. She was diagnosed herself and was very instrumental in supporting cancer treatment. Thankfully, after 6 months of treatment, my tumor had shrunk enough to recommend my resection surgery in October of 2020, which was successful with clear margins, which makes me 2.5 years in ED. I only became acquainted with the foundation several months into my treatment, which became a game changer for me. I immediately contacted them, spoke with Melinda. She sent me a box of excellent folders, which I shared with my oncologist and the nurse practitioner, asking if they please have that on hand to share with any of their current patients or any newly diagnosed. I saw the slide yesterday, Stacey's slide, about how patients are referred, and the doctor referrals was way low. And we want to work to change that. Last year, my first attendance, I met a caregiver from Nashville, and our passion is working with the foundation to get the folders in the right hands and make it more available. As I begin to recover from treatment and surgery, I joined the patient Zoom sessions once a month. I viewed the streaming sessions of the 2021 conference. And finally, after seeing several notices of needs for mentors, I contacted the Cholangio Cadet Program coordinators. And while not feeling particularly qualified, I offered to serve as a mentor. Patty and Cindy offer so much information and encouragement to help get started. They truly have the gift of encouragement. Fortunately, one of my first assigned mentees was this young lady named Carla. From the beginning of our connection, she was so full of sunshine and optimism. Most of our visits and calls left me feeling uplifted. She shared how she was determined to continue doing the things that she enjoyed with her family, even making short trips. I was so impressed that she continued her regular work schedule, even with her treatments and appointments. This encouraged me that I should make efforts also to continue participating in the important events in my life. Buy the shoes, take the trips, and as a friend of mine encouraged me, I can actually start to buy green bananas. After about 18 months of becoming friends with Carla, I touched base again with Patty and asked Carla if she would consider becoming a mentor herself, and she can tell you more about that process.
Thank you, Debbie. Let me first begin with my journey. Started in May of 2021. I was diagnosed with stage 4 cholangiocarcinoma, also known as a Klatskin tumor. After the initial shock, I immediately wanted to know more about the diagnosis and what I defined as the 3 W's. The what is it, where is it, and why did it occur? Now, while I was in the recovery room, I had my cell phone. I was looking for information. One of the residents' physicians looked over at me and said, "Don't Google cancer, it will just take you down the rabbit hole." Well, with or without Google, I went down that rabbit hole because I was on search for as much information as I can find. However, as the days progressed, while originally being treated with Cisabraxane and multiple scans, I had less and less energy, and I was beginning to feel sorry for myself. Well, my daughter Cassandra suggested that I reach out to the foundation just so that I can get more information about what was going on with my cancer. But I was nervous to do so. Well, little did I know, I had to accept my new normal. I was nervous at first because not knowing what to expect of this diagnosis, it just really hit home, came to a point where, sometimes you feel like you don't want to go on or just know more and just, because like I said, of the new normal. Well, my daughter Cassandra, unbeknownst to me, reached out to the foundation for me, and I didn't know. Well, one day, as I was sitting around, I was talking with my family. My dad said to me, "Now, Carla, you have to continue to live, because life is to be lived." And hearing that reignited a spark within me to do the things that I enjoy doing. Well, one day, as I was sitting around checking emails, I happened to look, and I found one that came from the Cholangiocarcinoma website. And so while I was looking through the website, it said that I had a mentor. And that's when I learned that my daughter reached out to the foundation for me when I was telling her, no, don't do that, because, you want to know, but you don't want to know. Well, one of the emails I received was from my mentor, Debbie, and here's a snippet of what it said. "My name is Debbie Rose, and I am a fellow warrior who is glad to connect with you about this journey we find ourselves on. I'm interested in what things have happened since the diagnosis. I am interested to learn what your journey is like. I am glad to learn what I can from this Cholangiocarcinoma Foundation. Have you been able to participate in the patient Zoom meetings once a month provided by the foundation? I have not personally met a patient who has been diagnosed with a cholangiocarcinoma. I look forward to learning about your journey, and I'm happy to answer any questions about my experience so far. With hope, Debbie." Now, just one email opened up a greater sense that there was someone out there that can relate to what I was going through, and that I wasn't alone. I am grateful to be standing here with my patient mentor, Miss Debbie Rose. Through our shared experience, we have formed an unbreakable bond and friendship. It has also been an honor to be referred and selected as a patient mentor with Cholangio Connect program. I have now mentored for 5 months now, and I strive to encourage, support, and motivate all who are touched by this disease to keep moving forward and remind everyone you are not alone in this fight.
So today, if any of you here or those watching on the live stream have thought about giving back in some way, encouraging another person along your journey, whether as a patient or a caregiver, we encourage you to contact someone at the foundation, the Cholangio Connect program, about how you might support this part of the foundation. We've been told that the numbers of requests that are coming in are increasing, and there's always a need for mentors. We hate for them to have to wait. You may not think you're particularly qualified, but one of the best things you can do is to listen. I was raised in a family that was told you were created with 2 ears and 1 mouth, so you should listen twice as much as you speak. So if you're a good listener, that's a good start. You do not have to be a trained medical person. You do not have to be a social worker. But if you care about people, this is a good place to start. None of us choose to be a part of this club, but it is a win-win if you can connect and encourage another patient and also be uplifted yourself.
So in closing, I want you all to know I've been on this journey for 23 months and counting, and have been considered NED for the past year. I would like to leave you all with this quote: "Never lose hope. Tomorrow could be the day you've been waiting for." So in closing, Debbie and I would like to thank the Cholangiocarcinoma Foundation for the honor and privilege of speaking with you all today and sharing our story, and special thanks to Claire Condry with the Cholangio Connect Mentor Program. Thank you.
Right, welcome back to the afternoon. So we have 2 more fellow presentations. The first presentation is going to be by Kishore Pant, who's a researcher in Dr. Sergio Grattaloni's Laboratory of Cancer Cell Biology and Translation Research at the Hormel Institute, University of Minnesota. It also says Austin, USA. So Dr. Kishore is mainly engaged in the research of hepatocellular carcinoma, cholangiocarcinoma, and polycystic liver disease. Currently, he works on primary cilia-mediated regulation of the cell growth and cellular metabolism. And that is what he's going to present to us, the role of primary cilia and EGFR signaling regulation in cholangiocarcinoma. Dr. Pant.
Thank you. And My name is Kishore, as it's already introduced, and today I'm going to talk about our work in progress and the role of primary cilia in the EGFR signaling regulation in cholangiocarcinoma. Oh, okay. So cilia are an organelle found in almost all cells in the human body. They are microtubule-based organelle, and they are basically two kinds. And one is called motile cilia, which has main function to move the extracellular fluid around the cells or the tissue. And the other is basically primary cilia. It's also considered as a sensory cilia, which is found in the liver, skin, and other cells and other tissue. Okay, and our main focus is to study the role of primary cilia and its function in the cell growth and metabolism and other function in especially in cholangiocytes. So cilia is also primary cilia also considered as a cellular antenna, which found in the apical membrane of the cells, which extended out of the cell membrane. And cilia, primary cilia, which sends the mechanical, chemical, osmotic signals, and these signals are transduced further into the cells and which affect the cellular functions. So as I already mentioned, cholangiocytes, they also have primary cilia. So bile duct, if we zoom into this electron micrographs, you can see the cholangiocyte, the lining of the bile ducts. So they have cilia in their lumen, and which has several functions in the liver. So primary cilia, and what we have found that primary cilia is found to be either defective or lost in the cholangiocarcinoma as well as polycystic liver disease. And in our previous study, we have shown that in cholangiocarcinoma patients, the primary cilia is lost from the lumen of the bile duct. In same way, we also saw the in vitro samples also show that in normal cell there is a cilia. However, the cholangiocarcinoma cells, they lost their cilia. And in polycystic liver disease also, we saw that there is a report, they have shown that the cilia is lost or defective in the cystic liver disease cells. So what is common in these two cells? They both have increased cell growth as well as the increased EGFR signaling in these cells. So there is also several reports that there is increased EGFR signaling in both in cholangiocarcinoma as well as polycystic liver disease, and this can be a potential therapeutic target in the cholangiocarcinoma as well as the polycystic liver disease. So our focus is to study the role of cilia. Then we decided to study the role of mechanism and underlying the increased EGFR activity in cholangiocytes with the cilia defects. And we hypothesized that primary cilia can regulate EGFR signaling. So for this, first we prepared our animal models. We knock out IFT88 ciliary proteins from these animals, and we can see the cilia stain. And wild type animal, there is a cilia in the lumen. However, in knockout animals, there is a cilia is lost. We also use in vitro model. We use normal human cholangiocyte NSC69. We also deleted ciliary protein to make ciliary defective cells. And we use HU61 cells, cancer CCSL line, as well as to compare our results. Same way we use normal rat cholangiocyte NRC and the polycystic rat cholangiocytes. So first we check what's happened after we remove cilia from the cholangiocyte, and we can see that in the IFT88 cilia knockdown cells, there is a increase in enrichment of the EGFR signaling proteins. And when we check the protein expression, when there is increased EGFR signaling, either with the genetic knockout method or with the chemical desensitization method with the chloride hydrate. So which indicate that cilia defects can induce EGFR signaling in cholangiocytes. Next, we check the EGFR signaling, increased EGFR. So we found that the cilia defective cholangiocytes in these animals, there was an increased EGFR activity as well as the MAP kinase in these animals. So as we already know, as soon as EGFR is bind to its ligand, it's activated at this cytosolic side with the phosphorylation. Then it's recognized by the CBL protein. Further is lead to the endocytosis and ubiquitin, which leads to the degradation of the EGFR. This is in the normal process. This thing required for the EGFR clearance. And what happened when we treated our cells, cilia defective cells with the EGF in the time 1 minute to 2 hours. So we found that there is a increased sensitivity of the cilia defective cholangiocyte compared to normal cholangiocyte. In same way, we found that after 1 hour of treatment, the cilia defective cholangiocyte, they have increased EGF sensitivity and as well as the cholangiocarcinoma cell lines. Similarly, when we inhibited EGF alpha activity with the AG1478, the EGFR activity was decreased as expected. So we asked question why EGFR is more active in the cilia defective cholangiocyte. So for this we removed isolated cilia from the normal rat cholangiocyte as well as the polycystic liver disease cholangiocytes, and we used those cilia protein for the proteomics analysis. And we found that the normal rat cholangiocyte, NSC, they have increased EGFR in their cilia compared to polycystic liver disease cholangiocyte. And unfortunately, we cannot do this for the cholangiocarcinoma cell because they don't have cilia in their cell surface. So we also repeated this in the immunoprecipitation analysis. We see this EGFR which interact with the ciliary protein. So it is confirmed that EGFR can interact with ciliary proteins. And next we asked, so what could be the main reason? Like next we went to the check the endocytosis. We found the dinosaur which inhibit the mainly endocytosis process. We found in normal cholangiocyte that dinosaur which inhibit endocytosis, which restore the active EGFR after EGF treatments. But in cilia defective cholangiocyte, it has a little effect. So it indicates that this cilia defect may induce some delayed EGFR endocytosis. Next, we also use, after endocytosis, we also wanted to check the clearance of the EGFR from the cells. We use two proteasome degrader inhibitor. So we use these two for our experiment, and we found that in normal rat cholangiocytes and human cholangiocyte, there is an increased EGFR, active EGFR after treatment of the proteasome degrader compared to the, but there was a little effect in the cilia defective cholangiocytes. And then we asked what happened when we restore primary cilia in the cholangiocyte, what will happen to EGFR activity. So there is this in our lab we have been doing using HDAC6 inhibitor, which known to induce EGFR, which known to induce cilia restoration in cholangiocarcinoma cells. So we use either HDAC6 shRNA, tuberstatin A, ACY. These are the three different methods we use for the HDAC6 inhibition. And we found that these inhibition of HDAC6 induce cilia in cholangiocarcinoma cells. However, when we treated these cells, in normal untreated cells, the EGFR activity was sustained even after 2 hours and 3 hours in the cholangiocarcinoma cells. However, when we treated with the HDAC6 inhibitor, either ACY or the HDAC6, the EGFR activity decreased significantly in these cells. Similarly, we repeated this experiment in the rat cholangiocarcinoma cell BDNU, where we can see the tuberstatin A, another HDAC6 inhibitor, which decreased the EGFR activity in these cholangiocytes. Next, when we use these BDNU cells to prepare orthotropic rat animals, where we treated these animals with the tuberstatin A, we found these tuberstatin A induce cilia in these tumors as well as decrease the EGFR. And these EGFR as well as the cilia localized with EGFR. So, which indicate that the HDAC6 inhibition can lead to the EGFR clearance and the cilia formation. So we also found that this treatment of tuberstatin A inhibited the phospho-ERK and phosphomapanic activity in these animals' tumor as well. And so in summary, we observed that cilia defect can promote dysregulated EGFR signaling in cholangiocytes. and defects in primary cilia, which lead to the disruption of the activated EGFR clearance. And HDAC6 inhibition can induce primary cilia restoration as well as suppress the EGFR signaling in cholangiocarcinoma. So in future study, we are looking at the role of EGFR regulator like CBL interaction with cilia, how they can regulate cilia and EGFR clearance. We are also, which I already mentioned, HDAC6 linked with the cilia in EGFR clearance, as well as we are also now focusing on cilia-mediated signaling in EGFR and FGFR drug resistant cell lines to check on ourselves. And with this, I would like to thank my team and my PI Sergio Gratilonen and our collaborators. Thank you very much.
Great. And our next fellow presentation is going to be from Dr. Vindhya Vijay. Dr. Vijay is a postdoctoral fellow at Massachusetts General Hospital Cancer Center and Harvard Medical School. Her current work is focused on developing and characterizing patient-derived and genetically engineered mouse models to study various genetic subsets of cholangiocarcinoma with a focus on BAP1 mutant cholangiocarcinoma.
Thank you so much for this opportunity. Today I'm going to be talking about a subset of cholangiocarcinoma that's driven by the loss-of-function mutations of a gene called BAP1. So BAP1, or BRCA-associated protein 1, is mutated in about 20% of all ICCs. We normally see truncating mutations or deep deletions, which leads to ultimately leads to the loss of the protein BAP1. And when you look at BAP1, it is a deubiquitinating enzyme that belongs to the ubiquitin carboxyhydrolase family. Several functions have been associated with BAP1, the major one being BAP1 and its core complex can deubiquitinate histone H2, which regulates transcription of a majority of genes that are involved in cell cycle differentiation and metabolism. BAP1 is also known to regulate substrate stability, for example, in DNA repair factors as well as other cytoplasmic substrates, and can also directly regulate transcription when they're recruited directly by the transcription factors. And this is a mechanism that's independent of its deubiquitinase activity. So if you look at BAP1 mutant patients, there's a subset of these patients that have co-occurring actionable mutations in IDH, FGFR2, and BRAF. But there's this remaining set of patients that don't have any actionable mutations, which makes it really important for us to identify alternate strategies to target this subset of patients. So really going to this, we have two key questions. What is the oncogenic program that's unleashed by BAP1 loss within the liver? And by understanding this, can we identify molecular dependencies that we can take advantage of for treating BAP1 mutant ICCs? So a key challenge has been clinically relevant models. So we developed a genetically engineered mouse model by using a liver-specific albumin promoter to knock out BAP1. And we found that homozygous deletion of BAP1 resulted in significantly decreased tumor-free survival and also ICC, as shown here in histology. And when we acutely deleted BAP1 in adult livers, we found that there was significant increase in the liver size and also rapid cell cycle entry, as shown here with the Ki67 staining. So these results went on to show that BAP1 plays an essential role in maintaining quiescence within the liver. When we profiled these livers, what we found was that upon BAP1 loss, there was a significant increase in the lipid metabolism program, especially those genes that are involved in sterol, cholesterol, and lipid biosynthesis. The heat map here on the right is showing you the leading edge genes that showed the lipogenic signature. But importantly, when we looked at the patient data set, we found that at both the mRNA as well as the protein level, there was a significant increase in the lipogenic signature or enhancement of a lipogenic program in BAP1 mutant ICCs in comparison to other genetic subsets such as IDH, KRAS, as well as P53. In the last couple of days, we've talked about the importance of good models. So a huge ongoing effort in our lab has been to develop preclinical models or patient-derived cell line models that we've subjected to genomic, transcriptomic, as well as proteomic profiling. And what we've also done is functional genomics to create this atlas of biliary tract cancers, where we can identify specific vulnerabilities that are associated with different subsets of BTCs. So when we analyzed these models, it further reinforced the finding that the lipid metabolism is a significant feature of BAP1 mutant ICCs in comparison to other ICCs. So we all know metabolic reprogramming is very important in cancer. We've seen that these mechanisms are constantly altered by different oncogenes and tumor suppressors to handle the nutrient stress. One of the questions that we had was that these molecular programs or molecular circuitry that's altered upon BAP1 loss, do these mechanisms are these mechanisms required for continued, or do they have a continued role in established ICCs? And if so, do these mechanisms directly regulate lipogenesis? So we used a BAP1 deficient model, and we restored wild-type or fully functional BAP1, or a catalytically dead or a mutant version, which is a C91A BAP1. And we found that upon BAP1 restoration, there was significant decrease of cell proliferation. And this was specific to the BAP1 deficient ICCs, but not in BAP1 wild-type setting. And we also found this to be true in vivo, where BAP1 restoration resulted in significantly smaller tumors or no tumors at all. So these results go on to show that BAP1 has a continued role in maintaining ICC tumorigenesis. Since our profiling showed lipogenesis as a prominent feature of BAP1 mutant ICCs, we stained our cells using oil red O, which is a stain to visualize intracellular lipid accumulation. And we found BAP1 deficient ICCs, in comparison to wild-type ICCs, had significantly higher levels of lipid accumulation within the cell. And when we restored BAP1 levels, we found that restoring BAP1 levels was able to decrease these levels of intracellular lipid accumulation. And in contrast, when we deleted BAP1 in the wild-type setting, we were able to see an increase in the intracellular lipid accumulation. So these results show that BAP1 does play a role in functionally regulating lipogenesis. So we wanted to see what are the other what is the mechanism by which BAP1 was regulating lipogenesis, and we found that the transcription factor that was most highly deregulated upon BAP1 loss was SRBP1, which is a lipid metabolism transcription factor, and it's a master regulator of lipid metabolism. In fact, we found that the transcriptional program of SRBP was significantly suppressed upon BAP1 restoration, and we've seen that in our human cell line systems as well. And we also saw that the mRNA levels of SRBP1 and SRBP2 itself was decreased upon BAP1 restoration. Interestingly, when we looked at our functional genomic screen data, we found that BAP1 mutant ICCs were selectively dependent on SRBP. In fact, it was the top dependency that we had seen. And it was not only SRBP, but we also saw other members of its pathway, such as SED, which is a transcriptional target of SRBP1. And we also saw SCAP and MBTPS1 that are factors known to activate SRBP. So we knocked out SRBP1 in a BAP1 deficient as well as wild-type model, and we found that deleting SRBP1 significantly decreased cell proliferation in BAP1 wild-type, in BAP1 mutant cell lines, but not in BAP1 wild-type cell lines. And true to what we were seeing with the lipogenic phenotype that was observed in BAP1 mutant settings, SRBP deletion was able to significantly decrease or reverse this phenotype. So normally when we have these high lipid overload, what we see is that increased oxidative stress, which results in a form of cell death that's called ferroptosis. It's an ion-mediated form of cell death. And there are compensatory mechanisms within the cell that can offset this, such as increased glutamate uptake and glutathione metabolism. So one of the questions we had was that with this high lipid overload, how are we not seeing cell death? So we found that BAP1 loss resulted in increased levels of anti-ferroptosis factors, such as GPX4 and ACSL3. But at the same time, we saw a decrease in the proferroptotic markers, such as ACL4 and NOX4. So these results went on to show that there was not only high lipid biosynthesis that was happening, but this was accompanied by a protective mechanism that caused resistance to ferroptosis. So we tested this by looking at lipid peroxidation. So we used a dye that turned from red to green upon lipid peroxidation. And you can see that BAP1 restoration was able to significantly increase the levels of lipid peroxidation based on the green signal there. And when we used a redox scavenger, such as N-acetylcysteine, we were able to reverse this effect with the increased red signal that you can see. We also looked at protein carbonylation, which is another sign of oxidative stress, and we once again found that BAP1 restoration was able to significantly increase protein carbonylation, which goes on to show that upon BAP1 loss, what we see is high lipid overload accompanied by decreased lipid peroxidation and carbonylation, which means decreased oxidative stress and ferroptosis. So in conclusion, what we've seen is that BAP1 loss, part of its oncogenic mechanism is to increase de novo lipid biosynthesis via SRBP1, which activates its transcriptional program. And restoring BAP1 levels was able to decrease this and not only decrease the lipid load, but also increase ferroptosis. Now, why is this important? Because this really opens up a scientific rationale for testing inhibitors of the SRBP1 pathway for BAP1 mutant ICCs, such as SCD1 inhibitors, FASN inhibitors, inhibitors of the mevalonate pathway for this subset of patients. With that, I'd like to acknowledge my lab, starting off with my mentor, Nabil Bardisi, and a shout out to Lay, Lilian, and Ines, who've contributed to this work, and our terrific team out there at MGH. We also have a lot of great collaborators at MGH and Broad. And finally, I'd like to thank CCF, the patients and families, for a couple of things. One, the fellowship that has really helped support my work over the last year, but also all of these studies wouldn't be possible if we didn't have the right models to ask these questions. So thank you so much.
Okay, it is now my privilege to introduce a session about the patient-physician interview. I'm calling on the stage Professor Sahai, who is a medical oncologist at the University of Michigan in Ann Arbor, and Laurie Robertson, who is a patient who received a diagnosis of extrahepatic distal cholangiocarcinoma, and under the guidance of Professor Sahai, had access to a phase 1 clinical trial, which turned out to be quite a good success for our tumor control. Thank you.
Thank you for having us, and I'd like to keep this a little bit informal and just have a discussion between the two of us, if that's okay. We do have a couple of slides, and mostly for engaging you guys in the journey that Lori went through. And before we start, I just want to thank her for having the courage to come up and share her story. I'm sure this brings back lots of memories that she doesn't want to relive, and I apologize on behalf of both of us, but certainly look forward to you sharing your journey that perhaps even I'm not aware of some of the things you've went through and did not share with me, and hoping you can again go through some of these things for benefiting the patients, caregivers, and the physicians who are in the audience today. So thank you, Lori.
Thank you. Thank you for having me.
So, you know, I understand that your journey, Lori, really began in 2018, and I was not part of your care back then, and I understand that you had upper intestinal symptoms, and I'm hoping you can shed some light on what happened, what led you to the hospital, and what really happened next.
Okay. Well, I was otherwise a healthy 52-year-old female, with the exception of high blood pressure, which I inherited from my father, and generalized anxiety. I was working on Thursday, October 4th. You always remember your dates. And I remember complaining about epigastric pain. And I said, oh, I think I might be having a gallbladder attack. And my coworker said, oh, you would know if it's gallbladder. So I finished out the workday, and I woke up on Friday, and I was just sick. I was weak, but ironically, I had a physical scheduled with my internist. I usually go once a year, mostly to renew my maintenance medications. I'm really bad about going to the doctor, except for the physical. When I was a co-op in high school, I started working in the emergency center at a local hospital, and for the better part of 35 years, I've worked with the emergency center. And if you know that type of person, we just don't go to the doctor. So I went to my internist, and she took one look at me and said, you need to go to the emergency center. Well, I already know what that means. I really don't want to do that. But my son had driven me to the appointment because I was very weak. He drove me to my emergency center, and I was seen, had all of the lab tests. Ultrasound did confirm gallstones. So, of course, I got admitted for a simple gallbladder removal, but they did see stones in my common bile duct, so they recommended an MRI to confirm that before the removal. I don't know if you were here yesterday and you listened to Dr. Goldschlack's talk, but he talked about how on the weekend in a hospital nothing happens. And unfortunately, it was the weekend. So Saturday and Sunday, I felt totally fine. I was just waiting to have this gallbladder removed. But it wasn't happening. So finally, I got on the computer myself and I looked up the MRI results because I just wanted to know, like, what's gonna happen. If I'm not gonna have surgery today, that's fine, but I really wanted to shower. You know, I wanted to wash my hair. So kind of freaked out a little bit, figured out I'm not having surgery on Sunday. I do have stones in my common bile duct, so they scheduled me for an ERCP on Monday. I had the ERCP in endo, and it was a failure because my common bile duct was kinked. So they then scheduled me to go into interventional radiology where I had a PTC, correct?
Yes, and just for the folks in the audience, a PTC is an internal external drain, and I understand that the ERCP could not be done because the anatomy was quite challenging, and that was the only way to get the stone out. So.
Yep. So I had the PTC. I woke back up in the recovery room after my second ERCP, and the gastroenterologist said, you know, I didn't see anything. He removed some sludge, and that was it. But when I got back to my room, that's when everything kind of started to go downhill for me. So I started having episodic pain, 10 out of 10. It was horrific. It was very difficult. They called the rapid response team. They gave me, I think, morphine or Dilaudid. I'm not even sure. They thought maybe I had free air in my abdomen. They sent me back down for an acute abdominal series, which came back negative, and sent me back to my room. So this first hospitalization ended up being 11 days. I had a third ERCP because I kept...
And you had a gallbladder removal before that, as I understand.
Oh, that was before my third? Okay, I couldn't quite remember what...
That's okay.
Okay, so the first hospitalization, I had 2 ERCPs because I had a total of 5 by the time all was said and done. Okay, so I get the gallbladder removed. I'm discharged. I went home for 11 days, and you have to remember, I don't go to the doctor. So, like an idiot, I waited 11 days to see my internist for follow-up. And she drew some labs and called me the next day and said, you have to go back to the emergency center, you have high platelets, which I didn't even know what that meant. And guess what? It was Saturday. And I'm thinking, are you kidding me? I'm going back in on a weekend again. So my husband took me back to the emergency center. They admitted me, and I had another, you're gonna have to probably help me with this.
No, that's
okay.
So
I ended up having 3 more ERCPs. I was admitted for 11 more days, so 11, 11, 11.
Right.
The 4th ERCP. By now, my sister is absolutely freaking out and texting me, you need a second opinion, you need a second opinion. So I called my internist, I asked her for a second opinion. She was actually a step ahead of me. She had already brought in a second gastroenterologist who recommended a brushing, a biopsy, and she recommended putting a stent in. So I went down for that procedure, had the stent, and I felt a little bit better, and they sent me home. I still was, even in post-op, the gastro physician still said he didn't see anything. And he felt very confident that it was just inflammation that he was seeing because he had already gone down 5 times. So he sent me home. I still was not feeling good, and I just have never been this sick before. And by now, the wheels are starting to turn. I know something's wrong. Never got a call about my biopsy results, and no news is good news, right? So I only waited 5 days this time before I went back to my internist. So now I'm starting to learn. So I told her I haven't gotten the biopsy results back, and we thought that was a little unusual. So she pulled up her laptop. I was alone. I wasn't expecting to have anything but, just do this and we'll send you back home. So I was alone. She pulled up her laptop, opened it, and all I really remember is bright red and large words that said abnormal, abnormal, abnormal. And I said, oh, I do have cancer. I kind of knew. I knew something was wrong. So what's kind of odd is I work full-time for Michigan Medicine, and I was an administrative specialist for a department called the Clinical Trials Office. And I had just transferred 2 months. I had just left the Clinical Trials Office, and I had just started working for Precision Health. So I actually had worked with Dr. Sahai. He was on a committee that I would schedule, and I would beg him, like, oh, can you come on this day at this time? And he would always do it. So I knew who he was.
And it was a challenging thing to know a person beforehand, and that's the person you're treating. It's a very hard time for us as well, and especially because everybody knew Lori from day one. So as I understand, Lori, that you then transferred your care to University of Michigan.
Yes.
And the biopsy results were suspicious for cancer. They were not definitive. And of course, you met our surgeon, who immediately recommended that you undergo the Whipple surgery for removal of that. And if I can share the biopsy results,
Absolutely.
and I should have walked the folks through some of the MRCP findings that they identified. And then eventually, that's where the location was. And it was a little bit challenging from a physician's perspective. When you see mass in the pancreas, you are going to start calling it pancreatic cancer. And I think that was where we started was, hey, this must be pancreatic cancer. You've got a mass in the pancreas. And post-Whipple, there was a stricture that only originated in the distal bile duct. And so this was a distal bile duct cancer, not a pancreatic cancer, but that bile duct was traversing through that head of the pancreas. And so this is a very challenging diagnosis that is often wrong and missed. And so I think you underwent the Whipple.
I did.
There were a few complications. And if I can share the pathology results, the pathology results were T3, N0, so 22 lymph nodes were taken out, and none of them were positive, and all the margins were negative.
Yep.
I think it was a great surgery, and you took a couple of months to recover from that. There were a few complications, as I said before, and then we met for the first time.
Yep, I started chemo 10 weeks post-op.
Do you have any recollection of the visit that we had, and would you like to share anything?
So it is cliche to say that when you have a cancer diagnosis, when you meet with your doctor, you do smile and nod your head yes. I really can't hear anything that he's saying, but I know that I'm in good hands. And I always take my husband with me now, and he asks the questions, but I really do just nod my head and say yes. And like when I first started the chemo, I thought I had 6 weeks of chemo.
Right.
And I came in and I said, oh, so what happens after June 4th? And he's like, well, what's June 4th? And I'm like, my last chemo treatment. And he's like, who told you that? And I'm like, I don't know. He's like, no, it's 6 months. And I'm like, oh, you're
So
kidding
this is
me.
very true, Lori, for all patients. And I think after a few minutes of talking with a physician, you stop listening. It just
You
doesn't
can't hear
process. And I think this is very, very big to note that you need caregivers by your side when you go for the appointments. You need that extra set of ears. In fact, 10 minutes after the conversation, you'll start sharing notes and you're on a different page already.
Yep.
And so please ask if your provider would allow recording conversations. Many of my patients do, and I'm very much open to it. And the second pair of ears are always helpful. And so Rob's in the audience, and he was just fantastic and always kept you grounded and,
Yep.
Look at the next step ahead of you than to think, what's going to happen a year from now and so forth. So I gave you my poisons, and
They were tolerable, though. They were very tolerable. I worked full-time the whole time.
You're just being nice.
No, it was tolerable.
I remember her describing a hand-foot syndrome, which is quite known side effect for folks with capecitabine. And you did not complain to me, but I think you complained to Rob quite a bit.
So I did have hand and foot syndrome. Part of my issue, again, because I don't like to go to the doctor, I just kept saying, well, it's not as bad as the Whipple. So even though my feet were swollen and my skin was dying and they were peeling, I just kept thinking to myself, well, I mean, this isn't as bad as the Whipple. But then we finally did disclose it, and he lowered the dose. So I would recommend you always have to report your side effects, no matter how silly you might think that they are, whether it's a fever or swollen feet.
And very, very important to have a free and open discussion with your provider. And if that provider is not having that discussion with you, there's something wrong. You need to probably call somebody else. With that, I think you went into surveillance, and
Yes.
we started doing scans and labs and visits every 4 months.
4 months.
And we continued that for up to 2 years.
Two and a half.
2 years from the end of chemotherapy.
Okay.
Sorry. And
I was thinking from surgery.
our surveillance time starts from end of all therapy. So we recommend 5 years of scans at intervals depending on what the pathology was and what is the risk of recurrence. And so based on that, 2 years into surveillance, one of the scans I had to deliver some bad news to Lori. And essentially, we found a nodule that was identified in the peritoneum, which is essentially means the abdominal cavity. And it's really subtle on there, but it was caught on the MRI. And I don't, again, recall if you have any thoughts to share from that meeting, if you remember anything.
So that was complete shock. Post-Whipple, I never thought about cancer. I did not have anxiety that it was coming back. I think it might have been naive of me. We didn't talk about statistics or anything like that. It wasn't coming back, and I was great. We were having our lives. My husband and I took our kids to Alaska. We were hiking. I felt really strong. I actually had commented like, wow, I'm not the weak link that, I thought I was last year, and I felt great. Came home, had the scans, and it was just absolute shock. And then we met, and it was not a good prognosis. And then I really fell into deep despair, anguish, very bad depression. So thankful that my family, my friends, especially my husband, pulls me through that. And so we start, we meet, and you mention a clinical trial.
Yep. So we talked about all the options, right? And that was not a good conversation. And it was very sad and emotional for both of us. Nevertheless, we got through the options, and I don't know how, but you ended up selecting the option for a clinical trial, and I still for now don't know why you did that. I don't know if there was something specific about that, or you just wanted to be part of something that would take you beyond standard of care.
So I may not have ever shared this with you, but a couple of weeks before my scans, I had two friends that still work for the clinical trials office, Kate and Carrie. And Kate and Carrie independently had texted me and said, oh my gosh, I'm sitting in this meeting and there's this great clinical trial and they're having great results and this person is like NED at 52 weeks. And I was like, oh my gosh, that's great, that's crazy. And that's the clinical trial that I ended up on.
So you should not have had that insider data.
Pretend that I did not mention Kate and Carrie. Shh. Schmate and Schmary told me.
So I had no idea about this.
Oops. Oops. Oh no.
So we were in the midst of the phase 1 trial, Lori, at that time. We had enrolled 19 patients in the phase 1. We needed 20 patients, and the 20th slot was assigned to another site and was already called for. And that 20th patient, unfortunately, was a screen failed. That means they did not meet all the criteria. So unfortunate for that person, very fortunate for Lori, because we immediately called her up and said, we've got a spot for you. And I don't know if you have anything to share about the trial and the journey and the therapy that you received.
So you have to remember now, this time around, the anxiety is DEFCON 10. Even, you know, like accessing my port, I was just a hot mess. I really was. I was a hot mess. I felt really bad for my chemo nurses because I just wasn't the same like happy, bubbly person. I didn't want anybody talking to me. I just wanted you to get the drugs and get me out of here. And it was a 12-hour day. It was every Monday. It was a very, very long, exhausting day. The side effects from the chemo, again, fatigue, some nausea. I did work full-time still, but I also have a managing director who is so extremely supportive that if I needed to go take a nap, I would take a nap. Or she might see me and say, go home. You know, she just was fantastic. And chemo brain, for sure, I have this time around. Oh, and then I did lose my hair.
Another reason to have another set of ears. It's very hard to multitask and to remember conversations.
Chemo brain, I don't know if it's, I think it is part of the chemo and all the anesthesia, plus probably a dash of menopause. So I cannot get my words out sometimes.
Fair. And then we started, of course, monitoring your scans. And with the first scan, I think there was some ray of hope. The tumor lesion had shrunk already within 2 months by 53%. There were 2 of these lesions. I'm just showing one of them. But there were 2 nodules that were identified in the abdominal cavity. And this was biopsy-proven recurrence. So within 2 months, there was a significant improvement. And I think that brought so much joy to you. I remember you and Rob just completely exhilarated with the knowledge. And I think that was the time where we took your case to the tumor board and said, you know, listen, we've got this young person and we need to do something different. We cannot just fold our hands and say that this is a recurrence and it's outside the area where it started and we cannot do more. It has to be another thing that we can offer. And kudos to Lori, because simultaneously she did her research. It was so funny. We came to a meeting, and Lori's like, I want to take these nodules out, and I want this thing called HIPEC. I just stare at her. I was like, Lori, we already talked about this at the tumor board. It was raising hair on me. I was like, how did you know this? You've really got insider information here.
I have very good friends. I have very good friends.
So the tumor board decided that we are going to take a chance, and because of the exceptional response and the low amount of disease that she has in the young age and good performance status overall, so we, of course, recommended to complete 6 months of chemotherapy to assess the biology of the disease, that it is not very aggressive, and if not the case, we are going to take these nodules out. And I think that made your day.
Yes, that was really what Rob and I had been fighting for, was HIPEC. That was my end goal, was HIPEC. I had learned about HIPEC from two different friends, Nancy, who's a dietitian, and then a man named Bob Granata, who was diagnosed with appendiceal cancer and has done great works trying to get awareness out for HIPEC. HIPEC, I felt like that was going to be my best option for longevity. So, I mean, the options were be on chemo for the rest of my life or try to have this HIPEC surgery, which isn't normally for our types of cancer. HIPEC is usually for colon cancer, appendix cancer, and ovarian cancer. So I was kind of a unicorn wanting it. But
lo and behold, I mean, we had 6 months of therapy.
Yep.
There was no evidence of disease. We call it a complete response, 100%. And we took Lori in for surgery.
Yep.
And I mean, she did well, and they found the 2 nodules. They took them out, and she got the HIPEC, which is Lori just talked about, which is heated or hypothermic intraperitoneal chemotherapy, completely unusual and no data for biliary cancer. But that's we just can't look at the guidelines and say that's all we can do. We need to take that extra step. We need to think ahead. So Lori's a case in point, and she's done extremely well after this. In fact, when the pathologist looked at it under the microscope, that's all they could find. So we call as a near complete response. There was only one focus of cancer that they could find in there. So almost complete response, both on scans as well as on pathology.
recovery from HIPEC was much easier than the Whipple, but a true HIPEC would have had organs removed, where I only had the tumors removed. Whereas with the Whipple, like 40% of my pancreas was removed, my gallbladder was already gone, my bile duct was taken, part of my small intestine, part of my stomach. So the HIPEC recovery was much easier. I also walked like a maniac. The second I could get up from that hospital bed, Rob and I were walking laps around the unit. When a new nurse would come in, she would even say, "Oh yeah, we saw you walking, we saw you walking." I just kept walking. I think walking is key, both pre-surgery, if you can, if you're strong enough, and post-op, you gotta walk, even if it's just down the block and back, or just around your house. Walking is very important.
And you've been a warrior throughout, but especially when you went through that phase, you were like, I'm absolutely not looking back. This is it.
It's, again, I have very good friends. My friend Al Rocchini, he's a physician. He had colon cancer in his 40s, and I called him one day just freaking out, and he said, you know what, I just live by the mantra, it's nothing until it's something. And he said, I'm crabby on scan day, but then I'm not giving cancer 1 second of my life until I have to. And I thought, gosh, you know, that is, I'm doing that. And I committed to it. And sure, I have some off days, but for the most part, I am just so blessed that I have a third chance. I mean, you've saved me twice now. Do I think round 3 is going to come? I don't know.
Absolutely not.
And I am not, but I cannot dwell on it until that day comes. And so every time I get a clean scan, I book another trip. Rob is starting to say, like, where are you getting this money from? I'm like, don't worry about it, honey, don't worry about it. It'll come later, don't worry. But every time I get a clean scan, which they're coming up in May.
And there is a lot of scan anxiety.
Yes.
I don't know if you want to talk about that, but I know you look up the results before you come to clinic.
I try not to.
But there's a lot of scan anxiety.
Scan anxiety does definitely exist. I usually do go alone. I'm usually pretty good on scan day, but since the reoccurrence, I think there is more anxiety for me. It used to be, I think when you had a positive result, the test result would not pop into your portal, and now I think they do pop. And that's how I found out I had the reoccurrence. I was getting my hair colored, and it popped, and everything had been great. So I just looked at it, and I was like, what? This is saying I have cancer again. How can this be? I'm getting my hair colored. So
That's an unfortunate
I try
part.
not to, but
we cannot block the results anymore.
I wish
So-
you could.
Right, right. So, yep, all the results are immediately released to our patients. We cannot delay it by a second. And that is, the only results that are delayed are the pathology or the biopsy results that need to be given by the physician. So we are 1 year out,
Yes, 2/28, 2022 is my HIPAC.
and how are you doing now?
I feel great. I feel great. Back to traveling.
You already have your next trip planned after the scan.
Next month, we're actually coming back to Utah. We're hiking the Zion and the Big Five. But yeah, I think this is important that cancer has brought many, many blessings along with the bad. You know, Rob and I, there's just no petty arguments. Even when he's yanking the covers off me at 3 o'clock in the morning, because he sleeps like a feral bear. But there's no pettiness, and
you've got a lot of friends too.
I have a great
huge amount of support.
My daughter Caroline says I have a fan club.
Right.
So I do have a fantastic support group, but I couldn't do it. Oh, my neighbor Diane, when I had my reoccurrence, she had these heart LRs made, these signs. I got up right around my birthday, and they were all over my street, all over my neighborhood. It just, my support system, I'm telling you, you can't do it alone. You really do need other people to be there with you, for sure.
Thank you for sharing your story today,
Thanks
Lori.
for having
I
me.
hope everybody's gotten some positive vibes, and you know, we want everybody, of course, to do as well as Lori. And there are folks who are unable to get surgeries and so forth, but I think if you take anything from this, Lori and Rob have been champion. They've done their homework. They've talked to us. They've been very open. We've, of course, shared a very phenomenal relation over the past several years now, initially as colleagues and now as a patient and provider, and now hopefully back to colleagues.
And friends.
And
Hello.
friends.
How soon he forgets.
Well, thank you again, Lori.
Thank you.
Yeah.
Thank you.
So the next presentation is going to be going over exciting clinical trial prospects, including a actively being developed platform trial. We're gonna have Dr. Mitesh Borad and then Meredith Buxton from GCAR are both going to speak. Are you speaking together or coming up one at a time? One at a time. Dr. Mitesh Borad.
Okay, well, good afternoon. Thanks to the audience for hanging in there on day 2 with such tremendous enthusiasm. This is definitely my favorite conference of all the hundreds I've been to. It's probably the only one that has direct patient engagement, and that's so incredible to see. So on behalf of a very large team, I'd like to provide some updates on the International Cholangiocarcinoma Research Network. Next slide. Okay, so this network was formed at this conference about 7 years ago due to a fortuitous discussion at a coffee break. And just a word of caution, only give Stacy ideas if you're prepared to work on it, because so a need was identified, given that it was felt that this was a somewhat less common disease, that we would want to work together across centers, across investigators, across researchers, across the world to, as the mission statement says, rapidly translate discoveries into practice so that they can start benefiting patients. And we would need a facile, agile, collaborative network to accomplish that. So you can see that it has lived up to its name. This is very much international in nature. We do have to get to Australia to get to all the highly inhabited continents, but otherwise you can see that it does have a fairly significant global presence across the very many specialties that patients get their care through. You can see that there's engagement across many, many countries. We have representation here at this conference that mirrors what you see here in this network, both at the level of researchers, but also at the level of patients. So thank you for all of those who came from great distances to be at this meeting. Over the years, while we were initially a bit more nimble, we felt that it had grown to a point where it may make sense to try to provide some additional structure to the network. I'll go through some of the committees that have emanated as a result of this, and you can see them highlighted here. I'll go through sort of their functions one by one as well. So of course we want to continue onboarding new members from areas of the world, from parts of the country, so that patients ultimately have someone local that they can turn to who is engaged and knowledgeable about the efforts. To facilitate that, of course, we would have a membership and communications committee. This committee is also tasked with all kinds of communications, not just with colleagues, but also with trainees, with the media, and most importantly with patients, their families, and caregivers. There's a Meet the Expert section on the webpage, which may provide you the bios of people who have been engaged in this field, like Dr. Sahai and others you've heard from, who have spent their entire careers caring for patients who have this illness. The Scientific Programming Committee would, of course, be tasked with organizing conferences such as the one we have here right now. But besides this conference, you can see that there are many other events, including an event we've done in the Asia-Pacific region for many years. You can see the first couple that occurred there that were in Thailand, and then over the years in Taiwan, Korea, Japan, and other venues. We also have, of course, ad hoc meetings at conferences that other societies organize, and the foundation has been extremely active in making sure that there's a meaningful presence there as well. Last year, we put together a think tank called C²T², Cure Cholangiocarcinoma Think Tank. And the purpose for doing this was to stop trying to make incremental advances. We wanted to be able to come to you here every year and say we've made more tectonic shifts. And we weren't going to be able to do that just by the community we already had in place. And as such, C²T² was an opportunity to put together domain experts in this community, along with people who had developed platforms or other technologies and were sort of outside-the-box thinkers to see if we could apply it to make advances in cholangiocarcinoma and at a more tectonic level, not incremental. So shown here is a group photo of the inaugural think tank. Hopefully we continue this on a regular basis, and hopefully we don't have too many of them so that we can bring these ideas into advances that can be used in everyday practice to help patients on a significant scale. Two themes had emerged from this meeting. We used precision medicine as our anchor, and you've heard a lot during this meeting about precision therapies and biomarkers and drugs that would hopefully be less toxic and the right ones for the right patient. But we also recognize that we will make much bigger advances if we also have a significant effort in early detection. So you can see precision, early diagnostics, and prevention was a critical theme of this meeting, in addition to therapeutics. I'm very delighted to mention to everyone at the conference that from the generosity of the many donors to the foundation and other funding sources that we were able to garner, we have been able to fund both of these efforts, and they have already been launched and work is underway. So we're trying not to waste even a single day when we want to make these advances. Okay. The Industry and Biopharma Committee, of course, has been very instrumental in engaging with our colleagues and partners in the pharmaceutical and biotech industries. They have been wonderful colleagues with us to align our mission to fit the mission with biopharma to help patients so that we can have advances again on a consistent basis. And as was highlighted in the very first talk by Stacy, as the conference was open, now we have 5 therapies that we didn't when these efforts were first underway. A new model was developed as part of this. Many companies engage people from the community to provide them with advice on how to best develop their therapies, and typically this is done through advisory boards. So through, again, a very generous action taken by the members of this community, people felt that we could donate these proceeds towards the efforts of the kind I just showed, and instead of that money going into things where there wouldn't be direct benefit to the research community and ultimately to patients, we were able to raise funds that we would have otherwise not been able to. So again, I want to thank everybody who took this initiative and for this kind generosity to make this happen. So $100,000 was raised last year, and that went to the projects that I just showed from the cholangiocarcinoma think tank. There has been a lot of interest from the biopharma community. I think when Stacy, as Stacy mentioned, when it was the early days, this slide would be totally empty. Even if you tried, even if you paid for dinner yourself, you couldn't get them to come. So now things have certainly changed, and we're very appreciative of all our colleagues in industry for thinking of this patient community and wanting to make a difference. We've had industry forums like the ones we've had at this meeting, where we can leverage the presence of experts that come from all over the world to this meeting and allow for colleagues in industry to get guidance on the best way to develop their therapy. So this has very much become the destination for patients, researchers, and biopharma to come to try to make a difference. We, with COVID, also leveraged sort of the power of Zoom and the internet to do virtual advisory boards. This has also been a tremendous cost saver, and more biopharma partners are using this mechanism to run their advisory boards. We have a data committee, which means there's a lot of data. In fact, it's not just big data, it's huge data. And a lot of this data is not just sort of demographic and clinical data. As genetic and genomic analyses are being done, a tremendous amount of data is being generated from each person's genome, from their contributions, in order to make meaning of this data so that it can help other patients. We are hoping that this committee can engage the right folks, both internally and externally, to convert this data into knowledge. The career growth, education, and engagement of the next generation is absolutely critical. And as highlighted in many previous talks, and from the generosity of donors, both small and big, keeping the next generation engaged and growing in this arena will be critical in order to ensure that we maintain the momentum, that we have the advances, and hopefully the huge successes we're looking for. We've been very fortunate to partner with our colleagues in Europe in this regards. So the European Network for the Study of Cholangiocarcinoma, ENSCA, has been a tremendous partner. We've had a mentorship program with them. We've had a Meet the Emerging Leaders program as part of our collaboration with the Communications Committee. All the research fellowships and other initiatives have also, again, helped advance the careers of these folks, but more importantly, keep them engaged in helping patients with cholangiocarcinoma. So again, thanks to everyone in the audience as well for this. Dissemination of knowledge is critical, and preservation of knowledge is critical. So a few years ago, we felt that it would be an exciting endeavor to have experts come and give webinars, not so much in a lecturing fashion, but in an engaging, as Stacy likes to say, fireside chat format, where there's significant discussion between the speaker, the moderator, and the audience. And there are a series of such webinars listed on the website, again, for the perusal of anyone who may want to learn specifically about a nuanced or general topic for cholangiocarcinoma. And we hope that this will just become an ever-growing collection that serves as a source that can be disseminated everywhere. With all the generous donations folks have made, grants can be afforded to both the emerging generation and folks who are sort of in that mid-career range and senior investigators. Largely we're focused on the new generation, but the time and generosity of the Grant Review Committee ensures that the best science, the best ideas are supported in the fairest way and in the most transparent manner. And this would, of course, be very critical to how the foundation is perceived and to ensure that there's confidence amongst the many donors who support these efforts. You can see that there's been far and wide reach of the funds that have been generously allocated, and this has been highlighted earlier today. I want to talk about a new model briefly. So most clinical trials are somewhat patient-centric, but truly they're drug-centric or biopharma sponsor-centric, and to some degree investigator-centric. There's always this feel that, oh, that trial's done, so-and-so is leading them, they'll come here or elsewhere to present them. That isn't the purpose of the trials. The purpose of the trials is to provide early access to patients so that they can have an advantage in beating this illness. As such, what I show here is the collective work of a huge number of people, and this is a patient-centric model. We have all kinds of things available in the same model, where targeted therapies are available, drugs that don't require a biomarker are available, something for patients who have resistant diseases available, patients who need their first systemic treatments is available. So it's all in a single model, and we're hoping that this becomes a way in which industry will engage with patients, and that we think of the patients first and not last. Okay, again, I want to thank everyone for their attention. I want to give a big shout out to Nilo Azad, who's been my co-chair in this journey the last few years. Also want to thank Stacy, Riham Abdel Wahab, Wendy Seelig, Ash Patel, who just joined, and the entire executive committee shown here for their hundreds and hundreds of hours of selfless dedication to ensure that everything I showed can happen. Thank you again.
Hi, everybody. First, I want to thank Stacy, oh, there she is, and the Cholangiocarcinoma Foundation for the opportunity to present here. You got a little peek at the master protocol that I'm going to share with you today, but I wanted to just start to get you excited about how you can contribute to these kinds of efforts to support advancements in the space. I've been in the master protocol space for about a decade, but we continue to see advancements in the field. And over the last 10 years or so, we've seen movement from screening trials to drug registration trials and using these models to support those activities. And we want to apply that here. We want to take those learnings and help the patients with biliary tract cancers. So I thought before I started it'd be helpful to understand who we are. So GCAR, Global Coalition for Adaptive Research, is a nonprofit organization that leads the development and implementation of master protocols. And you heard a little bit about it this morning from the FDA as a type of innovation to support some of the challenges in clinical trials. So we serve as a trial sponsor, we serve as an IND holder, and we really try to facilitate these efforts on the behalf of the community. And by that community, I'm talking about the group on the left, the scientific leadership, pharma and biotech and industry, as well, and most importantly, the patients and the patient organizations. And then working close in collaboration with the regulators to ensure that these meet the needs to support the development and advancement of new drugs to bring to patients. And again, we are here to facilitate and convene these efforts. We don't consider ourselves experts on the disease. We consider ourselves experts on helping you to implement these efforts to support the patients. So today what I wanted to do is spend some time going back over, I know we heard some of that this morning with the speaker from the FDA, on the current challenges with clinical research, then dig a little bit more in detail around the utility and value of master protocols and really understanding how these benefit the patient, the clinician, and even the pharma, the biotech community, and then show you a little bit more about the master protocol, the BTC master protocol. What you saw there is already adapted a bit, and it's evolved a little bit in how we've been thinking about it over the last couple of days. We've had the great opportunity to meet at a lunchtime forum today with many clinical investigators and already start to think about how to further improve it. And then discuss next steps and how the community can get involved and how we need your involvement as clinicians, as patients, as advocates to help us move this effort forward. So we all know that drug development is a long and costly process. I'm sure you've heard this before, that there are thousands of drugs in development. It can cost billions of dollars and take many, many years. And very few oncology drugs actually ultimately get approved. And while we consider randomized controlled trials as the gold standard, they can be slow, they can be inefficient, limited in the questions that they address. In a lot of cases, that can impede the development and timely delivery of new devices or agents for patients. And then when we start to think about our understanding of the biology of cancer and the fact that we need to be doing trials to look at more focused groups, we really understand that we need better trials. And so what master protocols are they are an opportunity to build an infrastructure once and use it many times. So the example we often use is if you were to, let's use the Utah Jazz. If you were to play a basketball game, you wouldn't build a stadium every time you played that game, tear it down and build another one for your next game. You would build it once, as they do, and use it many times. And that's really what a master protocol does. So it is a collection of trials that are, or sub-studies that are an infrastructure that's built once, and it shares a lot of the same, shares design and operational components that are better coordinated than if you were to do them all separately. And you may have heard some of the terms. Master protocols are applied to platform trials, umbrella trials, and basket trials. So in terms of the different types of master protocols, there are umbrella trials where we think about multiple different targeted therapies in the context of a single disease. basket trials, where we're now talking about a single targeted therapy in the context of multiple diseases or disease subtypes, and then platform trials, where we think about an infrastructure that's built and where we're studying the disease and many therapies in the context of this infrastructure, where you can have therapies enter and exit at different times based on a decision algorithm. And that decision algorithm can include a Bayesian adaptive design, where you're understanding and updating the probabilities of assignment to a drug based on how other patients have performed. So what's the benefit? Why would this be a value to patients and to the patient advocacy community? Well, they're often built to allow you to have access to multiple investigational options, rather than a traditional trial, which may be a one-to-one randomization to standard of care, which may or may not be performing particularly well for particular diseases. It gives you increased opportunity to have access to investigational drugs. They're really designed by the patient and the advocacy community. We've been working closely with the Cholangiocarcinoma Foundation, and so it's disease-centric. It's not drug-centric, it's not company-centric, and so it's really informed by the patients, their caregivers. And so you'll see in these kinds of efforts opportunities to have crossover from one treatment to the other, to be re-randomized if the drug isn't particularly performing well. And so that is often really encouraged by and pushed forward by the patient community to allow that happen. It also, in a lot of cases, provides more accelerated outcomes. And so we can learn quickly in some of these designs. Failing fast is important. Knowing that a drug is not performing well and moving on and testing other drugs and doing that quickly is just as important as moving drugs faster to the market. And we've heard here through the mentorship program, through other opportunities, an interest in giving back to the community. And again, it provides a pathway, if you are a patient on these efforts, to continue to support and improve the standard of care for other and future patients. We also want to make sure it's beneficial to the biotech and pharma community. We want to make sure the exciting drugs make their way, and the ones that you all want to see make their way into these trials. So again, we build these infrastructures, and for the companies, the work is done for them. It's really designed to be a plug-and-play model. And that makes it sometimes easier, faster, and cheaper than if they were to go it alone. We have a global effort to support patients with glioblastoma, and we see that the cost of a drug to be studied in that trial is about 1/3 to 1/4 if a company would do it themselves, and we are enrolling at 4 times as fast as traditional trials. So we create an infrastructure to shorten timelines. We can use it for lots of different development opportunities, screening, approvals, and we hope what that does is it encourages more interest in the space. And we have seen that in other disease areas where we've seen more interest of companies to test their drugs in these rare diseases. It also is an opportunity to be innovative. We know, and we heard this morning from the FDA, that there is regulatory interest in these approaches, that they do see it as a way to overcome some of the challenges with some of the traditional randomized controlled trials. And it allows us to really target specific aberrations, and also, if there is benefit, to move these forward and get approvals. And finally, I think there's a great value to our clinicians and researchers. It creates a clinical portfolio in one platform. So for the clinician, there's less bias. You're not pushing patients to trials where you think a drug may work or don't really know. It really, the trial is helping you to decide and give patients lots of options. It allows you to rapidly evaluate potential new therapies, to get that opportunity to get that commercial level rigor to support new approvals, so you can see these drugs move in faster. And it also gives our clinical community leadership opportunities. Again, I said we are not the clinical experts when we run these efforts. We really lean in on the clinical community to support these and to decide what are the questions that want to be asked. And so they serve as leaders in the effort. We bring in junior faculty to be co-leads. There's authorship and academic credit opportunities, and an opportunity to interact more broadly among the international community. And finally, it gives you an opportunity for a continuous learning model. We've talked in, and we'll show you, I'm getting to the trial, which I know you're eager to see, but we've talked a lot about opportunities to continue to collect data to do continuous learning and for the community and to share that data with the community. So we know that the challenge here is there, as we see in other rare diseases, there's biological factors, there's trial factors, and we really do think that this really gives us the opportunity to study multiple experimental therapies simultaneously, to increase the opportunity for access to new treatments, to create an infrastructure to limit downtime, to enable institutional knowledge and learning so we don't recreate the real. We don't build that stadium for the Jazz every single time. And so create a turnkey solution for companies, for patients, for clinicians. And that's what we're hoping to do and apply all that learning here in this space. And so the plan for the master protocol is to provide more opportunities for patients to be who participate to be assigned targeted therapies, and to allow for multiple rare aberrations to be studied simultaneously, and allowing new investigational therapies to be added at any time. So arms can enter and exit at different times, led by the key opinion leaders in the field, and you'll see the leadership that's already come together to work on this, and working closely with Stacy and the Cholangiocarcinoma Foundation. We really came together a couple of years ago to try and solve the issue of enrollment, patient enrollment on a trial, and really came to the realization that this is really what the community wants to see to try and move forward and advance treatments in the space. So we already have added to this list. So we've adapted a bit, we've grown. We had the opportunity at a lunch forum today to sit down with many of you and talk about what else you would like to see in the trial. We're going to continue to have those discussions over the coming weeks, so we encourage you to reach out to us if you want to participate in those. But again, wanted to acknowledge the leadership, the clinical leadership who are really driving this effort within your community. So Mitesh showed you a slightly different version of this. We spent some time last night and today moving and advancing this and refining it, and we'll continue to do that over the coming weeks and months. But again, it is an opportunity at first to look at progressive or recurrent disease and then move and expand into the newly diagnosed patient population. We want to use local NGS testing to place patients into either of these different options. And so those options may include focusing on a particular target. They may be aberration agnostic. There may be opportunities to look at and get some early signal seeking for single agent, and then move those into, if those that have a positive signal, to look at those treatments against some patients being randomized to control, but with the opportunity for a crossover. So there's a lot of different ways we can utilize this infrastructure to ask a lot of questions that will support validation and an approval. So the initial part, you'll see the top part of the screen is really the initial build. So it'll provide, we hope, multiple options for targeted evaluations for both aberration agnostic and as well as ones that are more targeted in rare targets. In some cases, it will include a comparator arm, and if appropriate. And then over time, we'd like to continue to build and grow this infrastructure. So while this isn't part of the initial plan, we would like to look at potentially an exploratory, an infrastructure to identify even new targets, combinations, and bring them into the effort. So where are we in the process? So we are in the design phase. So we've been convening the design team. We're conducting these series of meetings where we continue to refine it. We would like over the next few weeks, months, to have some informal feedback from the regulators and continue to move that forward. And then our hope is if we feel like we've locked in on a design that is something that the community is comfortable with, then that's when the ramp up will really occur, where we'll start to work more collectively to get more formal feedback from the regulators, start to bring in our sites, and then our implementation effort. Sometimes these efforts can take just a couple of months and we can ramp up quite quickly, but I anticipate this is probably about a year from now where we'll start to see some real active work in terms of implementation and opening. So as I mentioned at the beginning, we are here to convene these efforts on behalf of the community, so your involvement is essential. We consider this an investigator, patient-centric effort, and so that success is dependent on the clinical, the academic, and the patient advocacy community to support this. So there's lots of ways to get involved, to join committees, to participate and bring forward new treatment options. And so if you're interested in being part of it, hopefully you stop by our table at the exhibit hall or you reach out to us over the coming weeks. But we'd love to talk to you about how you can work with us to make this the trial to support your community. Thank you.
Thank you very much. So there are a couple of more initiatives that we would like to share with you. The next one is the Citizen Initiative, and to have an update about the data from the cholangiocarcinoma cohort. So I'd like to call on the stage Amanda Notti, who is working at the INVITE, where she focuses on the data quality and insight generation for the clinical genomic data set.
Hello, everybody, and hello to those who are live streaming in as well. So today I'm just going to take a couple of minutes to walk through an overview of the registry platform, then get into the structure of the data that is collected from the medical records, tell a case study involving FGFR2 alterations and what we can learn from this real-world data set, and then get into future directions. So INVITE's citizen platform, which powers the CCF registry, ultimately the objective was to form a patient-centered platform that would enable patients to have all of their medical information in one place and provide to them a structured data set that they could control access and use of. And so the way that it works is an individual participant signs up with the platform and then provides consent for INVITE to leverage the HIPAA right of access to go out and obtain all of their medical records and bring them back into one place. And again, they have access to this. They can share it with whomever they wish. And then in parallel, all of these medical records, structured and unstructured, are processed through a machine learning-driven pipeline. First scans the text and then surfaces likely clinical variables of interest. This is followed by 2 rounds of human QA and confirmation to confirm the validity of these variables. And ultimately, all of these variables are standardized against an underlying terminology or coding system. So all the different ways that something can be referred to in the unstructured medical records gets normalized to a single term. And at the end of this process, we end up with a de-identified data set, which again, once the individual consents, can be used for de-identified research use. And so now I just want to get into the data model or the types of variables that we include. And so I like to think of them in 3 main categories. We have clinical characteristics, which also includes some high-level demographic information. We have comorbidities or medical conditions, and then all the clinical detail of the cholangiocarcinoma, so the diagnosis, the subtype, secondary diagnosis or sites of metastases, a lot of detail on biomarkers, details of the tumor location or locations, grading, staging, and so on. We also collect the information about interventions, so diagnostic procedures that were used to confirm the disease, therapeutic procedures like the surgeries or radiation, and medications. And then in terms of things that can tell us more about the outcomes, we have the tumor status as declared by the clinician, whether it is stable responding, progressing. We document new sites of disease, either a recurrence in a primary site or a new site of metastasis. And then looking also at tolerability, we collect the adverse events as well, along with performance status over time. And all of these data elements are collected not just with the name of what they are, but with the date or dates that they occurred or were observed. And so that enables us to pull everything together into a longitudinal data set for each individual. And so this helps us, ask and answer questions that can be about characterizing a diagnostic journey, or really anything that's looking at a time between certain events, like how long is it taking to get from one thing to another. We can look at the real-world utilization, so across a data set, what therapies are being used, what interventions are happening. We can calculate endpoints, things like time to progression, time to next treatment, and so on. And we can also look at tolerability, as mentioned. And this includes not just what adverse events are occurring, but whether they are resulting in a dose reduction, a hold, or a discontinuation of therapy. And so now I just want to show a visualization. So this is a single case. So once this data is extracted, organized, standardized, we see this comprehensive and longitudinal view of the patient's cancer journey. And this, as described, includes the clinical characteristics, the interventions, the outcomes. So looking at this view, starting at the upper left at the time of the initial diagnosis, you see all the information that's collected as part of the diagnostic workup in that box at the bottom. So the details of the diagnosis, staging, biomarkers, grading, and so on. And now if you look at sort of the middle part of this visual, you see the introduction of medication, so gemcitabine and cisplatin. And we see the start of it, and we see that it continues on with some adverse events associated with that. Later on in this timeline, you see the introduction of an additional treatment, durvalumab. And in the meantime, looking back up at the top here, we see these points in time where the clinician recorded a disease status. There was a partial response, then it was stable, stable, and then another partial response. And so you can imagine pulling all of these individual data sets and journeys into one data set enables for some really interesting explorations of real-world data. And so now I want to switch gears slightly and introduce the current or close to current cohort that we have within the registry. So this is a high-level demographics, breakdown by female, male. You see the year of birth, you see the distribution of year of diagnosis, the diagnosis and subtype information, and then I'll draw your attention to the bottom right-hand side where we have the number of individuals with select biomarkers that are of interest because they have matched targeted therapies. And now for the case study example, I'll go through a set of analyses looking specifically at the FGFR2 fusion-positive population in this data set. So one thing that we are interested in, and this is a part of a broader project that we're working on, was looking at once a targetable biomarker is identified, we also have medication information in the data set. So we can look and see for those individuals who had a targetable biomarker detected, did they also ultimately end up receiving a matched targeted therapy? And the breakdown that you see here is that for each of these mutations or sets of mutations, the ones in the purple reddish, we don't see documentation of a matched targeted therapy in their data. The blue purple one is where we do. And so you'll notice right away that the numbers are roughly equal. And in fact, across all of these, it's actually more, over 50%, where we don't see this matched targeted therapy in the data set. So of course, initially you see that and feel very concerned, but we're able to look into these data sets to try to get some broader context on what's going on. For example, when was the treatment decision made? Was it before the approval of these targeted therapies? And also looking within each individual's point in time. Are they early stage or are they just in first line of treatment? Because these targeted therapies are not approved until second line or later. And so again, focusing in on the FGFR2 population, sure enough, 12 of the 15 are still early in treatment or early in disease, so not yet eligible. So let's focus in on the ones who have received an FGFR2 therapy and look into that treatment landscape to see what is being used at what point in treatment. So this is a busy chart, but just to orient everyone. So here, each row that you see is an individual with advanced or metastatic cholangiocarcinoma. The first column is the diagnosis date, and these are ordered chronologically from further back in time to more recent. The second column includes the details of the fusion partner. So as I mentioned before, we collect a lot of information about biomarkers that are in the data. So we'll have the details of the fusion partner if it's reported in the documentation. Third column tells us when they were, at what stage they were diagnosed, and if they ultimately progressed later. So you can see, for example, the first individual diagnosed at advanced stage, which ultimately became metastatic, something like 900 days in. And then looking across the rest of this chart, first line, second line, third line, we're recording what treatments were given with a highlighting in blue of the FGFR2 targeted therapies. And so this type of analysis allows us to look into the data and see who is getting a certain type of therapy, what therapies are being chosen, and it also gets to questions of sequencing between different therapies. So the next example I want to show is looking at some of these endpoints. And within the data, we can look at this a couple of different ways. So what I have reported here is that for each set of completed FGFR2 treatment, we're recording the duration of therapy, so the time from the start of the medication to the end of the medication, the time to progression, which is in the red bar, time from the start of therapy to the first clinician documented progression, and the time to next treatment. And each of these boxes within the chart represents an individual. So you can see that, for example, the third one down actually had 3 FGFR2 therapies sequentially, and here is sort of their outcomes from each. And so the next thing that we'll layer in, although I don't have it here to report today, is looking at adverse events and considering where dose reductions, holds, and even discontinuations may have occurred. And with that, I just want to take a moment to talk about future directions for this registry data set. So of course, we will enthusiastically continue growing this US-based cohort. As of February, over 800 individuals consented and over 500 with records fully collected. We will be soon incorporating survivorship data, which will enable calculation of survival-based endpoints. We were also eagerly exploring international expansion, and finally continue collaborating with all of our partners. And so I just want to close with some quick acknowledgments. Of course, thanking the Cholangiocarcinoma Foundation and their network of clinician researchers who have helped design and launch and improve this registry. Thanking the Invitae Citizen team for all their efforts in obtaining this data. But most importantly, thanking the individuals who have joined the registry so that their data can contribute and accelerate research and learning in this space. Thank you.
Thank you, Amanda. The next presentation will be by Sherin Worrell, who is Area Vice President at Komodo Health, and she will give us an update on the cholangiocarcinoma cohort of the Komodo project.
Hi, everyone. It's a real pleasure to be here today and to provide some updates on the partnership that Komodo Health has with the Cholangiocarcinoma Foundation. So thank you for inviting us to be here. Before I start, I really would like to, again, thank the foundation and also thank my colleague, Dr. Melissa Agnello, who works incredibly closely with the entire team here at the foundation. We're going on about a 5-year partnership with the Cholangiocarcinoma Foundation, and just really looking forward to that ongoing work. Not entirely sure, let's see. All right, there we go. So I'll kick us off today by talking briefly about Komodo Health and our healthcare map. Komodo Health has been transforming healthcare since 2014, and the company is a mission-driven company. Our mission is to reduce the burden of disease, and we're doing this by building a data set that represents the most comprehensive view of the healthcare system today. The co-founders had been working in the healthcare data space and realized that the data has many barriers to use. So not standardized, it's really siloed, hard to access, and they realized that there needs to be a better way to get these data together so that they can be more useful for researchers and the healthcare system in general. So that was around 9 years ago. Today, we have over 130 healthcare partners and customers in the life sciences. We have more than 15 patient advocacy organizations who we work closely with, in addition to several academic research institutions. All of these folks are leveraging Komodo's healthcare map to drive programs and ultimately help patients. We refer to our data set as the healthcare map. It's Komodo's goal to create a single source of truth as it relates to what's going on the ground floor of healthcare on a national level. We do this by bringing together thousands of siloed data sources, and linking them together to create a single version of truth from all of that disparate data. So the main source of the data is based on medical claims, but the healthcare map is layered, allowing us to continue to add on different types of data to provide more depth to the longitudinal data that we have. So we're constantly building upon it. The data is patient level, and we're able to really see those longitudinal patient journeys. So each encounter that these patients have in the healthcare system, we're able to capture and link together. This provides incredible visibility into the odyssey that many patients are experiencing through the healthcare ecosystem, from diagnosis and treatment and beyond. We do all of this de-identified. All of the patient identifiable information is stripped before it arrives to Komodo Health. And just really over the years, we've built this extremely representative, census-level, comprehensive data set that's actionable, timely, and I think what also is really important is that it's always expanding. So it's not a stagnant data set, it's evolving and growing every day. So about our partnership with Cholangiocarcinoma Foundation, it began in 2018. They were our first nonprofit partner in the advocacy space, and they continue to be really incredible partners who are pushing the narrative forward. The partnership enables the foundation to have a nearly real-time and comprehensive picture of the patient landscape. Our goal is to ensure that our data are accessible and easy to leverage by the foundation's team, and also to work in partnership with them to answer some of their most pressing questions. So some of the initial projects that we worked on with the foundation are still up and running today. The team uses data-driven intelligence from the healthcare map to help patients find specialists and care networks that have the most experience treating cholangiocarcinoma patients. So this includes high-volume treaters who are involved in publications and trials in cholangiocarcinoma, and who also have a broad healthcare provider referral network. These HCPs, these physicians, are funneled into the foundation's specialist map that lives on their website, where patients can interact with that map to find providers quickly in their area. Cholangiocarcinoma Foundation is also using this technology to proactively spot gaps in care where physicians might not be meeting benchmark standards of care around biomarker testing for cholangiocarcinoma tumors.
The team also worked on a project to uncover the amount of time that typically elapses from first diagnosis to first biomarker test and how that might differ across community and academic centers. What was uncovered was that in the time frame from 2017 to 2020, there was 54 days was the median amount of time between first diagnosis and first biomarker test, and it was not statistically significant between the academic and the community centers. And finally, the data access really has helped the Foundation's team as they expand their network of researchers working to reduce the burden of cholangiocarcinoma and to find providers that are seeing newly diagnosed patients. This is really critical in helping patients be able to access the educational support offered by the organization at this vulnerable time of diagnosis. Oops, excuse me. So there are a lot of questions that the Foundation team has presented to Komodo Health over the past year, and I have them listed here on the slide. These are the types of questions that the Foundation knows to be important and questions that we have worked to address with the Foundation. So what proportion of cholangiocarcinoma patients have comorbid autoimmune disorders? What proportion of cholangiocarcinoma patients have a history of GI disorders such as IBD? How many patients are diagnosed with cancer of unknown primary origin before being diagnosed with cholangiocarcinoma? And how does patient race and ethnicity affect outcomes? So you can see for that third question, we ran an analysis that showed that 23% of patients diagnosed with cholangiocarcinoma from 2018 to 2022 did have a diagnosis of cancer of unknown primary in the 2 years prior. So as it relates to the first question, CCF came to us inquiring about autoimmune disorders to assess if and how exclusion criteria may affect cholangiocarcinoma patients living with these disorders who are looking for clinical trials. Exclusion criteria for novel therapies might exclude patients with autoimmune disorders, so the Foundation wanted to have a good understanding of how many patients could potentially be affected. We ran a high-level analysis of all cholangiocarcinoma patients over a 5-year time frame to uncover the number of patients with autoimmune disorders. We saw around 16.3% had inflammatory bowel disease, around 3% ulcerative colitis, 1.5% Crohn's, and 2.5% primary sclerosing cholangitis. And the percent of cholangiocarcinoma patients with any autoimmune disorder, which included things like IBD, PSC, alopecia, fibromyalgia, and others, was around 34%. So how does race and ethnicity affect outcomes? This is another question that we've been exploring with the Foundation. Race and ethnicity is a valuable patient characteristic, really, for identifying and addressing healthcare disparities. Similar to the way we trace patients' journeys through the lens of medical and pharmacy claims history, the patient's racial and ethnic background provides additional rich contextualization that allows for a deeper appreciation for factors that might contribute to disease. So to better address healthcare disparities, we at Komodo Health have integrated race and ethnicity insights into our healthcare map. And for the Foundation, this is providing important information to help guide programs to create a more equitable healthcare experience and outcomes for patients of color. We are working with the team to identify pockets of the country that have higher percentages of patients of color and to begin to work toward health equity, again, through programs, clinical trials, and other initiatives. And the slide here, we have a 2-year time period listed, so between January 2021 to December 2022, and the distribution of race and ethnicity in those 2 cohorts. So Komodo's partnership with Cholangiocarcinoma Foundation really continues to grow with an aggressive approach that's needed to tackle this disease. In addition to maintaining the current projects and workflows embedded into the foundation, we look forward to the opportunity to explore and find answers to the foundation's most pressing questions. Now, this includes further investigation of autoimmune disorders and cholangiocarcinoma, perhaps rerunning biomarker analysis to see how things have changed from that previous cohort, that previous analysis to today. The second bullet here on the slide really is a foundational step that we need to take. We do need a clearer understanding of the burden of disease of cholangiocarcinoma, really to effectively address the problem. You can't change something if you can't measure it or if you don't have a baseline. So one project we may be exploring is an analysis of newly diagnosed patients, including patient demographics and their risk factors over a yearly time period. And then utilizing Komodo's solutions and data to continue to support healthcare provider education efforts and outreach. Again, really to ensure patients are getting connected to the Cholangiocarcinoma Foundation for support, and that healthcare providers can find updates on the latest research in the field. So while we've been working with the foundation for several years, we are continuing to uncover new opportunities to help patients and foresee a really exciting year ahead. So in conclusion, I want to thank the entire Komodo team who has worked on any project with the Cholangiocarcinoma Foundation. And again, Dr. Agnello, who is really close with the foundation and their projects. And of course, would love to thank our partners at the Cholangiocarcinoma Foundation, Stacy, for your partnership, for everyone's dedication and passion for this work. It's been a pleasure to be working with you, and we look forward to continuing the partnership. Thank you.
Okay, so here we go. Can we have the lights on, please? So we have now come to the conclusion of the 10th Cholangiocarcinoma Foundation Conference. It's been 3 amazing days, and I hope you concur with me that has been really exciting to be here and share the data all together. I hope you have learned, you have connected, and that you have received hope. I know and I acknowledge these have been 3 very full days, but I see that as a positive sign, as a message that we have been able to attract many more people working in the cholangiocarcinoma area. It was nice and really exciting to see how many young investigators have come to the podium and share their data, and that is a big brick to build, more infrastructures in the future. I want to take just a few minutes to say some thanks, and the first one goes to my co-chair, who unfortunately had to leave. It was really fun to work with her, and I'm sure that I talk on her behalf when I want to thank Stacy, first of all, for inviting us to chair this conference. It has been fun. It has been really a good learning curve for me as well, and a good learning opportunities. And above all, I think that has been amazing to feel like being part of a family. And this is what you are amazing at, Stacey, to really, and I think this is what makes up still being here in a Friday afternoon. You really make us feel like all part of the same family. And like if we can make things and we can go and achieve our goals, and that really is a big, big thanks from me. And I think from every one of us. Thank you to all the CCF staff. You've been amazing, and special mentioning to Christine and Ali. You have accompanied me and Laura over the last year, and thanks for all the work you have done. Thanks to techs who have been helpful in making these 3 days really smooth. The abstract review committee, which has taken some of the workload off of our hands. And then I want to thank all the donors in the room and the sponsors, without which we wouldn't have been here and we wouldn't have been able to share all the data that we have heard about. the speakers and the moderators who really elegantly convey the message and the update of how much is going on in the cholangiocarcinoma field. And above all the patients and caregivers who continue to be at the base and the inspiration of all the research that we have talked about. So thank you very much, everyone. Thank you for everyone who stayed here. And I wish everyone a safe journey home. And hopefully we will all meet next year.
You're welcome for me giving you a lot of work this year. Being a chair is a lot of work, and thank you so much to Dr. Goff and Dr. Ricconi. And thank you to all of the CCF staff who we've worked an entire year to put this conference together. Thank you to all the presenters. Thank you to our sponsors. Thank you so much, and thank you to all of you who are here. This has been, every single day has been great. This has been an amazing day as well. I loved hearing from Lori Robertson and Dr. Sahai. I hope that was just a highlight for me to hear their story and to be so open and vulnerable about that patient-physician relationship. That's really important, and there's a lot to learn from that interaction that you watched. A new platform trial, very exciting, emerging science, a lot of data, a new CMO, so many exciting things happening here, all of which get us closer to better treatments for patients. So much hope and so much support. I wanted to remind you that all of the presentations will be available online. I also wanted to just draw your attention to the slide. Well, you can hardly miss it, but a little over $27,000 was raised at the Giving Tree. Thank you to the Peoples and Bill Sessions for doing that. If anyone wants to close the gap to get it to 30, feel free. Thank you so much. Thank you so much. We completed all 2,500 care kits, and 145 patients were added to the GWAS study. Thank you so much. Thank you for participating. Thank you again for joining us. We hope to see you next year, and safe travels.